intersecting with the seasoned wisdom of our masterminds, our judges. The stage is set, the minds are primed, and the pursuit of excellence will begin now. Without further ado, let's move into the session proper. We now begin with our first scientific session of the day, the undergraduate oral presentations. I would like to welcome our moderators, Dr. Sonit Sai and Dr. Ashish Rahman, to the dais. May I now invite our masterminds, the honorable judges, Professor Gunashekaran sir from Pediatrics, Professor Venkatachalam sir from PSM Department, Professor Srirekha ma'am from the Department of Pathology, Professor Subhashini ma'am from Department of Ophthalmology, and Professor Ilamurugan sir from the Department of Surgery. Over to the moderators.
Good morning, everyone. Welcome to the UG Oral Presentation as part of the 11th annual conference. So today we have 9 presentations covering a fascinating range of topics from observation studies to advanced teaching. Firstly, thank you so much for being I'll hand over the mic to Sonit for the room.
Before we begin, let's just set up a few ground rules. So the total time allotted for the presentation is 30 minutes, followed by 3 minutes for Q&A session. You will, presenters, you will receive time signals at 4 minutes and 6 minutes. There will be a bell, and also at the 7-minute mark, which is a hard cutoff. Anyone in the audience, including the judges, of course, can ask questions. Our responses to all questions may be considered in this voting. Please answer them accordingly. Without further ado, let's get started.
I request presenter 1, so please on the issue. Number 1. So just to give context and info. So absence of reverse index also on HPL local, essentially a sign that the placenta is failing to develop adequate level. The worry has always been that the start of these disease is already compromised. So the default has been to hold these, sometimes give days. So the author there asked, is that caution actually necessary? So we can start with the presentation from you.
Good morning, everyone. I'm Ravi, and I'm trusting of safety of minimal enteral nutrition in preterm babies with antenatal doctor abnormalities. And this study addresses a long-standing debate on neonatal nutrition. And let's see the high-risk cohort of our study. The antenatal umbilical artery doctor is an indicator of placental perfusion. In SGN units, we often encounter the absent and or reverse end-diastolic flow. Like this is an absent flow, and here a reverse end-diastolic flow. These patterns indicates placental hyperperfusion and poor, in utero hypoxia, which necessitates early termination of pregnancy. And after delivery, also these babies are at risk of developing morbid complications like necrotizing enterocolitis and sepsis. So this made the clinician hesitant to initiate the feeds, and so it leads to prolonged fasting. But this parenteral nutrition and prolonged fasting has its own risk, like gut atrophy and parenteral nutrition associated infections and cholestasis. So we initiated feeds immediately from the birth. So this study evaluates the shift. We performed a retrospective cohort study in JIPMER NICU, and here we compared SGN units, small for gestational age neonates, less than or equal to 34 weeks with ARDF to normal Doppler and SCA babies with normal Dopplers. And we compared for outcomes like feeding intolerance, NEC, sepsis, and death. And this is the pie chart framework of our study. The population is preterm SGA units less than or equal to 34 weeks with AREDF. The observation is early minimal enteral nutrition initiated immediately from birth. The comparison group is SGN units less than or equal to 34 weeks with normal Dopplers. The primary outcome is incidence of feeding intolerance. Secondary outcome is composite of necrotizing enterocolitis, sepsis, and death. The time we followed each baby is from the birth until the achievement of full feeds. And this is the unit feeding protocol for AR India. The initial feed is increased for higher gestational age. And on looking at the baseline characteristics, the AREDF group represent a higher risk cohort. Like they had a lower mean birth weight and higher rates of cesarean section and greater need for respiratory support and increased incidence of fetal distress and hypoglycemia. On looking at the primary outcomes, the AREDF group had a slightly higher risk of feeding intolerance, but the apparent difference is statistically insignificant as the p-value is greater than 0.05. And similarly, the rates of necrotizing enterocolitis, sepsis, and neonatal death is also similar among both the groups. There is no difference in both the groups. And time to full feeds, the both groups achieved full feeds in a similar time frame as shown in this Kaplan layer estimates. The apparent difference is again insignificant as the values at the p-value is greater than 0.05. On performing multivariable analysis to see what was actually driving these poor outcomes, we surprisingly we found the gestational age was the significant predictor of outcomes, not the Doppler status. For every additional week of gestation, the composite outcome reduced by 38%. So this suggests that gestational maturity is far more important than the Doppler status when it comes to feeding safety. Our results align with major trials like ADAPT and recent trials like Katuria et al. But our protocol is even more proactive, initiated feed from the birth, while others initiated from 6 to 48 hours. The strengths, we used the SGA only cohort control group, so we could isolate the effect of AREDF. And the limitations, as it's a retrospective design, there's a potential for a documentation bias. The sample size may be underpowered for rare outcomes like NEC. In conclusion, early minimal enteral nutrition from birth is safe and well tolerated in select preterm neonates with AREDF greater than or equal to 32 weeks of gestation. So, by shifting our focus from Doppler status to gestational maturity, we could offer the benefits of early enteral feedings to this vulnerable infants without increasing any morbidity and mortality. Thank you.
Thank you for your presentation, Amit. Thanks for sharing your here today. So we go on to the Q&A session, but before that, how the question will be asked is, I want everybody to raise their hands, whoever has the question, and then the volunteer here will come up to you, and you will answer, and then you can answer. Okay? And we also kindly request you to please put your phones on silent. So let's start with the Q&A session. Good presentation, and the topic is also of much relevance in day-to-day practice. Are there any studies, are there any studies which compared early minimal enteral feeding and delayed feeding, and what were the outcomes in those studies?
There were some randomized control trials which showed that there is no statistical significant difference in the morbidity. So it's safer to start enteral feeding, early enteral feeding.
No, those studies also say there is no difference between early and delayed. But then what are you trying to do in the study?
In the study, we initiated the feeds from birth, but they initiated from 6 hours of birth. So this is the novelty now.
And how the feed intolerance was assessed in this study?
Abdominal distension, vomiting, and gastric residues in the area.
You said it is a retrospective study, no? How many of the children where the quality of the data collection was not appropriate, and then you have deleted them from the inclusion into the study?
Those spikes with the incomplete data are not taken for the study, sir. Only for
how many were incomplete in both the sides, both arms? So
Thank you.
And very very good presentation. So just I think somewhere there is a flaw because the methodology in the methodology you have put it as whether your research question was whether early entry feed would affect. So then your comparison group should be early versus the delayed or the fasting group. But your comparison group was non AR. So that's where you should be changing the research question and between these two groups which had better outcome.
Yes, ma'am. Initially, we thought to compare the early feeding versus late feeding, but the late feeding data was before 2019 in JIPMER, the protocol. But because of technological advance,
Yeah,
we
better
cannot
research question should be written in a different way. Very good.
Thank you.
After very good morning, very good presentation. Go back to the survival analysis curve. So other ratio is actually 0.83. Explain that.
That means 0.83 times the
Is that okay? You don't know.
It means the normal doctor group attained the early fix, attained the full fix prior to 0.8 times prior to the ARADF group. So like if ARADF needs 100 minutes to attain the full fix, the normal group required 83 minutes to acquire the full fix.
Okay, it's not appropriate. Okay, other way around, it is actually 13 percentage. Okay, it's 83, not 17 percentage, has better outcome in intervention compared to control, but you don't have the power to prove your hypothesis. Basically, you have what is the sample size?
82 ARADF and normal.
It's required some more calculate power of the the study with the adequate sample size. Please keep in mind. I think you should not leave it to this. Maybe you can do prospective study. Because all the limitation with larger sample size, you can prove that it may be effective because coming almost 17 percentage. 83, no, it's 0.83. To subtract 100. That is actually the one is protected. Hazard ratio less than 1, what was coming is protected for the intervention. Okay, thank you. Thank you. Let's move on to the topic presentation. We're about to the outcome of the project. When we think of Parkinson's, we immediately think of tremors. But the disease often starts long before the tremor manifests. Olfactory dysfunction and autonomic dysfunction may appear years before motor symptoms. How do we reliably identify this in our population? They can't really regulate that. That's what the author right.
Good morning, everyone. I'm Rajeshwari, and my project today is development and validation of a scoring system to predict 30-day mortality in patients undergoing emergency laparotomy. Emergency laparotomy is an important procedure which is done to manage acute abdominal condition, but it is associated with a high mortality of about 15 to 30%. Hence, preoperative risk optimization of patients is important. But existing scoring systems are not specific to laparotomy, or they're too complex, or they utilize intraoperative parameters, making them not suitable. Objective. Our study aimed to identify preoperative parameters associated with 30-day mortality among emergency laparotomy patients, to develop a scoring system using these predictors to predict the risk of mortality, and to assess the performance of the scoring system through internal validation using cross-validation techniques. Methodology was a retrospective cohort study, and the study population was formed by adult patients who underwent emergency laparotomies in the Department of Surgery. A total of 402 patients were included in the study. Data collected included demographics, clinical parameters, laboratory reports, and radiological findings. The outcome study was 30-day post-operative mortality due to any cause and was determined through discharge summaries and case records. Statistical analysis. First, univariate analysis was done to identify the predictors of mortality, followed by multivariable logistic regression to identify the independent predictors. Based on the beta coefficient of the independent predictor, an integer weight was assigned and a scoring system was developed. The scoring system was validated using tenfold cross-validation. The performance of the scoring system and the diagnostic accuracy of the scoring system was tested. So these were the preoperative parameters which we had studied, and there was a mortality rate of 23.13% in our patient. So the data set, which had 402 participants, was divided into a training data set and a testing data set. Elastic net logistic regression was developed from the training data using LASO and ridge regression. To determine the penalty, tenfold cross validation was done in such a way to minimize deviance. At this optimal penalty, only 12 predictors were retained in the model. The model's performance was assessed using goodness of fit command. There was found to be a mild decrease in the deviance ratio from the training data to testing data, indicating that the model was worked well on unseen data, but there was modest optimism. Calibration of the scoring system was assessed. You can see the central diagonal line is called the bisector line. This indicates perfect calibration where all the expected probabilities are exactly equal to the observed outcomes. But the belt around it suggests that there was significant deviation from perfect calibration, meaning there was underestimation and overestimation of mortality risk across the strata. The discriminative ability of the scoring system was assessed. Discrimination is the ability of the scoring system to differentiate survivors from non-survivors. The cross-validated area under the curve was found to be 0.785, indicating good discrimination and minimal overfitting. Bootstrap-based ROC regression was also done and had an area under the curve value of 0.7895. The close concordance between the cross-validated area under the curve and bootstrap area under the curve confirmed the model's consistency and stability in distinguishing between patients with the outcome and without the outcome. Overall, the model demonstrated a statistically significant overall fit, indicating that the 12 predictors together could predict mortality much better when compared to a null model. The pseudo R-square value was found to be 0.1991, indicating that the final logistic model could explain 19% of the variation in the mortality risk. The remaining 80% could be explained by other factors like post-operative factors, intraoperative factors, and ICU care. Overall, the model had moderate predictive power. A nomogram was built using a model for EV bedside application. For example, if a patient had come to you and they had a serum creatinine of 1.2, of more than 1.2, then we would code it as 2, and we would find the associated score, which would be 6.5. Similarly, suppose they were anemic, then we would also code that as 2, and then we would find the associated score, which is 3. Similarly, for all 12 predictors, we would have to find the score, and the total score would be found, and the probability can be determined. Discussion. So our study had an overall mortality of 23.13%, which is within the global range. And the parameters which we have included in our study, like ASA score, preoperative sepsis, preoperative blood transfusion, laboratory parameters, and delay in surgery, have been identified as important predictors of mortality in other cohorts as well. The area under the curve values which we have obtained in our study are similar to other models, confirming the comparative discriminative performance of our model. The calibration belt showed significant deviation from calibration, but this is found to be common in periodized regression models and has been reported in other discriminative tools like P-Console. The pseudo R-square which we got was 0.1991, and this was also seen in other clinical, this is, and a value between 0.15 to 0.25 is considered acceptable in clinical models. Some modern models like the HAS model include physiological vulnerability markers like sterility, but we did not include that because we focused only on routinely available preoperative variables. The limitations of our study was that it was a single-center retrospective study. There was moderate sample size, there was lack of external validation, and there could have been possible unmeasured confounders. In conclusion, a preoperative risk prediction model for 30-day mortality after emergency laparotomy was developed using routinely available clinical parameters. The model showed good discrimination and stable performance. The nomogram, which was developed, could be used as a simple bedside tool for perioperative decision making. And external validation in larger multi-center cohorts is required before widespread clinical implementation. Thank you.
Thank you. Let's move on.
Yeah, very good technical study, visually. But as a listener, what is the existing models and how is your model different from what is existing source?
Yes, sir. Other models exist, like one of them is deep but that uses intraoperative parameters as well. Whereas our model is focusing only on preoperative parameters.
There are no preoperative models for like if they preoperative shock. There are no models that.
Yes.
How is your scoring system different from that? Did you find anything extra which is not there in previous models which will be useful now?
Like,
So why the whole exercise now? Create a new scoring model when there is already some preoperative scoring models. Did you find anything new, some parameter new which is not there in older one? Or how do you say that your study is unique from previous studies using preoperative parameters?
we used like there was our study used very routinely available parameters, right? And we also like developed into a nomogram, so there would be like easy clinical applicability.
You said you'll be assessing both mortality and morbidity, but there is no discussion about
Only mortality.
no morbidity.
Yes. These were all of the parameters which we had studied done, but on doing that elastic net logistic regression, only 12 predictors were retained. So these are the 12 predictors which we are replacing now.
Yeah. You have observed the preoperative model, but then one of the 12 parameters follow-up searching.
Yes, like ma'am, suppose in during that particular admission period only, if they had undergone a follow-up surgery, for that follow-up surgery, it will be like that, like suppose like they
Preoperative. So after
no, for the second surgery, we can say that they're at increased risk because they had already undergone an emergency laparotomy in that particular admission.
the previous surgery.
Yes.
Okay, very good presentation. So, what is the gold standard? You mentioned ROC. What's the gold standard?
Generally, any value between 0.7 to 0.8 is considered good for clinical prediction models.
It's model and comparing, no? Usually we need to compare the model with the gold standard cutoff. Prove how you actually derive, this will be able to predict exactly as better than the existing model.
So like other established models also showed like similar ROCs of around 0.75 to 0.8.
Okay, so you have not made a model. Have you validated the model?
So we only did internal validation, we did not do it.
What are the validation steps you have done?
So we used tenfold cross validation, sir. We used tenfold cross validation. The model was divided into 10 data sets, and it was trained on 9 data sets and tested on the remaining one, and this was repeated 10 times till all of the folds were assessed.
Have you excluded after doing the model that some variables are not important, some variables included, something you have to do any modification?
No, sir, we did not modify after doing the.
No, even while running analysis, some of the variables have Run for alpha. You're not done, okay, you content validity. Okay, thank you. Thank you.
Thank you so much. Thank you. We also encourage the audience, the UG students, to raise questions with you. So we move on to the next presentation. Apologies for the mix-up of Amit. This presentation is on Parkinson, and we'll delve into the olfactory dysfunction or autonomic dysfunction and assess if it can appear years before it goes to board. On put on your hands again, so one will come over and give us something. Your viewing session.
Good morning, everyone. I'm Shakti Priyadarshini. A study is titled Association between Olfactory Dysfunction and Autonomic Dysfunction in Parkinson's Disease using the Indian Smell Identification Test and the olfactory dysfunction impact on daily life. Parkinson's disease is a progressive neurodegenerative disorder which involves both motor and non-motor symptoms. Olfactory dysfunction affects 64% of the PD patient, and it can occur even before the motor symptoms. The primary objective was to study the association between the olfactory dysfunction and autonomic dysfunction in PD patients. The secondary objective was to assess the impact of olfactory dysfunction on the daily life of patients. We used a cross-sectional analytical study in the AFT lab in neurology department over a period of 3 months, and a sample size of 30 was calculated using expecting a 0.5 correlation between INSIT and scope autonomic scores. Using a convenient sampling, patients of more than 30 years meeting MDS diagnostic criteria were included, and patients with atypical or drug-induced PD, dementia, major psychiatric illness, and chronic renal failure, thyroid disorder, recent nasal surgery were excluded. We recruited a 30 patient meeting with inclusion and exclusion criteria. After obtaining informed consent, the patient underwent Indian Smell Identification Test. After followed by English Olfactory Disorder Questionnaire, and scope autonomic score was evaluated and AFT was done. We expected a correlation of 0.5 with 5% significance and 80% power. We used a Spearman correlation to assess the relationship between INSIT and scope autonomic score. Linear regression analysis was performed. The baseline characteristic in the study population of 63% were male and 37% were female with a mean age of 55.6 years, and the mean disease duration were 3 years. In the population, 30% had diabetes and 20% had hypertension, with a mean INSIT score of 2.8 plus or minus 0.8 and a mean scope autonomic score of 18.9 plus or minus 11.1, and mean English olfactory disorder questionnaire had 38.6 plus or minus 15.9. This shows the overall result between olfactory and autonomic dysfunction, where INSIT score, scope autonomic, and English olfactory disorder questionnaire were compared. To further understand whether these two correlated, we performed a correlation between INSIT score and autonomic measures. In this, INSIT with various autonomic parameters were correlated, where RMSST, deep breathing RSA value fall in the diastolic blood pressure, maximum rise in diastolic blood pressure during hand grip, and Valsalva ratio, scope autonomic score, and English olfactory disorder questionnaire were evaluated, but none of them showed a statistically significant correlation of INSIT. During linear regression analysis, to understand whether INSIT score and scope autonomic score were related, we performed a linear regression analysis. The R-square value was found to be 0.019, which shows that it is a minimal predictive relationship between INSIT and scope autonomic score. And this graph plot is showing that there is no linear pattern between INSIT score and scope autonomic score. So this shows us that it predicts only minimal relationship between the olfactory dysfunction and autonomic dysfunction. So in our study, we aim to study the relationship and correlation between the olfactory and autonomic dysfunction. But observing the overall result, we found that there is no statistically significant association between the olfactory and autonomic dysfunction. Possible reason could be that in the population, everyone had an early disease stage, that is minimum duration of only 3 years, which shows that olfactory and autonomic dysfunction occurs at the different pathological timeline and neurochemical pathways. And phenotypic heterogeneity was also involved, and because maybe a cross-sectional analytical study used, maybe it could also be the possible reason there. To conclude, olfactory dysfunction did not correlate with the autonomic dysfunction in the PD patients, and olfactory dysfunction had minimal impact on patients' life, And larger longitudinal studies may help further evaluate and understand the relationship between olfactory and autonomic dysfunction. Thank you.
Thank you. Let's open the floor to questions.
My presentation, whether the severity of the Parkinson's disease was taken into account in this study.
So, like,
Because somebody would have been diagnosed just 1 year before, somebody would have been diagnosed 20 years before. Somebody would be having mild disease, somebody would be having a severe disease. Now, whether the population was homogeneous enough to arrive at this conclusion?
no, sir, actually, most of the patients are in the early stage only, sir.
Okay, then it would have not evolved in sorts of possibility.
Yes, sir.
And whether any of the drugs that are being used as a treatment for Parkinson's could interfere with this autonomic dysfunction.
I evaluated before I stopped the medication, sir, during the evaluation time. He told to stop the medication during the evaluation time. After the patients took.
No, I don't get it.
During evaluation on a particular day, we stopped the medication, sir.
No, 1 day you stop.
Right.
So,
No, Shakti. Nice presentation, and nice one. Information. Actually, I just want, because the sample size is small, maybe probably because of that, you do not find any association. What type of error?
That could be a possibility. Since correlation, I'll keep
Type two
discussing.
error, no? Like because sample size are not achieved. And moreover, all of them, as you said, in your limitations, they were all in early disease stage. Thank you.
No questions from the audience? Please feel free to ask any questions.
See, what is the scientific rationale for the possible reasons? Here are the possible reasons for not getting a significant relationship between olfactory versus autonomic function. You throw 3 points, right? What is the scientific basis of that reasons? In a clinical investigation for that? So if you are getting it, if you are not getting it, it may be true, right? Whatever the reasons, that is from your personal belief, right? Right. So these are the possible reasons. This can discuss it, but thing is that we cannot say this is the reason, possible reasons, no. Some scientific rationale should be there, scientific basis or biological justification should be there. That's one thing. Second one, see, if you are not getting a relationship between these two, how you are recommending for a longitudinal study in future to get it established. So it's a linear relationship, right? So the best method for establishing a linear relationship is the cross-section itself. Okay. So this is for your understanding. Okay, when you are just giving something, no, at least you should know. So what is the reason? What is the justification for this particular the comments? Okay, that should be very careful.
Thank you. Let's move on to the next presentation. Informed consent is one of the cornerstones of ethical care. Yet only a third of patients understand why the procedure that they just consented to is being done. The authors use additional animated video to facilitate better understanding and evaluation.
Good morning, everybody. I'm Sanjay Prakash. The title of my project is Impact of Animated Explanations on Patient Understanding and Decision Making for Percutaneous Coronary Intervention, a randomized control trial. We all know that informed consent is very important because that's where the patient understands the procedure that is being done to them, and then they will agree or disagree to the procedure. But most of the time, patients are rushed through the consent, so their understanding is a bit less than the information given to them. So we try incorporating an animated video into the consent so that we can check on compare the understanding and the level of satisfaction that they have received between the standard protocol of consent and also with the animated video. And our primary objective is to check on the feasibility of integrating the animated video into the informed consent. And our secondary objective is to see whether the understanding and the satisfaction of the patient increased on giving the intervention. The study design was a single center parallel group randomized control trial. participants, we divided the participants into two groups. The first group received only the standard consent protocol, and the second group received the standard consent protocol and also a video which is being made by our department, which explains about the procedure. The sample size came out around 40 participants per group. That is total 80 participants. This is the diagram which shows the inclusion and exclusion criteria. The participants were the patients who were admitted for the elective PCA procedures, and the participants were above 18 years of age, and they should be able to give a written consent. And the patients who are admitted for the emergency procedures, the patients who experienced the PCA procedures before were excluded. And we did block randomization of the participants, and allocation was made sure that both the groups received equal number of patients. That is 1:1 ratio. And yeah, as I said, we did block randomization and allocation concealment was done. Consent process was taken by the consent like SR department SR, and to prevent contamination, we took the consent process in a isolated place for every participant, and we did double blinding. That is blinding of the principal investigator, in this case me, who assessed the patient whether their understanding has increased or the satisfaction has increased, and also the data analyzer, in this case my guide, were blinded. And the tools we used were three. First tool, it's a questionnaire. This is a questionnaire. The questionnaire was already validated in a previous study which is done in JIPMER. And the questionnaire contains indication, purpose, procedural steps, risk, benefits, and alternate treatments. The next thing is patient satisfaction was assessed by a 10-point visual analog scale. We know that visual analog scale is the easier way to assess the satisfaction. And the most important tool in our study is the animated video. This animated video explains about the procedure, the indication, steps, risk, benefits, and alternative treatments. This animated video was made by integrating the live footage from our department, from the cardiology department cath lab, and also the 3D animations which were publicly sourced. And it is validated by the departmental committee, which contains 5 senior cardiologists and 4 senior cath lab nurses and 4 cardiology technicians. And this is the questionnaire, and this is the pass score. Baseline characteristics, we could see that the baseline characteristic was similar. There is a similar age distribution, and the gender ratio was also similar in the groups, which shows proper randomization. And results, we could see that the first two questions, the the indication and the purpose of the procedure, were known to both the groups. That is the basic understanding. When it comes to critical questions like alternative treatment, risks, benefits, there comes the understanding of the control group, the case group, that is the people who have received the intervention, had more understanding. We could see that in the graph, and it has significant value. You can see the P value. And when it comes to the satisfaction score, we assume that there will be a 10% point difference, that is 1 point difference. But we could see that the more than 10% point difference in the VAS score, satisfaction score. And primary endpoint, we could convincingly demonstrate that the feasibility of integrating the animated video into the consent procedure. And we can see the better understanding in the case group, that is the people who have received the intervention in more critical questions, like in question 3 to 6. The secondary endpoint was, we could see better satisfaction score. It shows like the clarity in their procedure. Limitations, it was a small sample size, and it was a short, because we could only see the short-term impact of the procedure. And strengths, it was one of the very few studies in this topic in Indian population, and it can be applied to other specialties also. Conclusion, this could be a very important strategy to mitigate the gap between the understanding of the patient and the information given to the patient. And the most important point here is there was no association of the understanding and the satisfaction score with the education and socioeconomic status, which means like everybody in the population, irrespective of the education and socioeconomic status, was benefited from the animated video, which has been shown to them. And that's what it has a potential. As I already said, it has a potential to be applied to other specialties also.
These are the references. Thank you.
Great. Very good presentation. They required a period of the study, period of our. So, but you said actually that the level blending was there. Actually, you are seeing the video. How it can be level blend, who are the blended?
So video, like, I'm the investigator, sir. Like, how the procedure happened is, first the patient will receive the consent process. Like, group 1 will receive only the standard consent process.
Patient is aware about the intervention. They know that.
Yes, sir.
Who are blinded actually?
The data analyzer and the principal investigator, in this case me, who was assessing with the questionnaire.
Actually, single blinded.
Double, if they mentioned double blind actually somewhere in
The
the.
patient also is blinded, then we follow that. I think Dr. Hari can.
Because you are assessing the questionnaire. What is the role of interpreter?
No, sir, I'm just asking them.
You're asking them marking. What is the other person doing?
Just analyzing the data from this.
Both are same. You're collecting the data, somebody is analyzing. Both are.
Call it single blind.
Okay, single blind, okay.
There's no question of patient being blinded. No,
Okay.
Okay, thanks for, clarity. The second one is, this is when you are getting informed consent,
Before the procedure being
1 or 2 days before or immediately surgery.
1 or 2 days before, sir. It's an elective BC.
Okay, nowadays the smartphones available, everything available in the net. Even this, whatever you have made the procedure, it's also available. They might have seen all these things, how you prevented contamination, how you adjusted.
Not everybody would have seen, no, sir. Like, we tried our best to prevent contamination. This is the best we could do. We can't.
And the outcome you measured continuous Richter scale. It's not actually, you cannot say it's number continuous. It's not space like a scale. Okay. But you measure, you analyze as a continuous variable. Yes. Which statistics you apply? What statistics you apply?
This is a continuous data. But satisfaction scores are continuous data.
On time, it's a continuous procedure. Like a scale, maybe you understand it later. Okay. So what statistics you use here?
For
Test or what test? Community test or battery test?
Sir?
What strategies you applied here? Two independent group, no?
Yes.
Okay, so better you put, okay, so where that what test you apply? Mostly you have so many tests you could apply here in different group. Okay, thank you.
Very well presented and the way you said that our department, and so, but then I sometimes wonder if there is a need for the randomized trial, and naturally if you show to the patient, there's a better understanding, compared to just a little concern. Okay, what was said in that? Okay. You have presented well and it's satisfying.
Whether the same person is involved in both types of interventions. Because counseling depends upon the person who is counseling.
Yes.
Whether the same person was involved in counseling on both sides.
Yes, sir. Same.
Both for the interventions. The question was only available in English. It was not given in.
It was given in Tamil also, sir. Yeah.
Okay, and you said 13 of them of the 40 were the preschooling or something other. So in that way, animation or a video would have been better for their understanding. So that would have reflected in this results.
The title of the topic only is the impact of animated video.
If you should have chosen more educated people, then probably the results would have been ambiguous.
Oh, thank you, sir. So sorry to talk about.
The population is it's okay.
So sorry to cut you off, sir. Let's move to the next presenter, the next slide. So, literal context. By 2050, antimicrobial resistance is projected to cause 10 million deaths annually worldwide. Carbon are often our last line, and the authors of this study set out to map the pattern from pseudomonas cultured from human cells.
Good morning, everyone. Myself, Perakala Kadambari. The title of my project is The Study of Antimicrobial Susceptibilities and Biofilm Formation among Carbapinamaceous producing Pseudomonas aeruginosa, which are isolated from urinary tract infections. And coming to the introduction, the multi-drug resistant Pseudomonas aeruginosa accounts for the 12% of nosocomial urinary tract infections, and with carbapenem resistant strains being associated with higher mortality, which is about 18 to 61%. And carbapenems have been the last line treatment used in the MDR strains. And the development of resistance is due to many mechanisms like carbapenems production, enhanced efflux pumps, and loss of outer membrane porins. And carbapenems has become the major concern, which is involved with high mortality rates. And biofilm formation enhances the persistence and shielding the bacteria. It will prevent the action of antibiotics and evades the immune system, leading to recurrent infections. And my study is based on these aspects. And the main objectives, the antimicrobial susceptibility of carbapenem resistant Pseudomonas aeruginosa, study related to antimicrobial susceptibility, and to profile the carbapenems producing carbapenem resistant Pseudomonas aeruginosa isolated from UTIs by using both the phenotypic and genotypic methods, and to characterize the biofilm formation among carbapenems producing and non-producing isolates. And methodology, it is a cross-sectional analytical study, and all CRPA strains isolated from microbiology department are included in this, and there is no exclusion criteria. And the sampling was convenient sampling. And in this study procedure, the CRPA strains were collected from the urine section in microbiology department, and AST profiles are done on this with the battery of antibiotics, which are ceftazidime, amikacin, gentamicin, ciprofloxacin, cefoperazone, piperacillin, tazobactam, meropenem, and imipenem. And further, carbapenems detection was done by both phenotypic and genotypic method. Phenotypic method followed was carba-NP test, and genotypic DNA extraction and multiplex PCR was done for encoding gene detection, and biofilm assay was done. And the reference strain used was Pseudomonas aeruginosa 27853. And the methodology, the data sources were HS, JIPMER, and the results from carba-NP and multiplex PCR. And the data collection includes the patient demographic details, AST profiles, carba-NP, biofilm, and PCR results. And the information was entered in Excel. The data analysis, the overall distribution of AST profile, gene positivity, and biofilm formation was presented with frequencies and percentages. And the multiplex PCR results are compared with the carba-NP test. And here the carba-NP test is considered as the gold standard to determine the sensitivity and specificity. The statistical software used is SPSS version 20. And the results which we found are the total isolates which we could get was 46, and among which 33 strains were resistant to all the tested antibiotics. And among 46 meropenem resistant strains, the cefoperazone was predominant with 95.7% resistance, isolates showing resistance, followed by ceftazidime and ciprofloxacin and amikacin. You can see the AST profile bar graph, where most of the strains were resistant to all the tested antibiotics. And we also checked the demographic details, and in this, the middle age group were found to be having more resistant strains, and males were predominantly having the resistant strains. And the results for the carbapenems production, the phenotypic study carba-NP test showed that out of 46, 39 isolates were positive and 7 were negative. And by multiplex PCR, we found that out of 46, 38, that is 82%, 82.6% isolates harbored BLA and NTM strains, and 3 were harboring BLA VIM. We also checked for the other strains, BLA IMP, KPC, and BLA OXA 48 genes, but only NDM and VIM strains were positive. And when carba-NP test is compared with that of the multiplex PCR using carba-NP as the gold standard, we found that there was 100% sensitivity and 71.4% specificity, 95.1% positive predictive value, and 100% negative predictive value. And among 46, 39 strains were carbapenems producing, by both phenotypic and genotypic method. And out of the 7 were carba-NP negative, in which 5 were negative by multiplex PCR also, but 2 came out positive by multiplex PCR, which showed BLA-NDM strains, which were BLA-NDM. And biofilm formation was observed in 15 strains, out of which 12 were harboring BLA-NDM strain, and 1 was harboring VIM, and 2 were negative for carbopinamases production by both the methods. And in addition to that, the 8 among the 15 biofilm producing strains were resistant to all the tested antibiotics. And these are the results of carba-NP, where the color change is used for the detection of carbopinamases. In discussion, by this study, we came to the conclusion that MDR strains are growing concern now. And in this, the carbopinamases production has increased the resistance in case of carbopinam resistant strain. And we found out that 84.78% isolates for producing carbopinamases by carba-NP test, and about 89.13 isolates for producing carbopinamases by multiplex PCR. The detection was done by multiplex PCR. And the BLA-NDM strains were predominantly found in our study, which is followed by BLA-VIM. And the conclusion, the study highlights the prevalence of BLA-NDM mediated carbopinam resistance among CRPA isolated from urinary tract infections, and they, together with the association with biofilm production and multi-drug resistance. Thank you.
Thank you so much. So we have a question from the audience. Study showed the prevalence of resistance in males compared to females, the high prevalence in men. Is there any implication of that media that
According to the demographic details, we found resistance to be more in those. And
I asked if there were plans of prevalence, more prevalence in males than compared to females for this particular
I mean, it can be due to the sample size which we had obtained, which is 46, and our actual sample size was 120. Based on that, the result might have been a bit different from this. But based on 46, we got that there was a slight prevalence of male than female. And if we had more strains, we would have got better results.
Also, is this limited to this institute? Do you think it's a generalized trend across the reason for assisting and
there are similar studies which are done in multiple institutes in different places, and there is a trend of carbopinam resistance, but the resistance due to carbopinamases was not studied much, but it was due to various different like efflux pumps or porin, outer membrane porin deficiency. There is resistance. So if we do the same study in multiple institutes, we will be finding similar results or even more clear results. Right?
Very good presentation. So, what the take home message for the clinicians you want to suggest based on this study?
So generally, if there is any multi-drug resistant strain, carbopinams will be used. But in our study, it is we can see that there are many carbopinam resistant strains. So using carbopinams will cause further resistance. So appropriate antibiotics should be given in those cases.
Okay, thank you so much. Yeah.
What is the rationale in keeping this carbo and beef test was constrained?
It is easy to perform. We can visually see the difference, and it is used as confirmatory test by CLSI. According to CLSI guidelines also, and it will take even less time to perform. And it is based on the direct enzyme action in this. It is based on the pH change caused due to lysis of imipenem by carbopinamases produced by organisms. It is direct enzyme action, so it will be better.
Thank you so much. The WHO 90-70-90 goal, the 70 stands for 70% of eligible women being free for free with the high-performing set. In India, only 5 to 30% have been reached. One of the most promising ways to close that gap is HPT self-sampling, method where women collect their own sample at home. The authors conducted a structured health education program to evaluate how it shapes both awareness and willingness to participate.
Good morning, everyone. I'm Corey, and my project got selected for ICMR SCS 2024, titled The Impact of Health Education Program for Sensitizing Women on Self-Sampling for Cervical Cancer Screening from Rural and Urban Southern India, a mixed method study. We chose this topic because cervical cancer is the second most common cancer among Indian women, and WHO has called for 70% of the women to be screened. But in India, barely 2% of the population have been screened. So to reach a wider population, WHO has endorsed the self-sampling method and many studies have proven that the self-sampling have yielded comparable results to the physician-collected samples. Our primary objective was to design a sensitization program to create awareness of cervical cancer screening and self-sampling. And our secondary objectives were to assess the knowledge and perception of cervical cancer and its screening methods, and to evaluate the impact of a health education program in terms of learning outcomes and willingness for self-sampling. After getting approval from the Institute Ethics Committee and Directorate of Health and Family Welfare Services, we started our data collection. Women aged 30 to 65 were gathered from Puducherry and Adungadu parts of Karaikal. The women who were gathered were those attending the PHCs and those from the self-help groups. A total of 10 health education programs on 4 days were conducted. After getting consent from the participants, we first wanted to assess the baseline knowledge about cervical cancer. So we gave a questionnaire consisting of 10 questions regarding their knowledge on cervical cancer, its screening method, and if they're aware of the self-sampling method. After that, health education was done. We talked about cervical cancer, the importance of screening methods, and self-sampling method. After this, to assess the knowledge gain, a post questionnaire was conducted, and for the perception of self-sampling method, a focus group discussion was done. So these are some pictures from a health education program. We use charts to explain about cervical cancer, different methods available for screening, and then a model was used to talk about self-sampling method, and various instruments available for self-sampling method was also shown. In methodology data analysis for quantitative data, first the pre and post questionnaire responses were scored, and paired t-test was used to compare the pre and post questionnaire scores, and an unpaired t-test was used to compare the scores of two groups. For qualitative data, thematic analysis was done. After getting consent from the patient, the audio was recorded of the focus group discussion and transcripts were made. From these codes were generated and 4 themes were generated. Those are preferences, facilitators, barriers, and suggestions for improving self-sampling. These are the results. A total of 124 participants were there, out of which 29 were healthcare workers, including ANM, ASHA workers, and Anganwadi workers, and 95 were from the general population. These are the women attending the OPDs, women from the self-help groups, and the housekeeping staff. We saw that most of the participants were from the age group of 35 to 40. And in the quantitative data, the number of participants willing for self-sampling, before intervention, there were a total of 48 participants who were willing for self-sampling, and after intervention, it increased to 100 participants, which correlates with 41.9% increase in willingness for self-sampling post-intervention. On assessing the knowledge gained post-intervention, we first categorized the scores into 3 categories: poor score, satisfactory, and good score. Before intervention, we saw that 4.8% of the participants had knowledge about, has scored good in the questionnaire. And after an intervention, it drastically improved to 62.9%, which shows a 58.1% difference, which is statistically significant. Among the healthcare workers, there was 52.6% improvement, and among the general population, there was 75.9% improvement. On assessing the qualitative data, we saw that the facilitators for self-sampling were autonomy and privacy, education, training, and confidence building, familiarity and procedural assistance, motivation, and perceived health benefit. The barriers were concerns about procedural accuracy, emotional and physical anxiety, socio-cultural factors, and acceptance issues. We showed them three different methods available for cell sample collection, and most of the women chose swab as the preferred device because of the familiarity. The suggestions for improvement were repeated health education programs, high fidelity using training using models, mannequins, and videos, and community engagement by addressing the local needs of the population. Our research showed that there was a difference of 41.9% improvement in willingness for self-sampling post-intervention, which aligns with various studies done on the same concept. And it also aligns with willingness for cervical cancer screening study done by various intervention types, in which our intervention of health education showed a 41.9% improvement. In conclusion, a well-structured health education on cervical cancer awareness and self-sampling method has a positive impact on women. Repeated education and training can empower our women to participate, addressing their personal and social concerns, increases the screening coverage, and ensuring proper assistance can improve participation. Our future directions is to show hands-on training on self-sampling and including the community healthcare workers to cover a larger population, creating pamphlets for wider coverage and creating interest among the public, and to procure self-sample kits and demonstrate the process of collection. These are my references. Thank you.
So for questions. Yeah, a very good study. So, already was the new name. So, like what qualitative approach he used actually to get that, he was both quantity and quality.
Yes, sir.
So, can you tell about in the setting, where you use that setting? Because it's matter for the patient will express the conducive control.
Yes.
What precautions do you take?
We mostly targeted women from the self-help groups, so they were a motivated population. And because most of the settings were only women and men were not present, they were more open to share about their concerns. And as all the population were from the same community, most of their preferences and barriers were the same, so they were more willing to share about it with us.
Okay, thank you so much. Good.
Your study on doubt is you assessed only the willingness, and all those who are willing, they were not. I mean, the samples were not taken immediately after this. So I think we have to take this results with a little suspicion. Okay, they may express their willingness, but no, immediately if you ask them to give the samples, probably some of them who have no given the willingness may have
Asked for this. So after collecting the willingness, we asked them if we were to give a self-sample kit now, would you be willing to take it now? And many of the women said if they had a person who has already taken self-sample, explain the procedure, or if the community healthcare workers like their ANMs and ASHA workers, who they are more comfortable with were there during the procedure, during the first time, for the consecutive sample collection, like after 3 years, as given, they would be more willing to take it for the next time. But for the first time, they would need some assistance, is what they said. So.
willingness is different from actual life.
Yes, sir.
And whether the educational status and whether they are from rural, urban, and so on was assessed to do among the participants. So that would also be one of the components in giving this willingness.
The rural, what we selected was Puducherry and Nedungadu parts of Karaikal. So Puducherry comes under the urban part and Nedungadu comes under the rural part. So we thought of giving a difference between rural and urban part. But what we assessed was that in these two groups, most of the women's educational status, their family conditions were all similar. So there was not much difference between urban and rural population. So we took health care workers and the general population.
Hi, really very nice presentation. I think we have the way to present it. It's not very appropriate, very confident presentation. And I know I understand that you've done a lot of groundwork having a focus group discussions. Just wanted to ask what was the number in that focus group? How many you said you mentioned 10 focus group discussions happened. So a number of participants in each group.
It actually depended, ma'am, because the number of participants in the healthcare workers were smaller than the number of participants in the general population. So, in the healthcare workers, the sample size was for single focus group discussion, there were around 12 to 15 participants. But when it comes to the general population, there were around 20 participants per focus group discussion.
Really?
Yes.
Okay, thank you.
Others. Okay, go on to the next presentation. So for the context, when newborn's heart is naturally not like we interpret that so. So the nomogram relating to that was built on Western population. And this classification will trigger unnecessary workup and anxiety down. So the author set out to validate an Indian nomogram in our population. On the next presentation, number 7.
So, good morning, everyone. Myself, Varun, and today I'm presenting our study entitled Comparison of Indian and Western Echocardiographic Z-score nomogram distributions for term Indian neonates. So, in pediatric cardiology, the significance of Z-score comes where, unlike adults, where they have specific range of measurements, neonates and children, they have continuous growing dimensions of heart with the age and size. So, they need a Z-score system in order to standardize the cardiac dimensional interpretations. So, then, but until 2023, there is no dedicated Indian nomogram for neonates. So clinicians widely relied on the Western nomograms. But there is ongoing debates all over the world for the need of ethnicity-specific references. When the first Indian neonatal nomogram published in 2023, but still there is no prior head-to-head validation against Western nomograms. So this gives us the question that are Western nomograms appropriate for Indian neonates, and do any meaningful differences arise when they are applicable in neonates? So my objectives my primary objective is to determine the agreement between the Z-scores of Indian and Western nomograms. And then my secondary objective is to compare the proportion of neonates categorized under -2 Z-score for each measured parameters when Indian and Western nomograms are applied. The study methodology is a single-centered cross-section observational study, and my sample size is 98, which is calculated using an expected interclass correlation coefficient of 0.65 at 5% significance and 80% power to read a convenient sampling. And the study flow is we screened around 150 units from the eligible units, and then we enrolled around 98 participants based on the inclusion criteria of gestation of age, that's 7 to 42 weeks, and birth weight of 2.5 to 4 kg. Then we did anthropometry. VSA is calculated using Haycock's formula. And then echo is performed on a radiant farmer in the kangaroo mother care unit in the NICU. The child is examined in the post-breastfed state and no sedation is used. The echo images were obtained in the standard views and stored in DICOM format. 18 parameters were measured, and then Z-scores were calculated for these measured parameters based on Indian regression equations which are present in the Indian nomogram, and then there are online calculators available for the Western nomograms, which is parameters.com. Then we did a statistical analysis. For primary, we did an agreement analysis, ICC. And then bias is estimated using Land-Altman plots. And then for secondary, we did a classification. Coming to the results, there is excellent agreement for almost all the parameters. When Indian and Cantonoti is a Western nomogram and Lopez is also other Western nomogram. When both of them are compared, the ICC is mostly 0.92 and MVA and LVA is shows borderline excellent. And when Indian and Lopez is compared, some parameters such as PV, IAST and left wave chamber dimensions, they had moderate, good agreement. The reference scales are here. So here are the Bland-Altman plots. We can also see this looks like excellent agreement, and then there is very minimal systemic bias. But when we see here, there is 1.7 of mean difference, which shows systemic bias. Now here, when IVSD is assessed and Indian and Cantonoti is compared, we can see like minimal systemic bias. Whereas for the same parameter, when Indian is compared with Lopez, we can see a huge systemic bias as well as wide limits of agreement. Here are the results. I have just put up the significant parameters which are showing any systemic bias. Here there are positive systemic bias and negative systemic bias, which indicate that one system is consistently estimating higher than the other. Basically, Indian is estimating higher in the positive systemic bias. And coming to the secondary objective, we had classified the percentage of neonates falling under -2 Z-score. So in a normally distributed population, we can expect around 2.3% falling below -2 Z-score. The thing I have probably mentioned in the first slide. But here we can see that the Western Z-scores have estimated more than 10% till 40%, nearly half of the population below -2 Z-score. The -2 Z-score is used to diagnose the hypoplastic of cardiac dimensions. But Indian Z-scores are also estimated a bit higher. But the rest of the parameters and Indian Z-scores is that's pretty fine, less than 2.3. But Western now Z-scores have a very high proportions have been consistent in all of the dimensions. So coming to the discussion, I have already discussed the importance of the echo. And then the major findings is Indian nomogram is performed on par with Western nomograms, which shows an extended overall agreement. Western nomograms has variable systemic bias and wide limits of agreement for several parameters that I have already shown. Western nomograms classified substantially higher proportion of neonates having measurements -2 Z-score, which is hypoglycemia. Particularly for sinotubular tension, ascending aorta, aortic isthmus, main pulmonary artery, and valve, and both mitral and pulmonary valve. These are very clinically significant for diagnosis too. So even between Western nomograms themselves, as we see in the Venn diagram plots, there is clinically relevant differences exist for specific parameters. So the clinical implications is use of ethnicity-specific nomograms may reduce misclassification and improve precision in neonatal echocardiographic assessment. We are basically not saying that whether it is correct or wrong. It is just it helps us to reduce the misclassification and misinterpretation. Also, there is literature from African and Asian populations which support the application of population appropriate reference standards wherever is feasible. So coming to the conclusion, this is a cross-sectional study compared echo Z-scores derived from Indian and Western nomograms across multiple cardiac dimensions in 98 healthy term neonates. Very strong correlation was observed between the nomograms. However, for several parameters, as mentioned before, brand analysis demonstrated systemic bias and wide limits of agreement, and Western nomograms classified a greater proportion of neonates as having measurements of -2 Z-score. These findings support the validity of Indian neonatal nomogram and highlight the importance of using the ethnicity-specific reference standards. Thank you. These are my references.
Thank you so much for sharing your information. I think we have a question from the audience.
Hello. You had mentioned that the echocardiograms were performed within the first 5 days of life.
Yeah.
So do you think any transitional circulatory changes in that early neonatal period could have influenced any of your measurements?
Yeah, like if the measurements are influenced, if one nomogram is influenced, other nomograms, like basically the measurement itself is influenced by the circulatory change. Yes. And other nomograms also will be classifying the same. So it's pretty much the same.
Good presentation, and my colleagues, the Western standards have been published how many months back?
One in 2017, sir, one is 2014.
Okay, and after examining assessing how many children, how many units in the population you have come to this scoring the publications?
Sir, one thing, the one with Lopez, they estimated around 1,000, sir, all over the USA multicentric study. That is a multicentric study. And Cantinotti has evaluated in this thing in American, it's basically an Italian journal, sir, which is around that 800, sir, 873. And then,
so when compared to them, your sample size would be less.
Yes, sir. Basically, we are validating the nomogram. So, like, if we are developing one nomogram, it would have required a larger sample size. But since we are validating and we had a good agreement coefficient for calculation of sample size, sir, so that pretty much we have significance and good power.
The assessment was done by a single person.
Yes, sir. All the echo is recorded by a single person, and measurements were done by a cardiologist. My guide.
Was very practical, very very useful. What is common more people are at there was difference between Indian mammogram and others, but is a scientific explanation for 40% difference.
This thing there is that's what, sir. Since it's developed by Western mammograms, maybe there this aortic isthmus is pretty much smaller. I mean, pretty much larger. So since ours is smaller, it is estimating a log number. I mean, ethnicity specific differences exist in the dimensions itself. Sir.
Mammogram. You need graded mammogram.
Yes.
Minor difference is 90, but why you take more so much of difference there?
Since it's developed on Western population, so these two mammograms. This is developed on Indian population. So these dimensional differences exist in the I mean, individuals itself, like the regions itself. So.
That's a one effort to understand that. Okay. Basically, when you want to make a mammogram, even for validation, require a large sample size and potential controllers, whatever different ethnicity users do, different societal status. Right, this all actually to address it. As a UG student, you made this setup in the greater perspective, we appreciate. The clinical implication, try to observe that they require large sample.
Yes, sir.
Then when you come to otherwise, whatever you got this thing, it's a difference. You cannot actually take it immediately and take
Yes.
right for our software.
So that's actually a limitation, sir. We actually need to validate this thing in preterm, small for gestational and after for gestational, so that it can actually identify whether it's very misclassification is happening in the unhealthy babies too. Since we included only healthy term neonates, we cannot. But my
The
conclusion.
operation definition for that, locals, those operation definition. Have you taken same definition or different
Yes.
definition?
They didn't include locals. Yeah. I mean, they didn't include preterm as.
There is no operationally methodology that's variation in there. Otherwise, this much difference you are not able to, visualize.
Yeah, I mean,
We need
sure, sir.
to actually, scientifically
We need to probe further.
more appropriately so that the bias can be addressed. You are taken convenient sampling.
Yes, sir.
What about other taken convenient sampling or random sampling? Convenient sampling won't give the
Yes, sir.
exact general normal distribution. So
I mean-
it's looking at that.
Yes, sir. The thing is like convenience based on, I mean, all the healthy babies which are
Study is very good.
will.
But in a larger perspective, we have most of
Yes,
the-
sir. Sure, sir.
Thank you. We have this one of them.
I know, very nice presentation.
Fine.
I want to follow the members. Just wanted to know when is Indian mammogram developed
2023, ma'am.
and there are the validation studies.
No, ma'am. There is no validation study. That's I mentioned in the background itself. Like there is no prior adequate validation, and even though it's present, none of the clinicians use it because there is no validity. So that's why we are think we thought of validating this so that
And all
clinicians.
that is very important in these
In-
times. In teenage children where we don't conform.
They have to diagnose and interpret as well as plan the medical
Yes.
information surgically or such.
Very well.
Thank you so much. Thank you.
On to the next presentation. Nutrition label is one of the simplest topics and it allows consumers to know exactly what is they are consuming. Yet, 80% of Indian adolescents are unable to read or interpret these labels. The authors conducted a structured education session to see if a targeted hands-on workshop could bridge this.
Good morning, everyone. Good morning, everyone. I'm Caroline Joseph. Today I'll be presenting my research on the effectiveness The effectiveness of a tailored education program on food label literacy in terms of knowledge, attitude, and practice among undergraduate students at selected Arts and Science College in Puducherry. So, according to the NFHS 5 survey, the high rates of NCDs are killing millions in India. Here, I address a major problem which contributes to them, the lack of food label literacy, which can act as a first-line defense against NCDs. So, Puducherry emerges as a critical blind spot in food label literacy research due to its unique vulnerabilities such as high packaged food consumption, low nutrition label engagement, and it is due to the national neglect such as tourism-driven processed boom, absence of school curricula on food label literacy, and no prior hands-on interventions in non-medical colleges. This intervention is the first line ever. This is the first ever low-resource hands-on practice, hands-on workshop to improve the KAP knowledge in college students. So the objectives of the study was the effectiveness of a tailored education program on food label literacy and to identify the association between post-KAP levels to a selected demographic variables and to determine the correlation between KAP related to the food label literacy after intervention. And coming to the methodology, the design was a quasi-experimental one-group pre-test post-test design. The study population included the undergraduate students of a selected arts and science college. The sampling technique was convenience sampling with a sample size of 75. 15 students from 5 different departments were chosen. And coming to the data collection procedure, the participants were collected conveniently after with inclusion and exclusion criteria after getting approval from the committees, and an informed consent as well as a structured self-administered questionnaire was given to the participants. The self-administered questionnaire had two parts. Part 1 having socio-demographic data and lifestyle and health factors. Part 2 having knowledge-related questions, attitude scale, and a practice checklist. After verifying the validity and reliability of the tool, pre-test was taken on the first day for 30 minutes, education program on the second day for actually 120 minutes, and the post-test after the 6 weeks of intervention. The workshop included a PPT followed by hands-on practice on decoding food labels, ended up with a discussion to clarify the doubts. Then coming to the statistical analysis, the continuous variables was summarized with mean, standard deviation or median IQR. Then categorical variables was expressed as frequencies and percentages. Pre-test and post-test was compared using Wilcoxon test. Correlations examined with Carl Pearson, and group comparisons was mainly done with Man-Whitney U test. Then median age of the students were, regarding the distribution of the demographic variables, 91% of the 75 samples were male. Among them, 52 were placed in the second year, 99 of them were day scholars, and 79 of the students' father had only primary education, and most of them were doing coolie jobs. 60% of the students' mother also had only primary education, most of them being homemakers, and 41% of the students consumed packaged foods weekly. Median age of the students were 19 years and median body weight was 55 kg. Comparing the median knowledge, it has improved from 9 to 12 after the intervention. Similarly, median attitude has improved from 64 to 77 and median practice has improved from 18 to 23, showing the statistically significant post-test results. The post-test knowledge was not significantly related to any of the socio-demographic variables. The post-test attitude of the students was found related with the gender, year of the study, and course of the study. It was inferred that the post-test practice on the food label literacy was found related with the year of the study of the students. The findings revealed a significant negative correlation between post-test knowledge and post-test attitude. A significant moderate correlation was observed between post-test knowledge and post-test practice. However, furthermore, a significant negative correlation was found between post-test attitude and post-test practice. Then in discussion, higher knowledge actually correlated with more negative attitude toward food labels. This suggests that just teaching the facts that isn't enough. We need target interventions that boost motivation and mindset to truly transform classroom learning into healthy. In concluding, empowering students means empowered food choices. True impacts comes when understanding is paired with positive attitudes and sustained practice. Equipping young adults today builds a healthier communities tomorrow. Low resource small interventions can spark long-lasting big outcomes, including public health improvements. These are my references, and this brings to the end of my presentation. Thank you.
Very good presentation and very good topic for the study because it's a major public issue. testing that have numbers in the, how do you assess post-test the frequency of eating?
I seen self-administered questionnaire was it has
So they have to self-report.
yeah. I actually the inclusion criteria was students who knows English. So it's like they will be right to they will be able to read the
You don't
questionnaire.
have independence for the
No. I just gave that questionnaire to them and they have did by their own.
And the 120 minutes of workshop, how who did it?
That me and my guide, we together did the workshop. And I had undergone a program regarding this food label literacy, like an online course. I went. After that only I had conducted the workshop.
You do it, mental quality skill.
Thank you, ma'am.
Proper presentation, my query is now, why you think knowledge correlated negatively with that?
Like because knowledge because the posters were done after 6 weeks, so it's like even we also will be having knowledge, but we'll be going to shop and we'll be looking into the food labels, but we have habit of eating it. So it's like we'll be, okay, anyways NCD it will be coming in future only, right? Now I am not having sugar or diabetes or hypertension, so I will just eat it like that. We will be also thinking, I think they might have also thought like that. So attitude changing attitude needs a long term intervention. Like so they asked me when I went for a workshop, like why you should study all these, like usually peer I know that how they are. So I was like this having these eating this like if they're saying just NCDs, they'll be telling we are young only, we don't need that. So I told them like this causes hair loss.
It seems that there could be a drastic change, but maybe after 6 months, then they won't be able to retain anything, no? The intervention may not be effective at all, no?
I am telling like this should be included in the curriculum of their
I think that's a knowledge only, no?
and so that it will change their attitude after a long time of
Okay, still extension of what's there is then what is the knowledge part you are inculcated?
like how they are able to interpret those food labels. Like by the
Your knowledge questionnaire, whatever you're going to teach in the workshop, not only reading it, so what is the implication of that? So if they are told about the implication of the knowledge, they will not ask you the question. They are involved, we not develop empathy now.
actually in food labels it was written as MSG, we all know it's actually not good for our health, and but in food labels it is not directly written as Ajinomoto or MSG. It is written as different names and codes.
Your workshop will be telling all that. Okay.
In pre-test only they have asked like that. Before going to pre-test, why what is this? Why we should do this test? And like that they have asked.
Not I'm asking post-test. As I was asking, no, your post-test knowledge is not corresponding to aptitude. That's what you said, right?
It's, separately, the knowledge has improved from pre-test to post-test.
Yes. But if knowledge is attitude also has been improved, no? But you don't think it is not, that's what the question. If the answer cannot be, their knowledge is still poor. They cannot ask 3 questions like that. No, I'm young, I cannot develop MCD. They have the good knowledge.
No, they asked that question before intervention. After intervention, they didn't ask it. I think I will get fine.
Yeah, it's probably it's a very good presentation.
Thank you, sir.
So basically, public health, it won't be work in single kick.
Yeah.
You can click it. You need to train course at least 3 times. Then only there will be a change start come. Even to us. Okay, so I think there will be effort, continuous effort. And someday the people will change. Okay, and presentation please try to have not too many numbers of numbers. Go back the tables. No, the tables are too small size. Make it more flexible in future, because positive things also need to tell some marks. Make it more clear presentation. Okay, thank you so much.
Thanks.
Okay, we go on to our ninth and final presentation. The protein growth failure is very predetermined. This is strongly linked to poor long-term growth and adverse development. However, because we lack a single universal agreement on definition for it, the issue is often faced widely varied prevalence rates and the very real risk of misdiagnosing these vulnerable patients. Explanation, the authors start with the lack of consensus
head on by comparing 4 different diagnostic criteria.
Good morning, respected judges, professors, and dear colleagues. This is Sridhari here, presenting our study title, Comparison of 4 different criteria for the diagnosis of postnatal growth failure in very preterm babies. This is a diagnostic study conducted in the Department of Neonatology. Preterm birth is a major contributor for neonatal mortality and long-term neurodevelopmental impairment in India. Postnatal growth failure is common among very preterm neonates and is associated with adverse long-term growth outcomes. Multiple diagnostic criteria exist for postnatal growth failure, but there is no consensus on optimal definition, which may lead to inconsistent diagnosis and delayed intervention. Our study is the first study to prospectively compare 4 currently used diagnostic criteria for postnatal growth failure and specifically addresses high-risk preterm neonates. So the 4 criteria which is evaluated in our study is weight for age delta Z-score, which is the change in Z-score from birth to discharge, which currently serves as our reference standard as it strongly predicts neurodevelopmental outcomes. Secondly, we have the weight gain velocity. Thirdly, we have the composite criteria, which includes more than 2 of the following indicators, which is length for age Z-scores, length gain velocity, and days to regain birth weight. And at last, we have the weight less than 10 centile at discharge as our last grade. So this table outlines our 4 key criteria across the mild, moderate, and severe spectrum. Due to the time constraint, we are not diving into the details of this. This is present for the reference. So the primary objective of the study is to test the diagnostic performance of 3 criteria of postnatal growth failure compared to the current definition, which is the reference standard, and to study the prevalence of postnatal growth failure in very preterm neonates across each criteria. And the secondary objective is to find the risk factors associated with postnatal growth failure. So our study is a hospital-based prospective observational diagnostic accuracy study, and our study population include very preterm neonates born less than 32 weeks of gestational age. And we excluded the criteria of the babies which expired in less than 36 weeks of discharge or had skeletal dysplasia. And in the sample size calculation, we are using the estimated prevalence of 80% with using the delta weight Z-score as standard. Expecting the 90% specificity and sensitivity, we required a sample size of 174 very preterm neonates. So this study was approved by Institutional Ethics Committee. The informed parental consent was obtained prior to our inclusion. Anthropometric measurements, the weight was recorded using standardized digital calibrated scale with plus or minus 5 gram accuracy. Length was measured in the recommended position in infantometer, and the head circumference was monitored using a non-stretchable measuring tape. This was collected during our data collection procedure. So the growth parameters were plotted on the Fenton centile charts. The delta Z-score, weight gain, and length gain velocity was derived from the WHO-based PediTools app. As you can see, this is the PediTools app which we used. Detailed clinical data include feeding, respiratory support, and neonatal morbidities were systematically collected from the case records of NICU. So for the data presentation, the continuous data was presented as mean or median, and the categorical data was presented as frequency percentages. For the risk factor analysis, continuous variable were analyzed using Mann-Whitney U-test, and the categorical variable was analyzed using chi-square or Fisher-Exact test. For the risk factor analysis, binary logistic regression was also performed to identify the independent predictors of postnatal growth failure. And for diagnostic evaluation, we calculated sensitivity, specificity, area under curve likelihood ratios, and ROC curve analysis. So during our study period, totally 3,041 NICU admissions were there, out of which very preterm neonates and 245 very preterm neonates were there, and the babies which expired before 36 weeks of discharge were 71, and after the exclusion criteria, we included 174 preterm neonates in our study. So comparison of prevalence. In the delta weight Z-score, we had diagnosed 149 very preterm neonates as postnatal growth failure infants, which corresponds to the prevalence of 85%. The weight gain velocity had diagnosed 161 very preterm neonates as postnatal growth failure, and more than 2 composite criteria diagnosed 81 neonates as postnatal growth failure, and weight less than 10 centile diagnosed 131 very preterm neonates as postnatal growth failure. So this table outlines the distribution of severity across mild, moderate, and severe criteria. So as we can see that the delta weight Z-score gives the balanced distribution of severity, but other criteria shows variance. So coming to ROC curve and diagnostic performance, we can see that weight less than 10 centile showed relatively higher area under curve of 0.683 compared with others and showed modest discrimination in performance. So coming to the factors associated with postnatal growth failure, we can see that the delayed regain of birth weight emerged to be an independent predictor of postnatal growth failure with adjusted odds ratio of 1.1. And also we can see that in the ROC analysis identified more than 13 days as an optimal cutoff for delayed regain of birth weight predicting the postnatal growth failure. Coming to the discussion part, postnatal growth failure in our cohort was 85%, which is in accordance with other studies. Weight gain velocity, which had very high sensitivity and low specificity, tends to overdiagnosis. The composite criteria, which had higher specificity and lower sensitivity, tends to miss cases. And weight less than 10 centile had relatively better discrimination with area under curve of 0.683, but its performance in overall diagnostic performance was modest. The delayed regain of birth weight remained an independent predictor of postnatal growth failure, where early postnatal nutritional inadequacy plays a crucial role, with nutritional intervention during this phase to be targeted. The strengths of this study was prospective head-to-head comparison, standardized anthropometric measurements were made, systematic collection of clinical variables, and the limitations was lack of longitudinal follow-up to define the best prediction of long-term growth or neurodevelopmental outcomes. So conclusion, the PGF prevalence was highest 85% using delta weight Z-score. Alternative criteria demonstrated limited diagnostic performance compared with the current standard, and the risk factor, the delayed regain of birth weight, remained an independent predictor of postnatal growth failure, highlighting the early nutritional optimization is critical. Yeah, this is the references. Thank you for this.
We go to the Q&A session. A good presentation. We were little fast. We are finding it difficult to understand. Like in my understanding, I think the three parameters are assessed against the gold standard parameter. I mean, then the title should be slightly different. No, the title is you are mentioning the four parameters are actually the three existing parameters in use are being compared with the newest one, which is delta results.
So actually, delta Z-score doesn't serve as a gold standard, sir. This is used as a reference standard in our study. So we are comparing like all the four.
Why you chosen that as a
because in the previous study it has predicted stronger neurodevelopmental outcomes. So it is currently used as the reference standard as also
I feel it could have been reworded in such a way, against this you are comparing the list and so on. And whether the feeding practices have been taken into account in
yes, sir. From the NICU records, we obtained the record of the calorie and protein intake of the child, which is required for our composite criteria, so which was also included in our studies.
Okay, it's very good study. So, by making being perfect, one thing you went very fast. Go back to the ROC curve. Yeah, ROC curve. So that here, which is reference one, the green one is reference one. Reference is okay, the reference color.
Yes, sir.
Okay. So which one is actually better one?
The green one, sir. The criteria 4, which is weight less than 10 centile.
Here I go the curve, not under.
Yes, sir. It's above the reference standard, which had 0.63 of area under the curve. So it has comparatively better performance when compared to the other criteria.
The red one is more going close and sensitive, but after that declining that. Can you explain why this one was like that?
So the red one is the
blue one is very close to the standard one.
Yes, sir.
Yes.
Yes, sir.
So the red and green have really different game. What could be the reason?
So the red criteria is the composite criteria, sir, which had higher specificity but low sensitivity. So it tends to miss cases in this also. Maybe it had more than 2 criteria which was to be satisfied to classify it as postnatal growth failure. It might have had low specificity sensitivity.
Which one you are going to get? It's just like an implication.
As of now, when compared all the criteria, the already used reference standard tends to be more clinically relevant. So, but still, compared to the reference standard, in the 3 criteria, the criteria 4, which is the rate less than 10 centile, gave a modest diagnostic performance.
That is going to be, what about your discussion of the other studies, which is consistent with your study finding, or it's different?
Sir, actually, this is the first study to prospectively compare the 4 diagnostic criteria. So, but we have only the data about individual criteria, and the delta Z score currently serves as a reference standard, so it has more studies based on that. So,
Thank you so much. Excellent. Yeah.
She had a presentation. Basically, my question is the same as what Dr. Motivating of. So when you have taken market, when the intelligence square score as the standard, that means standard, you have your research question. How things behave to a reference standard, 3 criteria instead of having the 4 criteria. And in the exclusion, you had excluded the skeletal displacement, right? Whatever the reason.
Ma'am, the skeletal dysplasia child, the length measurement, the anthropometric measurements might be having the inconsistent data. So that's why you have excluded the babies with had skeletal dysplasia.
Thank you.
Thank you so much. That brings us to the end of engaging UG presentation. We heard 9 companion presentations today, each one showcasing their capital inquiry and diversity in this group. To all of our presenters, we wish you the very best with your work going forward. And to our audience, thank you so much for taking the time as well. We hope you have been today with a few new ideas and perhaps we can keep going. That's exactly what we're research on. And go and have a wonderful day. The work.
Thank you to all the undergraduate presenters for their interesting research work and our moderators and the judges for guiding the session. We will now break for tea and poster presentations. Participants are requested to visit the poster displays at ground floor and 4th floor. We'll reconvene here at 11 a.m. for the next oral presentation session. Thank you. Lunch will also be provided here at 2 p.m. Kindly join us for lunch. 1 p.m. 1 p.m. for lunch. We can wait, yeah? Yeah. You can just laptop open பண்ணி you but you know video starts off நீங்க என்ன குங்குமம்லாம் போட்டுட்டு பயங்கரமா இருக்கு என்ன சார் நல்ல மாதிரி வந்து நிறைய பிரச்சனை சரியா
இன்னும் 6 நிமிஷம் தான் வருது
இன்னும் 4 நிமிஷம் தான் discuss outside.
அதே ஆர்டர் தானா
இத்தனை பேர் நீ எனக்கு அடுத்தது தானே ப்ளீஸ் எனக்கு அடுத்தது அதுக்கு நடுவில் தானே இந்த கௌரி பாக்குறது நமக்கு
அப்படியா
now in the junior residents oral presentation session. We are grateful to have our respected judges, Dr. Sonali Sarkar, Department of PSM, Dr. Gauri Doradajan, Department of Obstetrics and Gynecology, Dr. Lakshmi Shah, Department of Dermatology, Dr. Srijit Parameshwaran, Department of Nephrology, Dr. Noel Marie Joseph, Department of Microbiology. I would also like to invite the moderator of this session, Dr. Aditi, Department of Anesthesia, Dr. Saurabhita Banerjee, Department of Emergency Medicine. May I invite our moderators to kindly take all these sessions.
Morning, very warm welcome to everyone. So, we are the moderators, myself, Dr. Saurabhita, and with me, we have to run the class. Starting with the presentation, we have a set of 9 presentations as the junior residents to the post-graduate. So, we'd like to start with the first presentation. We have Dr. Maheshwari T. She will continue on the efficacy of doxycycline as an add-on therapy in drug-sensitive catheter pulmonary tuberculosis patients. It's a randomized placebo-controlled trial.
German.
So, we'll be having 7 minutes for the presentation and 3 minutes for discussion. So each speaker will have a total of 10 minutes. We will be having a short bell run at we have a short bell run at 5 minutes, which will be a warning bell, and then final bell run at 7 minutes, which will indicate the end of the presentation, and then followed by a discussion or review. So Dr. Maheshwari, you can start with your presentation.
Good morning, all. So, welcome you all to my presentation titled Efficacy of Doxycycline as an Add-on Therapy in Drug-Sensitive Cavity Pulmonary Tuberculosis Patients, a randomized placebo-controlled trial. Coming to the introduction, tuberculosis is a major global health concern. Though we have so many drugs which targets mycobacterial burden, there is paucity of the drugs which targets or influences the tissue remodeling. So, cavitation, as we all know, is a pathognomonic feature of pulmonary tuberculosis. And this cavitation, even after successful completion of the treatment, so it can affect the chronic lung health. This cavitation is driven by various factors, especially matrix metalloproteinase, so which basically breaks down the extracellular matrix. So this MMP is being inhibited by doxycycline, so which is known to have this property, and this property is being studied in our trial. So in cavity pulmonary tuberculosis. Coming to the objectives, so our primary objective is to evaluate the reduction in circulating matrix metalloproteinase with secondary assessment of microbiological status and quality of life and radiological features. Coming to the study setting, so a study was primarily conducted in outpatient department of pulmonary medicine and in some primary health centers in Puducherry for a period of 2 years. So we included newly diagnosed drug-sensitive cavity pulmonary tuberculosis patients, and they have been randomized to receive either capsule doxycycline or placebo 100 mg twice daily for a period of 4 weeks, along with their standard anti-tubercular regime. So a convenient sampling of 60 participants has been made. So this sample size was calculated based on a previous study, and the study was double-blinded with participant and myself, the investigator, has been blinded. The statistical analysis for between group comparisons, man-Vitti test or independent sample t-test or chi-square or Wheeler exact test has been undertaken based on the type of data and the distribution of the data. Coming to the baseline demographics, so baseline demographics were comparable between the 2 groups. So with mean age ranging from 46 in placebo group and 47 in doxycycline, with male predominance, and diabetes status, current smoking status and alcoholic status were similar between 2 groups. Coming to the baseline microbiological status, so all the participants were sputum positive at baseline and HIV status negative, with baseline comparable laboratory parameters including complete blood count, renal function test and liver function test. Coming to the matrix metalloproteinase levels, so in placebo group, there is a mild decrease in circulating matrix metalloproteinase level. So whereas in doxycycline group, there is a mild increase in matrix metalloproteinase level at the end of 4 weeks. So, however, the between group difference was not statistically significant. Coming to the sputum positivity status, so all the participants were sputum positive at baseline, and at the end of all the participants who have completed follow were sputum negative. Only 2 participants in the placebo group and 3 participants in the doxycycline group were remained sputum positive. That is, they were scanty positive at the end of intensive phase. So, it was not statistically significant between 2 groups. Coming to the SGRT quality of life scale, so this scale actually basically assesses the lung health. So with 0 representing a good health, so as the scores increases to 100, it indicates the worsening of the lung health. So this each bar represents the mean difference from baseline to the end of 6 months. So as we can see a visual difference, though we can see a visual difference here, it was not statistically significant between the 2 groups. Coming to the cavity wall thickness, so which was assessed using lung low dose chest tomogram rather than routine NCCT or HRCT. So we have reduced the radiation exposure to obtain these features, and we can see a significant change from baseline to the end of treatment therapy, end of TB therapy in between doxycycline and placebo group. So the significant p-value of 0.047. Coming to the cavity volume, and this cavity volume, though numerically it was different, there was not any statistical significance between the 2 groups. And the proportion of participants with no cavity at the end of TB treatment were similar between the 2 groups, with 28.6% in the placebo group and 30% in the doxycycline arm, with a non-significant p-value. Coming to the discussion, so our matrix metalloproteinase levels were similar to a study which utilized 14 days of doxycycline therapy. So, however, our study also demonstrated an overall declining trend, but it was not statistically significant. Coming to the sputum status, so which was also similar to a study which utilized the 14 days doxycycline therapy, which indicates that rather than doxycycline influencing the microbiological status, so it influenced only a host immune response rather than targeting the bacilli. Coming to the Sendra's respiratory questionnaire, so we don't have any trials which had head-to-head comparison of Sendra's respiratory questionnaire in their trials. And coming to cavity wall thickness and volume, so cavity wall thickness overall it demonstrated significant difference between the 2 groups. However, we are not able to pick up the significant difference in volume, which demonstrates that cavity volume it requires much more longer time for remodeling compared to that of wall thickness, which can be earlier modulated. I would like to conclude by saying that these features suggest that doxycycline could act as a potential host-directed effect, but further evaluation would be needed with larger sample size. So thus, I would like to say that not only targeting mycobacterium is essential, also modulating the host immune response will also be needed. Thank you.
Thank you, Maheshwari. I'm running outside also. Not sure from your presentation, where was the MFT matter? Was it in serum?
Circulating matrix platform. Yes.
Okay. The problem from the cavity formation, right?
Yes.
Patient developing cavity is not good in the long term also, but you have recruited people who already have cavity.
Yes, sir.
Do you expect with treatment the cavity will disappear? What was the expectation? I don't know, but my
clarification has been expected.
Vomit from cavity, right?
No, sir. It's not prevent. It is to see the resolution of the cavitation.
It is expected that cavity is formed
Yes,
by inhibiting metalloproteinase in the cavity resolved.
Yes,
Is that have been shown, or is that expected from the GPD? When cavity is formed, it is broken down.
Yes, sir.
How do you expect that the cavity will resolve if we integrate metalloproteinase?
It has been seen, sir. Actually, patients with cavities which have been noticed at the end of the treatment therapy, the resolution of cavitation was actually seen.
Normally, also it happens.
Yes, sir.
Okay.
Yes.
So you expect this to be enhanced,
Yes, sir.
which you are able to demonstrate.
Yes, sir.
Normally, whenever we do a drug trial, we will look for
there is an addition of a new drug to the existing
Yes, sir.
medicine. Was there any new adverse effect attributable to, was there any difference with regard to adverse effect?
No, sir. Both the treatment arms showed a similar incidence of adverse events. Most common was nausea and vomiting, so which is even attributable to anti-tubercular drugs.
There was no instances of any adverse effect.
Similar between two groups. There's no issue.
Oh, the randomization done.
Block randomization has been done.
Very sorry, the people there.
4 or
mentioned.
4 and 6 months. Block series of 4 and 6.
Then on the participants with being positive,
Yes.
right? Was the grading comparable in both the groups?
Yes, sir. Actually, it was CB net, sir.
No, but it's also mentioned Spain positive. That's why I want to. Was it CB net or?
CB net positive.
So.
Sputum positive only.
But then you check the PR.
Yes, sir.
So it's likely some of them would have been negative even in the beginning. CB net positive doesn't always mean smear positive.
Yes.
So.
That was actually a drawback, sir, because in
baseline smear and that would have been there, but in your protein from the cavity. Because the lack of significance does not mean more. It's because so it also could reflect on some besides.
Yes.
The convenient sample of significance.
Yes.
Like normally doesn't go very well with the convenient sample. It shows
Whoever I'm able to recruit.
Okay, then you can see there's problem with the way convenient is always never the randomized trial you take the convenient. That's always the bias. Taking any drug interaction of ATT with doxycycline.
Actually, it can doxycycline. Rifampicin can reduce the levels of doxycycline per se.
It's a how do you know actually the doxycycline works because
but it the literature says that it won't decrease that much. Some level decrease can be seen. However, this matrix metalloproteinase activity can be even seen from 40 milligram per day dose also. Antimicrobial dose also can be.
Third thing is the matrix metalloproteinase which represents the changes what happens in the tissue.
That was one drawback, sir, because we won't be able to measure actually what is the matrix metalloproteinase level in the cavity. So that is one drawback.
Yeah, now literally.
Yes, sir. That which because underlying other diseases can also influence this matrix metalloproteinase level.
This stage was
Yes.
So compare the quality of
Yes, sir.
Maybe when you expect people
Sir, this doxycycline, its effect is we are meant to improve the quality of life of the patients, especially by improving the chronic lung health. Whether this doxycycline would have better improvement compared to that of just ATT alone. So that's why we have included. Yes, sir.
Symptoms for improvement or what was because it is a very short period, right?
6 months. This was seen at the end of 6 months, sir. Yes, sir.
Something within 6 months can have been qualitative because they will be safe.
Yes, sir.
The normal TB patients,
yes.
it is symptomatic since at least 2.
Yes, sir.
Really reflect the improvement in the quality.
Maybe other factors will also have influence in this. So we can't solely say it could have influence. Because quality of life, it basically incorporates other nutritional support and social support also. So this just we have added to say whether it had any lung health improvement in patients. But we were not able to delineate with any influence of the nutritional status or
We want a discussion there. Dr. Maheshwari for the excellent presentation. We'll proceed with the next presentation.
Would like to call Dr. Kaushika. Her presentation is on incidence of pulmonary interstitial syndrome using point of care ultrasound in pregnant women with severe fetal of pregnancy.
Good morning, everyone. I'm Dr. Kaushika from the Department of Anesthesiology and Critical Care. I'm presenting title Incidence of Pulmonary Interstitial Syndrome using point of care ultrasound in pregnant women with severe features of preeclampsia. Prospective observational study. Severe preeclampsia is associated with a significant maternal morbidity and mortality. In that, acute pulmonary edema complicates approximately 2 to 8% of the preeclampsia patients. Conventional monitoring such as clinical examination, chest auscultation, saturation monitoring and chest X-ray may lack the sensitivity for detecting these early interstitial changes. The lung ultrasound being a bedside tool helps in detecting these early changes, which is a pulmonary interstitial syndrome, which is a radiological term, which will be defined as a presence of B lines in the lung ultrasound, which detects the subclinical pulmonary congestion even before the clinical symptoms of overt pulmonary edema. So the incidence of pulmonary interstitial syndrome using a lung ultrasound were limited in the South Indian population. So the present study aims to determine the incidence of pulmonary interstitial syndrome and its association with the cardiac biomarker, particularly NT-proBNP. My primary objective is to determine the incidence of pulmonary interstitial syndrome using point-of-care lung ultrasound in pregnant women with severe features of late-onset preeclampsia, which is more than 34 weeks of gestation. My secondary outcome is to determine the association of pulmonary interstitial syndrome with maternal demographic variables, NT-proBNP, ejection fraction, length of hospital stay, and the maternal adverse outcomes. Coming to methodology, the study has been conducted after getting approval from Institutional Ethics Committee and Clinical Trial Registry of India between September 2024 to January 2026. My inclusion criteria is pregnant women more than 18 years of age, gestational age more than 34 weeks, and severe patients with severe features of preeclampsia according to ACOG guidelines. My exclusion criteria is chronic pulmonary disease, chronic renal disease, chronic liver disease, and sepsis. The patients were screened for eligibility and the eligible participants were enrolled in the study. After getting consent, the lung ultrasound examination was performed in the patients, followed by the cardiac focus was performed and the ejection fraction was assessed by the fractional shortening method. Maternal venous sample was collected and processed for NT-proBNP values. The baseline demographic, vitals and the laboratory parameters were noted and the patients were followed up for the adverse maternal outcomes. Coming to sample size calculation, the sample size was calculated based on the previous study, which was by Agni et al., which reported the incidence of 50% with an absolute precision of 10% and 5% level of significance with the power of 80%. The sample size was 97. Considering a 10% dropout, the final sample size was 107. Statistical analysis was performed using SPSS version 20. The normality testing was done by Kolmogorov Smirnov test and the categorical variables were tested by chi-square test and the continuous variables were tested by independent t-test and Mann-Whitney U-test based on their distribution. To assess the association between pulmonary interstitial syndrome and variables, the univariate analysis was performed and to identify the independent predictors, multivariable logistic regression analysis was performed. This was the diagram showing. Initially, we assessed 120 patients for eligibility, 13 patients were excluded. Out of that, 9 patients were less than 34 weeks. 1 patient already diagnosed nephrotic syndrome and 3 patients refused consent. These are my baseline demographic variables, vitals and the laboratory parameters. The mean assessment time of lung ultrasound examination after admission is around 5.3 hours. My primary outcome, the incidence was found to be 13.1%, which is 14 patients out of 107 in our study. And we have also seen the mean NT-proBNP values in patients with PAS group and without PAS group. We have found the significantly elevated mean NT-proBNP levels in the patients with PAS group. And we have also followed these patients for adverse maternal outcomes such as development of acute kidney injury, intrauterine fetal demise, and neonates requiring ICU stay. We found that 71.4% patients had adverse maternal outcomes in PAS group when compared to the 11.1% in without PAS group. So, to find out the factors associated with the PAS, we have run a univariate analysis for all the variables. Out of that, only the significant association only I have shown here. These are the variables which shows significant association with the pulmonary interstitial syndrome. Since we have less number of events, that is only 14 patients had PAS, we limited our variables which enter into the multivariable logistic regression. We entered only the 4 clinical variables which is important, and we out of that we found NT-proBNP is an independent predictor for pulmonary interstitial syndrome, which are with an odds ratio of 1.008. Coming to strength, this was the first study to estimate the incidence of pulmonary interstitial syndrome in a South Indian population and to determine the association between NT-proBNP and the pulmonary interstitial syndrome. Limitation, since it's an observational study, the possibility of observer bias can be there. Detailed assessment of diastolic dysfunction was not performed. Small number of events may limit the robustness of multivariable logistic regression, which requires a large multicentric studies for external validation. 13.1% with late onset severe preeclampsia had pulmonary interstitial syndrome detected on the lung ultrasound bedside. This indicates subclinical pulmonary congestion is relatively common in this group. The incidence was lower than the previous study due to differences in the diagnostic criteria, the assessment timing, and the frequency of assessment and the population difference. The higher NT-proBNP levels were associated with the pulmonary interstitial syndrome, suggesting underlying the cardiac strain. So pulmonary interstitial syndrome with elevated NT-proBNP, we have found those patients had a longer hospital stay and increased adverse medical outcomes. So the take-home point is lung ultrasound plus the cardiac biomarker NT-proBNP may aid in early detection of these kind of patients even before developing the clinical symptoms of pulmonary edema, and perioperative risk stratification, fluid management, and perioperative anesthetic planning. These were my references. Thank you.
Thank you, Dr. Kausika. Now, who will go on the discussion? This presentation, the paper, question. I just want exactly the objectives. To say that this will help in particular person will help in earlier diagnosis of PIS, or how can you say this is early? Without this, it would have been later. Because you don't have a comparison data, but you're taking early, and you say your objective is to see the find the incidence of PIS. And the two specific question, your result is 30%, whereas the data based on which you calculate your sample size is 50%. So, what is the impact of the POS? Otherwise, how many benefits would not have been detected, or without the POS, when focus whether your outcomes would have been worsened? So, because your conclusion does not seem to come from your study, how can you say they were earlier diagnosed? So, had the focus not been done, were they going to be diagnosed much later? Or otherwise, it is a known fact that it will help in diagnosing earlier. But that is not a conclusion from your study.
It's not a conclusion. So I think your study is not to evaluate point of care. No, ultrasound.
No, sir.
So you are just
Finding the
at least by the title it is saying that you are primarily focusing on determining the incidence using this point of care.
point of care.
So stick to that. You just say using this method, this is the incidence. Don't draw unnecessary conclusions like that this is a useful technique, or unless you compare it with that, or say useful in early detection like madam's point. No? Was not designed for that. Fine. So again, this incidence which is detected by this method, we don't know whether it is the actual incidence or is it lower than the expected. All those things in the and was the looking at other parameters, the factors, was it part of your objective or?
The other parameters is my part of my objective, sir. This NT-proBNP and the secondary outcome is to determine the association between the variables and the pulmonary interstitial syndrome, sir.
And what about other studies? Have they highlighted the same thing like
sir, others previous studies have seen serum albumin and brain natriuretic peptide in preeclampsia patients. Previous studies have not established any relation of this NT-proBNP with the pulmonary interstitial syndrome, sir.
So what is the hypothesis? How do you explain this level?
Sir, hypothesis is that preeclampsia patients, due to their pathophysiology, they will be having a cardiac stress due to the volume overload. So which will be detected in the rise in NT-proBNP levels due to the ventricular wall stress. So our hypothesis is that in severe features of preeclampsia, the NT-proBNP will be increased.
Thank you.
I have a couple of questions. What was the timing between your scan and delivery? You have mentioned that. So sometimes it gets too short. After 34 weeks, we go up to 36 weeks, 27 weeks, you might have dimension baseline. At the time of delivery, it's like an increase. Second question, how many of these patients actually have a clinical pulmonary edema?
Out of these patients, nobody has developed a clinical pulmonary edema.
Okay, because of this PIS on ultrasound, did anybody receive a diluted therapy?
Yes, ma'am. 2 patients have received Lasix.
Only
2 patients.
14.
Yes, ma'am.
And what adverse outcomes are you talking about?
Adverse outcomes is like development of acute kidney injury, intrauterine demise, and neonates requiring ICU care because of the pathophysiology of the preeclampsia.
But I'm not sure that's the right kind of this thing you can draw simply because of PIS. That may not be the right interpretation of the PIS being associated with these adverse outcomes. Okay, thank you.
You study the compare this pH with elevated marker and the adverse medical outcome.
Yes, sir.
Statistics that you do.
Yes, sir.
Find a significant p-value.
Yes, sir. The patients with PAS had a higher NT-proBNP levels. They were the group who has developed the adverse maternal outcomes significantly higher than the other group. I mean, like without PAS group.
Not without PA.
In PAS.
Elevated NT-pro.
Yes, sir. In PAS only with elevated NT-proBNP level, those patients only developed significant adverse outcomes, sir.
You have studied severe preeclampsia, but all severe preeclampsia are not the same. Some of them have higher blood pressure, higher dose of antihypertensive, higher volume overload, higher proteinuria.
Yes, sir.
So, is it that the PIS you are seeing and the NT-proBNP you are seeing is just a marker of severe disease,
yes,
and they are not, you cannot attribute relationship between NT-proBNP and you seem to be trying to attribute that these two are related, but then event from both can be related to severity of underlying disease, right? So how we accounted for that? Because basically also I couldn't find, like somebody could have had more edema, more proteinuria, more liver injury, more severe hypertension. How do you account for that?
That part we didn't.
So without accounting for that, how can you assume that or assign a relationship between NT-proBNP and the PIS?
This NT-proBNP can be raised because of the disease severity also.
Yeah, and PIS also those patients having severe hypertension, patients having hypoalbuminemia, they will develop interstitial edema. NT-proBNP may not go up, we don't go up.
Yes.
So that will happen, right?
Yes, sir.
That's why I'm asking.
Next presentation is by Dr. Sangeeta Chera. It's on a comparison of the expedition profile in patients undergoing a supratentorial tumor resection using dexmedetomidine or lycopene infusion. It's a non-inferiority trial.
Good morning, everyone. Myself, Sangeeta. My topic is on comparison of extubation profile in patients undergoing supratentorial tumor resection under opioid sparing protocol using intravenous infusions of dexmedetomidine or lignocaine, a non-inferiority trial. So, anesthesia for intracranial tumor resection mainly aims at providing an optimal cerebral perfusion, adequate brain relaxation, and maintaining a stable intrahemodynamics and rapid and smooth emergence, all of which is needed to provide an early post-operative neurological assessment. Tracheal extubation, which is a crucial step in anesthesia, leads to sympathetic activation, which in turn leads to increase in MAP and heart rate. And it also causes airway irritation, leading to coughing, all of which might lead to disruption of intracranial dynamics. Therefore, achieving a smooth and hemodynamically controlled extubation remains a central objective.
Traditionally, we use opioids to attenuate these airway and circulatory responses, but it has its own side effects like respiratory depression, hypercarbia, and PONV. All of this might in turn affect the cerebral dynamics. So now routinely dexmedetomidine is being used in neuroanesthesia, which is a highly selective alpha-2 agonist, but it has its dose-dependent bradycardia and hypertension as its side effects. In our study, we introduced lignocaine for this supratentorial tumor resection. So the primary objectives of the study are to compare the hemodynamic changes in terms of heart rate and MAP during tracheal extubation and airway responses with cough gradient during tracheal extubation. And the secondary objectives included brain relaxation, intra opioid requirement, intra hemodynamics, emergence agitation, and post-operative pain. The main hypothesis of the thesis is the intravenous lignocaine infusion will provide a stable hemodynamics profile compared to the intravenous dexmed infusion, which would be non-inferior to that. Methodology, it is a randomized control trial, which is double-blinded with a block randomization of 4. In order to blind the treating anesthesiologist, transparent equidosal volume of study drugs was used, which was based on the dilution. Based on a study by Bindu et al., a standard deviation of MAP at extubation was found to be 11 mm of Hg in dexmedetomidine group, with a non-inferiority of a margin of set as 9 mm of Hg, with an alpha error of 5% and power of 90%. Sample size was calculated as 52, and assuming a 10% dropout, total sample size was calculated to be 60. Normality was assessed by Kolmogorov-Smirnov test, and categorical data were expressed as frequency with percentage, and continuous data with normal distribution as mean with the standard deviation, and non-normal distribution as median with interquartile range. And the following tests were used to assess the significance. Methodology on shifting to the operation theatre, standard ASA monitors were attached, and based upon the randomization, they were randomly allocated into group D and group L, and study drug infusion was started. And depth of anesthesia monitoring of CONOX was used for this study. The participants were induced with fentanyl, propofol, and vicuronium, and maintained with sevoflurane with a target of QCON 40 to 60. Scalp block was given with bupivacaine, and 20% mannitol was used for brain relaxation. Hypertension was defined as a systolic BP less than 20% from the baseline and was treated with fluids and vasopressors. And intra analgesia supplements were based on a heart rate, MAP, and QCON values was supplemented with fentanyl 1 mg per kg boluses. During dural opening, brain relaxation score was calculated by the surgeon, assessed by the surgeon, and noted down, and a procedure was commenced. Once the study drug infusion was stopped at the dural closure. After adequate reversal, patient was extubated. During extubation, maximum MAP and heart rate at extubation were noted down, and cough grading and emergence agitation scores were also noted. After shifting to ICU, post-op pain based upon the numeric rating scale and the analgesic requirements in the post-operative period were also noted down. Initially, 65 patients were assessed for eligibility, out of which 60 were randomized and allocated into group D 30% and group L 30 participants. Out of which 2 participants had an unplanned post-operative ventilation. They discontinued intervention in group D, and in group L, 1 had an unplanned post-operative ventilation. Finally, 28 participants were analyzed in group D and 29 in group L. The baseline demographic variables were comparable between the two groups. Coming to the primary outcomes, initially the cough during emergence, which is one of my primary outcomes, around 50 participants in dexmedetomidine group didn't have any cough, and 44.8% in lignocaine group didn't have cough. The overall cough grading, degree of cough grading between the two groups were also comparable. And the other primary outcome, which is the difference in MAP. Difference in MAP was calculated as a MAP at extubation minus the MAP at baseline. It was found to be statistically significant between the two groups, with the difference in MAP in dexmedetomidine group being lower than the lignocaine group, whereas the difference in heart rate were comparable between the two groups. And coming to non-inferiority analysis of the difference in MAP, the mean difference was found to be 5.23, with the upper limit of confidence interval being 8.84, which was less than the preset margin of 9 mm of Hg. And the secondary outcomes like brain relaxation score and intrafentanyl requirements were also comparable between the two groups. The hemodynamics, which was another secondary outcome, in terms of heart rate and mean arterial pressure at various time points, we have confirmed. In comparison of heart rate, during the initial 45 minutes, there was a statistical difference in the heart rate that might be attributed to the difference in onset of action of the infusion drug. And in math, there was no statistical difference between the at various time points. And in post-operative period, the numeric rating pain scores and post-op rescue analytics were also comparable between the two groups. Coming to the discussion, with the primary outcome being hemodynamic changes at extubation, mean difference of 5.23 with the confidence interval lying between the within the upper limit of the confidence interval lying between the previous set margin of 9 mm of Hg, lignocaine was confirmed to be non-inferior. But even though dexmed showed a superior sympatholytic action, that was also confirmed by a study by Luthra et al. Lignocaine provided a clinically acceptable control via the airway reflex suppression, which was also supported by Jain et al. In a study by Luthra et al., cough incidence was there was no cough in almost 80 to 100%, but in our study there was almost 50%. This might be attributed to the drug dosages, timing of a drug given, etc. In Luthra et al., they have given a bolus dose at the time of the dural closure, followed by continuous infusion until the extubation. In our study, we have started at the start of anesthesia and we have almost stopped at the dural closure. This might attributed to the difference in the cough. And in lignocaine, similar results were also produced by Jain et al. In brain relaxation, a satisfactory brain relaxation was obtained in both our groups of dexmedetomidine and lignocaine with more than 80% satisfactory by the surgeons. And it was confirmed by Kaur et al. And Chandra et al. Also. Emergence agitation scores were also comparable between the two groups. And the introp opioid consumption between the two groups were also comparable, which was also supported by McCullough et al. By dexmedetomidine group and Chandra et al. For lignocaine group. Post-op pain scores and rescue analgesia were similar between the two groups over 24 hours. Coming to limitations of study, it is a relatively homogeneous cohort. Like we have included only elective supratentorial tumor surgery of size less than 5 centimeter with full GPS. So generalizing to the other population might be difficult. And direct ICP measurements were not performed in our study. And brain relaxation score was a subjective assessment by the surgeons, which was noted down. And they didn't have any placebo group to compare and generalize the results to other persons. Conclusion, intravenous dexmed infusion provided a better attenuation of emergence-related MAC changes. However, lignocaine infusion was non-inferior for a clinically meaningful hemodynamic control during extubation. Both the drugs ensured a stable intraoperative hemodynamic, adequate brain relaxation, and similar opioid requirements with no difference in emergence agitation of post-operative pain. Thus, intravenous lignocaine is a safe and effective alternative to dexmedetomidine in super.
We open the floor for discussions. I just have one question. How did you arrive at the non-inferiority constraint of 9? Your standard deviation you propose 11, non-inferiority margin 3.
Based on clinically acceptable values only, sir, map, we have set that margin.
Was it based on any studies, like how it clinically?
Based on previous study by that Bindu et al. Only we have taken, so.
In non-inferiorities, you compare it with the placebo confidence interval, and then you will think. And normally there is some consensus to decide that the most critical aspect of non-inferiority trial is not very much. Because they are provider one and then there is no so the justification for the rest of it is fine. But how you justify time really matters.
That was my question as well. So thank you for asking. I have three questions. How was the outcome assessment of cough and all efforts? Was it objectively done or subjective?
Cough was like a treating anesthesiologist who was there in the operation.
Was aware of the mechanism?
No, ma'am. For that we have used drugs. We have given us transparent saline, like it looked like that only. They have made a drug.
These outcomes So, other question was about sample size. It's usually 120 is one-sided. Don't take 0.05, not 5%, it's 0.025. But this half we take one-sided, it's not two-sided. So probably that also is somewhere in basically value of that line and then that is justifying confidently taking one figure. But the small comment is where you said block size of 4, no allocation has been made, or it was blinded. She brought the whenever we use usually different block sizes. you have concluded that ibuprofen is safe. What about the side effects? You have not shown us, was there any adverse?
During introps, we have actually noted down any bradycardia events or hypotensive events. It was also comparable between the two groups, and overall incidence of hypertension was lower, man.
You seems to have used a different regimen for the industry compared to the other studies.
They have given a loading dose followed by infusion, sir. We have avoided loading dose.
Expect the anti similar to those studies, right? Or the regimen used is different.
Yes. But the previous studies, no studies with the only lignocaine, like only dexmer infusion. There are no previous studies, sir. Most of the studies they have given either bolus, only bolus, or bolus followed by infusion.
See, the dosing regimen have an impact on the.
Yes, based on the dosings, if a higher doses have a significant bradycardia and hypertension in dexmedetomidine.
You have used a lower than standard dose compared to the lignocaine.
Not the standard doses like 0.2 to 0.7 mics per kg per hour for dexmedetomidine infusion, sir. We have taken around 0.5, which is not too higher or too lower to accept the.
You also something about the duration. You thought that
We started at the starting of surgery and we stopped at the dural closure, sir. In our previous surgery, they have given just before extubation, like 5 minutes before extubation, or at the time of the dural closure.
For a longer duration.
So the effects were a peak at the time of extubation. The results were good for extubation, but introp fentanyl requirement and we have some other advantages by giving it from the start of the surgery. Thanks.
Next, I'd like to welcome Dr. Nitish Kumar Jawaharlal. The topic is on the agreement between intraoperative frozen section and final paraffin embedded histopathology in ovarian adnexal reporting and data system, ORAD, greater than or equal to 3 ovarian tumors.
So very good morning to one and all gathered here. So I'm Dr. Nitish from the Department of Obs and Gynae to present my study titled Agreement between Intraoperative Frozen Section and the Final Paraffin Embedded Histopathology in Ovarian Tumors of ORADs of more than or equal to 3 ovarian tumors. So ovarian tumors may vary from a simple benign cyst to a frank malignancy. Likewise, the management also will change from simple cystectomy to extensive staging. This imaging has to be done for the preoperative assessment of the ovarian tumors to classify them as benign, borderline, and malignant. Although imaging and so the clinical evaluation help us, the full extent of this is not sure. So intraoperative frozen section plays a role in this. However, histopathology may be the gold standard of the evaluation of benign or borderline or malignant tumor. So the role of histopathology in intraoperatively to define the extent of surgery is practically nil. So various studies have been shown that the efficacy of the agreement of ovarian agreement of ORACs, agreement of frozen section is around 80 to 90%. However, all of the studies were done in unselected ovarian tumors. In this study, we have selectively taken ovarian tumors of ORACs more than or equal to 3. So the primary objective is to assess the agreement between intraoperative frozen section and the paraffin embedded histopathology in ovarian tumors of ORACs more than or equal to 3. And we have used a cross-sectional analytical study design. And the study population included all the women coming to our JIPMER with ovarian tumors. And we have included adult women with ovarian tumors of more than or equal to 3 who underwent surgery in the department with intraoperative frozen section as well. So the study duration was for 2 years with sample size of 49. So as it is an agreement study, we have calculated the statistical method using the Cohen's-Kappa method with expected agreement of 80% and the significance level of 0.05. And we have used power of 90%. With this, we have come to the sample size of 49. As mentioned earlier, all the consented women with ORADs more than or equal to 3 on ultrasound were subjected to eligibility assessment and workup and were intervened with surgical management with intraoperative frozen section, and the sample remaining was analyzed with final histopathology report. With this report, we have statistical analysis has been made. So the continuous variables such as age, CA125 and the tumor size, which were like normally distributed, were summarized with mean plus or minus standard deviation. And this normality testing was done using a KS testing and a Shapiro-Wilk test. And this categorical variables such as intraoperative assessment of the tumor was like summarized with frequency and percentage, and the group comparison, which were like categorical variables, were assessed with a Fisher, Freeman, Halton test, and the group comparison of continuous variables was done with like Mann-Whitney U test, and agreement analysis was done with like Cohen's kappa, and and so the diagnostic performance of each category was done with sensitivity, specificity, and the positive predictive and the negative predictive value. So the software used for SPSS and the significance was p-value of so upon the results, so the baseline results showed the mean age was around 48 years, and most of them were multiparous women. Among the ovarian tumors, like around 50% of them were ORADs of 4. And upon the surgical profile, the planned surgery was like staging laparotomy in most of the cases, and the most common final procedure done was TAH BSO plus omentectomy. The agreement analysis showed, so the Cohen kappa of 0.714 with an observed agreement of 81.3% and expected agreement of 34.4%. This it is interpreted as a substantial agreement. And while discussing the category specific performance, so there were 20 cases which were reported as borderline in the frozen. 20 cases were reported as benign in the frozen section, of which around 17 were actually benign and 3 were actually malignant in the final paraffin histopathology. And in the borderline cases of 13, which were reported as borderline in frozen section, 1 was benign, 8 was actually borderline, and 4 were actually malignant in the final histopathology. Of the malignant cases of 15 in frozen section, only 1 was borderline, and all the 14 were actually malignant. So this slide shows the diagnostic performance of the frozen section across the various tumor categories. This shows that the benign tumor group has got a very good sensitivity, specificity, and accuracy of 89%, and borderline tumor has got a positive predictive value of only 61.5%, which is expected from the previous existing literature. Although the sensitivity and specificity is good, and the malignant tumors has got a very good positive predictive value of 93.3, although the sensitivity is only 66.7. And we have combined the borderline and the malignant tumor as a separate category, as these subgroup is very important in the intraoperative surgical decision making. And all these variables such as age, parity, and menopausal status, all these variables were analyzed using a univariate analysis to see whether there was any impact of these variables on intraoperative frozen section, and found to be it is not statistically significant. And impact of surgery, 3 cases which were found to be benign in intraoperative frozen section were actually downstage to avoid unnecessary extensive staging procedure, and almost 14 cases we have upstaged to avoid to avoid second surgery for staging. We have operated in the same setting. So actually there was overall this impact was in 17 cases. Although there was although there was a very good impact, so there was observed discordance of 20.4%. So this shows that integration of frozen section findings with pre-operative ORADS classification and the patient-specific factors such as age, fertility, desires, and comorbidities. With all these things, we have to make an individualized surgical decision making. I have listed a few landmark studies which I have quoted, and as you can see, all of them has got a very good accuracy of 80 to 90%, but our study has got 79.6. This shows that all of the studies were so they have taken ovarian tumors as a whole. It was not unclassified, but we have taken image defined high risk cohort, and the borderline focus was there. So I conclude with I conclude with the overall concordance of 79.6 with kappa of 0.714, and impact of surgery was in 34.7%. Thank you.
Open the floor for discussions.
So mention that important 50%, right? Would it have had any clinical impact on the patient or based on that, did the outcome of the patient?
No, sir. Actually, we have integrated, as mentioned earlier, we have integrated the fully about the patient profile and intraoperative findings of the surgeon and everything. And all these 20% discordant cases, it was, it has not impacted on the surgical decision making.
The same pathology is getting covered.
Same pathologist.
Yes,
sir.
So as far as I understand, your plan is that based on this again in future, on frozen section itself, you take a position to stage the disease.
Yes, sir.
So whether you need to do an
Extensive surgery or simple cystectomy will be
That's the
sufficient.
plan.
That's the plan.
So if that is the plan, then when you get what you said is any of the cases you either revised or even went. So how did you do that? Because that's not the gold standard when you were doing this one.
Yes, sir. So that's why we have done agreement analysis only as of now, where we are just comparing the frozen section in final histopathology.
Nobody says if you actually did not downgrade or did not do it, in some cases you actually went ahead.
Yes, sir.
When you're not, so when it's not, it is still in the, let's say, experimental. So how do you take a decision based on that?
Again, we have integrated everything, sir. This adds on as in we find it, we assume it to be malignant, and it proves so that we can with much more confidence.
You're still doing this.
That's what, sir. We are operating, and intraoperatively we assume it to be a malignant case, based upon the intraoperative findings about the solid, about the consistency of the tumor, and we already have a thought. Okay, so this might be a malignant tumor, and we are sending for frozen section. And if it turns out to be malignant, we go confidently. It is an add-on.
Yeah. What you're talking about is a clinical decision, right?
Sir.
But that's not tantamount to a proper research. You're talking about a clinical decision, right? I understand what you're saying. That you saw that and you upgraded all because that's a clinical decision thing. But that's not a research, right? Here you want to compare two methods. You want to see the concordance between what is the frozen section and what you got by histology.
Yes, sir. That also we have done, sir.
No, I understand, but the way you can see that's a clinical decision and not a research. So that's the point number one. And it's important to specify what was the area which was common. Where the mild ones give you, because it's only the mild ones, then it's acceptable. But if it was, the biopsy histology says it is high grade and given,
Yes,
that is not acceptable. So even if there's discordance, what sort of discordance?
Yes, sir. Whatever you are told in case of this benign tumors, 20 were actually benign in frozen section, but out of 20, 3 were malignant. But intraoperatively, we found, we suspected it to be malignant. Yeah.
Comparing frozen with it.
Yes, sir.
So basically, even if the 3 malignant you're missing, that means you are missing. That's more significant. The discordance is more important.
Discordance is more important.
Rather than it saying it's malignant in terms of the beginning.
Yes, sir.
So that's the point.
So one answer, indirectly, how many cases frozen help you change a pre-operative decision?
Around 17 cases, ma'am. We have planned for TAH, BSO in 3 cases, but in frozen section, it turned out to be benign. So we have downstage with only cystectomy in these 3 cases, and the final histopathology also turned out to be benign.
Okay. Okay, that's very interesting.
Thank you.
Our next presenter is Dr. Sharat. Our next presenter is Dr. Sharat. He is presenting on head-to-head comparison of PCA, SSCI, and 18F FDG PET C2 in treatment-naive non-small cell lung cancer or prospective comparative study.
Good morning all. I am Dr. Sarat from the Department of Nuclear Medicine. I am going to present on my topic head-to-head comparison of gallium FAPI and F18 FDG PET-CT in treatment-naive non-small cell lung cancer. It's a comparative study. So lung cancer is a leading cause of cancer deaths with non-small cell as the most common type. 18F-FDG is the standard tool for staging lung cancer and for response assessment. It utilizes the Warburg effect, which is a key metabolic hallmark for cancers. FAPI is a new molecule utilizing cancer-associated fibroblasts It specifically targets the stromal component of the tumor, which constitutes roughly about 90% of the tumor mass. Over 90% of epithelial carcinomas manifest heightened FAP expressions in stromal fibroblasts. The aim of my study was to compare FDG and gallium FAPI in evaluating the primary tumor, distant mets, and lymph nodes in baseline non-small cell lung cancer patients. So the lung cancer patients which were referred for PET-CT scans, if were treatment naive and eligible as per inclusion and exclusion criteria, were recruited. So a total of 34 patients were recruited who underwent both FDG as well as FAPI PET scan in a span of 1 week. So FDG PET scan required 6 hours of fasting and a fasting blood glucose of less than 200. A dose of 1 millicurie per 10 kg body weight is injected, and scans are required 50 to 70 minutes post-injection. On the other hand, FAPI does not require any specific patient preparation, and a less dose of just 2 to 3 millicurie is injected, and scans are again acquired between 50 to 70 minutes, and a low dose CT was used. The gallium FAPI was prepared in-house using our own automated synthesizer, and the radio labeling was done in-house. Visual interpretation was done as follows. The lesions with uptake more than the mediastinal blood pool were considered positive. Quantitatively, the number of lesions were measured. SV max, or the tracer uptake, and tumor to background ratio was measured and analyzed using paired t-test, and TNM staging was performed in the 9th edition of AGCC. There were total 34 patients with mean age of 59.3, 76% being male and 24% being female. 64% had adenocarcinoma, 32% had squamous cell, and roughly 3% had poorly differentiated. So these are some of the interesting cases which we found. So on the right side, we can see gallium FAPI PET scan, where we can clearly see how much more metastatic, pleural metastatic lesions are being seen here. Also, the skeletal mets are also clearly visualized in gallium FAPI scan, not as much in FDG PET scan. In another case, with a patient with liver mets, more number of liver metastatic lesions were identified with intense uptake. An extra mediastinal lymph node was also identified, which was missed in FDG, and the skeletal mets also had higher uptake. This is the scapular lesion and femur. This was an interesting case where a patient presented with unsteady gait and was evaluated to have lung cancer with brain metastasis. The FAPI PET scan clearly delineated the metastatic lesion in the cerebellum, whereas due to high background tracer activity in brain scan, FDG was not able to localize it. In this case, FAPI was able to localize a solitary metastatic lesion in the pelvis, which was not picked up by the FDG scan. Interestingly, the patient had benign physiological uptake in the stomach in FDG PET scan, which is not due to cancer. It is a physiological tracer uptake. Another interesting case where a new rib lesion was identified in FAPI PET scan. Intense adrenal metastasis was identified, and a rare intraparotid lymph node was identified in FAPI PET scan. This was an interesting case where, due to anemia, FDG shows reactive bone marrow changes, because of which the full bone marrow has low to high grade bone marrow FDG uptake, due to which the metastatic sites which were in bone marrow were not clearly visualized, as you can see here and here. But in FAPI, no such thing is noted, and the lesions were clearly identified in the bone marrow. Okay. This was a case which was a pitfall of FAPI, because patient had a chest wall trauma a few days back on the chest. The chest pectoralis major muscle had intense FAPI uptake. Also, this patient had a uterine fibroid, which was clearly very avid in the FAPI PET scan, not in FDG PET scan. Oh. So coming to the statistical results. First, we evaluated the number of lesions. These are the number of lesions in lymph nodes, bone, liver, pleura, adrenal, and brain by FDG PET scan. And as clearly seen in FAPI, almost in all of the systems, more number of lesions were identified in all of these areas. The SCV max comparison, or the tracer uptake comparison, was as follows. In almost all the areas, higher tracer uptake was noted in the primary lesion, lymph nodes, bone, liver, and pleura with statistical significance. But in adrenal and lung metastasis, the statistical significance was not there. Tumor to background ratio was also significant in almost all the areas, including adrenal metastasis, because of low background tracer uptake. Only in lung, it was not statistically significant. An interesting thing which we noted was a clinical impact of FAPI PET scan on staging. Nearly 15% upstage, FAPI upstage, 15% the end stage, and 18% the M stage, and 15% the overall TNM stage of the patients. That was an interesting finding. Okay. So what is FDG PET scan? It is very important to do FDG PET scan in lung cancer because it is important for response assessment, staging, and recurrence evaluation. However, it is dependent on cyclotron. We cannot produce it inside in our hospital. It requires fasting. It is suboptimal in detecting brain metastasis, and it has intestinal uptake because sometimes when patient has metformin. On the other hand, gallium has some practical advantages like in-house preparation of gallium using a generator, no need to depend on cyclotron, no specific patient preparation, no fasting, not requiring sugar control, very low background tracer uptake, and no physiological brain or intestinal uptake. In our study, we found out that FAPI PET scan found more brain metastasis missed by FDG PET scan due to high background. It had better tumor to background ratio in liver and adrenal metastasis. Pleural lesions were easily detected by FAPI. It was unaffected by reactive changes in bone marrow. And because of high tracer uptake, it had a therapeutic potential as well. Gallium FAPI can localize in areas with benign fibrosis like uterine fibroids or injured muscles, leading to intense uptake that must be interpreted cautiously. Small sample size was a study limitation for my study, and the lack of pathological confirmation for the suspected metastatic lesion was also a study limitation. To conclude, gallium FAPI outperformed FDG PET scan in detecting metastatic lesions in non-small cell lung cancer patients and improved tumor staging. It offers therapeutic potential for metastatic cancers, especially in chemotherapy refractory cases, and it is patient convenient and more accessible due to its on-site production. And finally, impact in our department. Based on these results, our department is planning to incorporate gallium FAPI PET-CT in routine clinical practice for baseline staging of lung cancer. Further prospective studies are being planned to evaluate the role of gallium FAPI PET-CT in treatment response assessment as well as follow-up. These are my references. Thank you.
Thank you.
Have mentioned FAPI has related more metastasis. Yes. But like have you already mentioned as well? How do you know they are genuine positive or could there be false positive signals? How do you address that issue? Because that will decide the outcome of your study, whether it's useful or it's negative reverse.
Yes, sir. So we not just saw the per se PET scan per se, but we evaluated with the CT component as well. So if the CT and the PET were correlating towards each other, basically a lesion was there in CT scan as well as the FAPI was having an uptake, we considered them as positive.
Have you
Yes.
done that analysis in your?
Sir, we not like that, but the scan was interpreted like that. If positive was there, we just not took it as positive. There should be some lesion present there.
If you check with patient outcomes or patient symptoms, do you have any comparison available in that?
Ma'am,
The treatment method of this patient?
not currently we have not done like that for a patient response, but we are planning to do that. We are planning to incorporate AI and radiomics in my study and evaluate on the patient outcome as well. Currently, we have not done.
About this, is wanting to not use anywhere or is it not approved for this sort of purpose? Are you using it for the first time? Usually is very first time or what is it?
Sir, in JIPMER, it is being used very recently, but in India only it is being used as a research molecule. However, there are centers which they are using it as a baseline staging as well. But as of now, not many studies are there to fully incorporate into the clinical portion to evaluate to put it into clinical practice. But still, I know that many hospitals are using it.
Thank you. Call upon our next presenter, Dr. Jawaharlal. A topic is on diagnostic accuracy of airway elastography of even now for peripheral neuropathy among diabetic mellitus patients.
Good morning, everyone. I am Divya Bajaj from the Department of Radio Diagnosis. Today, I'll be talking about my study, Diagnostic Accuracy of Shear Wave Elastography of Tibial Nerve for Peripheral Neuropathy among Diabetic Mellitus Patients.
So, diabetes mellitus is a significant public health problem with steadily increasing prevalence, and it has significant long-term complications. Peripheral neuropathy is one of the most common chronic complications of diabetes, and it affects up to half of the patients during their disease course. And nerve conduction study is the standard of diagnosis for diabetic peripheral neuropathy. It can be time-consuming, though it is painful and may fail to identify early or small fiber neuropathy. So, shear wave elastography is an advanced ultrasound-based technique. It evaluates tissue stiffness by measuring the response to mechanical stress. Basically, it is combining imaging with virtual palpation. And in patients with neuropathy, there is increased fibrosis, edema, axonal degeneration, which results in increased nerve stiffness. So, when we are doing shear wave elastography, it provides quantitative assessment of the stiffness, and it is comfortable to the patient, and it can be easily integrated into routine ultrasonographic examinations as well. Coming to the primary objective of our study, it is to assess the diagnostic accuracy of shear wave velocity and elasticity of tibial nerve for peripheral neuropathy among diabetes mellitus patients. And the secondary objective is to assess the diagnostic accuracy of tibial nerve cross-sectional area. Coming to the methodology, we selected patients from participants from endocrinology OPD. There were two groups. The first group was type 2 diabetes mellitus patients who had clinical features suggestive of peripheral neuropathy, and their NCS was also positive. In the second group, we had type 2 diabetes mellitus patients who had no features suggestive of peripheral neuropathy, and their NCS was also negative. 44 participants were selected in each group, and then their shear wave elastography and cross-sectional area was measured. Patient positioning was as follows. Patient was lying supine with limb in neutral position. Then slight plantar flexion and external rotation was done to expose the medial malleolus. Tibial nerve was evaluated 3 centimeters proximal to the medial malleolus. First, the cross-sectional area measurement was done using 8 to 24 megahertz linear array probe, and then shear wave elastography was evaluated using 311 megahertz linear array probe. Here we had put 2 mm region of interest within the elastography window, and then shear wave elasticity and velocity were evaluated. We'll be seeing a few cases. So the first case is a participant in group 1. The patient is a type 2 diabetes mellitus patient with peripheral neuropathy. Here we can see that. So here we have measured the cross-sectional area of the nerve in the transverse axis, and in the above two figures, we have seen the nerve in the longitudinal axis. The green color is a reliability map. The H above shows that it is high reliability. So here in this figure, we have measured the elasticity value, and in the next figure, we have measured the velocity value. In this patient, the average elasticity is 30.03 kilopascal, and the average velocity is 3.16 meter per second, and the average cross-sectional area is 80 millimeters square. Coming to the second case, this participant is from group 2. Here, the cross-sectional area is measured, and the mean cross-sectional area is 7 millimeters square. Similarly, the elasticity average is 8.64, and the velocity average is 1.7 meter per second. Coming to the result. In our study, both the groups were comparable for age, gender, duration of diabetes mellitus, and the glycemic status. However, the proportion of patients who were receiving insulin therapy was significantly higher in the first group compared to the second group, which probably reflects the more advanced disease severity in the first group. Then we did within group comparison for right and left tibial nerve elastography values. Using pair t-test, there was no significant difference between the elasticity parameters. The p-value is greater than 0.05 for all the three parameters for elasticity, and it is greater than 0.05 for all the three parameters for velocity as well. Now coming to the comparison of shear wave elasticity, we evaluated 3 parameters, that is the mean, maximum, and the minimum elasticity. There was significant difference between the two groups. The p-value is less than 0.05 for all the 3 parameters. Similarly, for velocity, the p-value is less than 0.05 for all the 3 parameters. That is the mean velocity, maximum velocity, and minimum velocity. Based on the data that we acquired, ROC curve was generated. Here we can see that this is the reference line for 0.5. So here we can see that the area under the curve was 0.811 for mean elasticity, and it was around 0.79 and 0.77 for maximum and minimum elasticity. Similarly, for velocity, the highest area under the curve was the mean velocity parameter. Based on the Udens method, sensitivity, specificity, and predictive values were calculated. Based on the cutoff was found to be 18.729 kilopascals for mean elasticity and 2.491 for mean velocity. The sensitivity and specificity were similar, 70.5 and 88.6% respectively, and the positive and negative predictive values were 86.11 and 75% respectively. When we compared the cross-sectional area of the tibial nerve, there was no significant difference between the two groups. So the area under the curve values that we have got here, approximately 0.81 for both mean elasticity and mean velocity, they fall within the good diagnostic performance range. That is, shear wave elastography has good discriminative ability in distinguishing neuropathic from non-neuropathic nerves in diabetic patients. The observed sensitivity and specificity here suggest that shear wave elastography has particular strength at ruling in neuropathy because of its high specificity and positive predictive value, but it still maintains acceptable sensitivity. Shear wave elastography measurement can be influenced by factors such as the ultrasound platform that we are using, the probe frequency we are using, imaging depth, ROI, placement, acquisition settings. So we have to consider this technical limitation that we cannot use our cutoff values with other machines or other institutions before doing any local calibration. So we included both elasticity and velocity as shear wave elastography parameters, which facilitates the comparison with the existing literatures that are reporting either metric. A formal reproducibility assessment of elastography measurements was beyond the scope of the study. Furthermore, we did not do detailed correlation analysis between individual NCS parameters and elastography derived values. The findings support the potential incorporation of tibial nerve elastography as diagnostic pathway for diabetic peripheral neuropathy. It is feasible, patient-friendly, and informative modality, and it may enhance early detection and assist clinical decision making, particularly in centers who are already equipped with modern ultrasound machines like JIPMER. Thank you.
Thank you, Dr. So it's open for discussion now.
Some arm where we studied where people who didn't have any symptoms and the NCS was normal.
Yes.
So they didn't have any symptoms or anything for the straight neuropathy. Why was the NCS done?
Because NCS is the reference standard, we wanted to be sure that patient does not have any neuropathy when we are keeping it at the moment.
To control, you actually did an NCS on
Yes.
And you have studied tibial nerve. So why tibial nerve?
Sir, previous studies have also been done on tibial nerve and medial nerve. For the simplicity of our study, we included one nerve, tibial nerve. It is superficial nerve. It is easily accessible on ultrasound.
And NCS showed abnormalities to the tibial nerve or what was it like? The NCS was done, no?
Yes, sir. Tibial nerve abnormality, NCS abnormality was there.
Tibial nerve
Yes, sir.
abnormality.
Only those patients. We did tibial nerve NCS only for those patients.
NCS is more objective, right?
Yes, ma'am.
Which is
Functional parameter.
what is the time taken for being able to get them? What is the advantage ultimately of elastic?
Ma'am, first NCS was done, then on the same day or by the next
So
day,
that
that will done.
I'm asking you, on an average, what is the time taken for the NCS study? What is the time taken for elastic?
For NCS, it takes around 10 minutes per limb.
Okay.
And elastography takes around 3 to 4 minutes per limb.
Okay.
It all
Is
depends on my speed, how I'm able to find out the real nerve, the ease at which I'm able to do. Because elastography in itself, you just have to pause the probe, make sure that there is no movement, no external compression, and then press acquire. It will generate the map, and from there we have to just acquire the data that
You already yourself mentioned that it needs to be validated whether the reproducibility and both of them are normal measures.
On this study, can you actually conclude on the sensitivity specificity because you have chosen two groups with very clear distinction. One had that community, the other did not have. So, do you need to do further studies to conclude upon research and how good is this diagnostic system?
Ma'am, we have taken two clear-cut groups so that we know that what we are comparing with is normal or not, which we are selecting as a control group. If we want to further make it better, if we want to see with the healthy patient compared to diabetic patient with no neuropathy and then diabetic patient with neuropathy, which has been done in few previous studies, we can consider that also as a
future recommendation.
Okay, so let's get into the discussion. I'd like to welcome our next speaker, Dr. Balaji. He will be presenting on the effectiveness of targeted client communication for self-care of diabetes mellitus and hypertension in Puducherry. This method, the experimental intervention pilot scale.
So, good morning, my president. My title is Effectiveness of Targeted Client Communication for Self-Care of Diabetes Mellitus and Hypertension in Puducherry, a mixed methods experimental pilot study. So, the prevalence of diabetes and hypertension is increasing, and providing conventional care for such a large population is very difficult. There comes the evidence-based digital health interventions, which can bridge the gap. But evidence on digital health interventions is limited in NCDs, but well proven for maternal and child health and mental health. So the objectives of my study are among people living with diabetes mellitus, hypertension, or both, availing treatment from public health facilities in Puducherry to develop targeted client communication using WhatsApp messaging for improving self-care practices to determine the clinical and behavioral outcomes at the end of 6 months intervention in comparison. And secondary objective is to explore the facilitators and barriers for user engagement from patient's perspective. So the study design is mixed methods experimental study. The study duration is 18 months, and the study setting is sensory clinic of selected urban THCs. So the inclusion criteria for objective 1 is people living with diabetes mellitus, hypertension or both, availing treatment from public health facilities in Puducherry and their caregivers and healthcare providers perspective. For objective 2, the intervention group consisted of patients using WhatsApp, receiving WhatsApp-based targeted client communication for self-care. Comparative group is on the standard of care. So for objective 3, participants from the intervention group were chosen. Exclusion criteria, participants with complications were excluded. So sample size for qualitative phase, we selected participants purposefully based on criterion-based maximum variation sampling. 12 interviews were conducted until data saturation. Quantitative phase, since it was a pilot study, 100 participants in each arm were recruited consecutively from NCD clinics. We used interview guides and semi-structured questionnaire at baseline and enrollment. So these are the variables. So here ownership of smartphone means the participant has a smartphone of their own or their family member's smartphone is being used by them. So these are the independent variables, and these are the dependent variables, and these are the operational definitions. Adherence to hospital visits. So visit to hospital within 4 days of the scheduled date will be taken as adherence, and visit adherence of more than or equal to 50% will be considered as adherence. And uptake is defined as accepting the sender, accepting our messages in the first 2 months of the intervention, and engagement is read status of 50% of messages and 50% of the runtime of videos. So data analysis qualitative phase, because then we did the thematic analysis and mapped all the themes and sub-themes to help belief model, and inline interviews were also categorized based on facilitators and barriers. Quantitative phase, we used EpiCollect to collect data, and we analyzed using data. So the descriptive statistics and inferential statistics were done. So we used intention to treat analysis with difference and difference methods. We used DAG to identify the confounders, and regression diagnostics were also looked at. So phase 1 of the methodology was formative research, where 12 interviews were conducted. Message content development and validation was done using Combi framework, and message calendar was developed. So development of the technology platform, we used WhatsApp Business API, and we also pilot tested prior to implementation. So this is the phase 2. So we selected assessed participants for eligibility, and baseline assessment was done for 96 participants in the intervention group and 104 for in the comparative group. Phase 3 intervention, we gave the intervention, and inline assessment is phase 4, where there was 5 to 10% loss to follow up in the groups. And phase 5 is integration with inline qualitative results. So this was the health belief model which we developed with the interviews as part of phase 1. So we used this health belief model and we mapped it to Combi constructs, which is capability, opportunity, motivation for behavior change. So each code we mapped it to one of the three constructs, and we developed messages which were mainly targeting at education and training, action planning or habit stacking, and providing cues or prompts for following self-care practices. So step 2 is content development and evaluation. We developed 33 messages under 3 domains: clinical status updates, treatment adherence, and self-care promotion. So these are tailored communication or targeted communication, both clinical and treatment related messages, and self-care behavior messages were general messages. So next is message evaluation. We used patient education material for assessment of treatment tool for print material, where we did pre-modification, we assessed all the messages, and post-modification, we modified and then reassessed the messages. And message targeting was done with algorithm based on preset parameters and their control thresholds. Message credibility, we included the same header and footer containing the details of the participating institution, JIPMER, and we also endorsed NP-NCD program logo with their permission. So message scheduling, in order to ensure a logical sequencing of messages, we developed a message calendar. Here, till month 2 is depicted. This is the example of the messages. Here, this is a targeted message where the name is here and the blood glucose value is mentioned. And since it's more than the control threshold, the message goes with an into cross sign, and the patient is told to visit the physician for treatment modification. This is the example of a general message having a video link for exercises for knee joint exercises. So step 3 is the development of technology platform. So backend we used targeting algorithm with WhatsApp Business API message delivery. So this is the data flow diagram. And during pilot study, there was a change in WhatsApp terms and conditions which delayed our intervention. And difficulty in approving the templates under utility category was also faced. So baseline sociodemographic details. Gender distribution was statistically different in both the groups. Other variables were comparable. Coming to behavioral characteristics, here we see that all the variables which are statistically significant are better in the comparator group at the baseline. So these are the process indicators. We planned for 48 messages per person. We were able to deliver 40 messages, out of which 8 were video messages. And 88 participants received the messages, of which uptake as our operational definition was 84% and engagement was 75% for text-based messages, and video messages had an engagement of 100%. So we used directed acyclic graph to determine the confounders, which were socioeconomic status, age, employment status, family support, and ownership of smartphone. So inline characteristics, the significant variables were better in the comparator group at the endline also. So this is the difference in difference analysis. So here we have depicted both the unadjusted and the adjusted estimates. So for alcohol use was significant in with an odds ratio of 0.35 in unadjusted analysis, but after adjusting it was not significant. Other variables are not statistically significant, even though there was a reduction in of 2 units of blood pressure in both systolic and diastolic. LDL cholesterol and HDL cholesterol both were statistically significant, but both were favoring the comparator group. So integration of inline qualitative and quantitative results, we saw that there is a marginal increase of 3% of the proportion of participants in the intervention group following physical activity, and the findings are converging. Here in quantitative findings, we see that even though message delivery we could achieve 93%, the engagement was only 75%, which was explained by the qualitative findings owing to dependence of the participants on their family members for viewing the messages. Thank you.
Okay, we can just accept maybe one question.
The outcome of this study, did you get any better favorable response or that you're not good detail?
Sir, we wanted to be focused on having an improvement in the control status of hypertension and diabetes.
Was that achieved?
No, sir. There was no statistically significant difference. It may be due to lack of sample size also, because sample size which we calculated, we got around 566 in 260 in both the groups. But we recruited, since it's a pilot study, we recruited only 100 each.
Thank you. We'll go ahead with the next presentation. Next presentation is by Dr. Hari Ganesh. His topic is on the impact of planned 2 study act cycles on high quality chest compression fraction and point of care ultrasound utilization during cardiac arrest in an academic
Fine, 31. So full sorry. Very good afternoon to everyone. I'm Dr. Hari Ganesh from the Department of Emergency Medicine. So I'm here to present my research on impact of planned 2 study act for the improvement of chest compression fraction and utilization of point of care ultrasound in cardiac arrest patient academic emergency department. So cardiac arrest is a major time critical emergency in which the survival depends on the chest compression fraction and the CPR quality delivered during the cardiac arrest resuscitation. So chest compression fraction is nothing but the proportion of resuscitation time with active chest compression, in which the American Heart Association and ILCA recommends a chest compression fraction of more than 60% and ideally above more than 80%, as the higher chest compression fraction is associated with improved survival. And also the point of care ultrasound used in cardiac arrest helps in identifying the reversible causes of cardiac arrest, which will also help in the improved survival outcome. So coming to the problem statement, even in the trained setups, the CPR quality is often suboptimal because of shallow compressions, incorrect rates, and frequent pauses. And the providers often underestimate the hands of time, leading to low compression fraction, which will affect the survival outcome. And there is no single composite measure to quantify the quality of CPR. So the important thing to note is that, even though there is a AHA or a ACLS guidelines present, the quality of chest compression is often suboptimal even in the trained setup. So coming to the primary objective of my study, it is to improve the chest compression fraction by 10% and utilization of point of care ultrasound by 20% from the baseline in cardiac arrest resuscitation. Here we want to introduce a composite measure, which is called as the high quality CCF, which included the chest compression fractions of more than 60%, along with the high quality parameters such as compression rate of 100 to 120 and compression depth of 50 to 60. So it is a quality improvement study which was done in the Department of Emergency Medicine, which included the patients in emergency with cardiac arrest, and we excluded the patient with a do not resuscitate order. And the analysis was done using an interrupted time series analysis. And the data collection was done using a ladle CPR feedback device, which is associated with an application which showed an objective measures on chest compression fraction, compression rate, and depth. So coming to the study timeline, the study spanned over 22 months, in which the pre-intervention phase lasted 13 months, followed by the implementation phase, where we implemented a sequential PDSA cycle, which is nothing but a planned do study act cycle, which was almost 4, and then followed by the sustainment phase, which was lasted over 4 months. So this is the workflow chart of our emergency department cardiac arrest. The important thing to note is that the primary issue in which the chest compression fraction and focus utilization is affected is in the rhythm analysis and pulse check and during the procedures during the resuscitation area. And we conducted multiple QA meets with the QA team, and we devised multiple PDSA cycles to address these issues in the workflow problem. So this is the image of our QA meet. And then we devised a fishbone analysis diagram, which is nothing but the problems were divided into multiple components, such as the CPR quality and chest compression fraction is affected by people factors such as fatigue during cardiac arrest resuscitation, knowledge variability, skill variability, and because of procedures during cardiac arrest such as point of care ultrasound, defibrillation, and intubation, whereas there is a lack of feedback device during cardiac arrest resuscitation and lack of debriefing metrics, whereas in material there was no proper device cardiac arrest performa with ultrasound protocol, and there was some ergonomic issues were also there in the resuscitation bay, and there was no clear-cut allocation of roles and responsibilities during cardiac arrest.
So similar, the fishbone diagram was also devised for the focus use also. There was no standard ultrasound protocol which was dedicated to the cardiac arrest management. And coming to our PDSA cycle, this is the first PDSA cycle. We focused on the ergonomic support and rapid team mobilization. We introduced a code blue alarm system in the emergency department along with CPR stool for ergonomic support. The goal is to reduce fatigue and improve compression consistency. So this was the code blue alarm which was installed in the emergency department along with the CPR stool which we acquired in the emergency department. And coming to the PDSA cycle 2, the cycle 2 addressed the structured code blue team and documentation which integrating the focus and debriefing metrics. So we introduced something called as the JEM code blue team, the JIPMER Emergency Medicine code blue team, along with the proper device cardiac arrest performer, which included the proper ultrasound protocol, which is nothing but CASA protocol was incorporated, cardiac arrest sonography assessment, and then we introduced debriefing metrics to assess the quality during each resuscitation, which will be done by the CPR coach. So this was the code blue performer JEM code blue team. We introduced one board where each and roles and responsibilities are allocated, which included all the nursing officers and the department junior residents. And this was the exact code blue documentation sheet, which included the proper cardiac arrest documentation data, which included initial rhythm, which included focus algorithm, and all the resuscitation timeline. Along with there was a dedicated space for quality assessment, which will help in the overall improvement of the cardiac arrest resuscitation. So coming to the PDSA cycle 3, this is where the real-time audio-visual feedback was introduced, where we introduced the low-cost audio-visual feedback. This was indigenously made. We made this audio-visual feedback, which will be kept along the bedside, which will be helping the compressor to adhere with the recommended guidelines compression rate. So the PDSA cycle 4, where we introduced a high-intensity training with gamification and simulation, in which a CPR corner we introduced in the residence room, where the people can come and practice their CPR skills, where it was gamified, where we introduced specific course for high quality CPR metrics, and it was graded, and we made sure that it ensures more participation among the residents so that it'll be easy for them to learn the skill and it will prevent skill decay. And this is the baseline characteristics. Both the baseline characteristics, the pre-intervention, post-intervention are comparable. The important thing to note is that there was more non-shockable rhythms in the patients which we seen in both the groups, and there was more in-hospital cardiac arrest which was there. So this is the interrupted time series analysis of my study, in which the x-axis shows the time points at which the study was conducted, and the y-axis represents the primary outcome measures. The vertical lines represent the PDSA cycles in which the implementation of PDSA cycles was done. So as you can see in this high quality chest compression fraction, showed an obvious increase in trend, even the pre-intervention phase. And after the introduction of the PDSA cycle, there was some fluctuation which can be attributed to the cognitive load to the residents. And after the sustainment phase, there was an obvious increase in the high quality CCF. So this was the other components which included the high quality CCF. As you can see, the median chest compression fraction also showed a similar trend. And median compression depth, even though it was not up to the mark in the recommended guidelines, but it showed an obvious increase from the pre-intervention to the post-intervention phase. And coming to the mean compression rate, the important thing to note is that the mean compression rate was almost high, above the 120 level in the pre-intervention phase. But after the PDSA cycle 3, after introduction of the audiovisual metronome, there was obvious decrease to the recommended guidelines of 100 to 120. The one important thing to note here also, even though the chest compression fraction was high, above 80%, the median compression depth and compression rate was low, which indicates that chest compression fraction is not the only measure which will tell that there is a high quality of CPR. So this was the point of care ultrasound usage also, which also showed an improving trend from the baseline phase to the sustainment phase. So this was the objective values where the high quality chest compression fraction improved from 11% to 56.5, which showed 45.5% increase. Whereas focus utilization also increased by 29.3%. So the PDSA cycle significantly improved the high quality CCF and focus utilization. The discussion wise, the metronome optimized the compression rate and focus improved with CASA protocol. And the limitation of the study is nothing but it's a single center study limiting generalizability, and it's a non-randomized QA design with potential confounders and possible Hawthorne effect, because there was an increase in the pre-intervention phase itself, which can attributed to the Hawthorne effect. And long-term outcomes were not evaluated, and CPR depth and ROSC influenced by patient-provider variability, and limited sustainment follows also. These are my references. And one more quote: "Death is not the enemy, but occasionally needs help with timing." So thank you.
We have 2 minutes for discussion.
How many CPRs were clinically successful?
Ma'am, actually, we looked at the proportion of CPR which lost. Almost like 38.9% among the pre-intervention phase included 154 patients were successful. Whereas in this sustainment phase, 72.5% were successful. The problem with this was ROS cannot be attributed only to the provider variable. This can be patient factors which will be affecting the ROS also. So we primarily focused on the process rather than the patient outcome. The study is based on the process. Yes, ma'am. Chest compression fraction showed decrease in trend because the no, ma'am. Actually, the chest compression fraction guideline recommendation is 100 to 120. Due to the anxiety and higher level of acuity in the certain cases, the chest compression rate was high in the initial phase, which was above the recommended range. So to bring down the compression rate to the compression level, we introduced a CPR meter, like the rate device. The decline is what we wanted. CCF also, there was some variability was there. The variability can be attributed to the interventions or the PDSA cycle which we implemented. Because of new cognitive load and new interventions which should be introduced to the junior residents, there was some difficulty in adhering to the protocols. But after the sustainment phase, it showed an obvious improvement.
So fluctuation, but these reasons also taken care of during your meeting.
Yes, one QA meeting we taken care of, but the fluctuations were not that much significant. The y-axis showing 82.5 and 85. It was like almost 0.5%. So this small fluctuation we could not expect to achieve. That was one difficulty with this.
Thank you. Thank you, Dr. Ravi.
Thank you.
We will go ahead with the last presentation for this session. Let's welcome Dr. Prasanna Venkatesh. He will be presenting on the clinical profile and outcome of neuromyelitis optica spectrum disorder.
Good afternoon, everyone. I'm Dr. Prasanna Venkatesh. I'm going to present my paper on clinical profile and outcome of neuromyelitis optica spectrum disorders. Neuromyelitis optica spectrum disorder is a severe relapsing autism and astrocytopathy. It can lead to significant and irreversible neurological disability if it is not diagnosed and treated early. The global prevalence is very rare, actually 0.5 to 4 per 1 lakh, and the Indian prevalence is 2.6 per 1 lakh population with relative higher prevalence in Asian populations. And the Indian data on NMOSD is actually limited, and very few studies has been done after the adoption of the 2015 International Consensus Diagnostic Criteria by Venkatesh et al. And data from South India is actually very scarce. My primary objective is to study the clinical, radiological, serological, and outcome of patients with neuromyelitis optica spectrum disorders, and to study their disability status using the modified ranking score and the change of score on sequential assessment. My study design is an observational study. Retrospectively, I recruited patients data from July 2018 to June 2023, and prospectively between July 2023 to November 2025. And I recruited patients admitted under the Department of Medicine. And depending upon the availability of clinical case records in prospective group and the consecutive sampling which I included in the prospective recruitment, a sample size of 50 was estimated. I included all the patients of more than 18 years of age fulfilling the international consensus diagnostic criteria for the diagnosis of NMOSD, and excluded patients less than 18 years of age and with a confirmed diagnosis of multiple sclerosis, ADAM and MOGAD, and patients with secondary demyelination due to vascular, infectious or other immunological causes. Study procedure: patients presenting with signs and symptoms of demyelinating of central nervous system are initially taken a complete history and detailed neurological examination of them, and all routine investigation is done, and they were classified according to the international consensus diagnostic criteria based on the MRI features and serum and CS of aquaporin status into NMOSD with aquaporin positive and NMOSD without aquaporin positive status or unknown status. And then additional MRI findings were input in the patients. And the first time MRS was documented during their enrollment, and subsequent MRS during their discharge, 3 months and 6 months were enrolled. Statistical analysis: categorical variables are summarized as frequencies in percentages, and continuous variables as mean and median. For the ease of my study, I dichotomized the MRS score into favorable outcome of 0 to 3 and a poor outcome of 4 to 6 because of the small sample size. And I used chi-square and Fisher-Exact test for the association between categorical variables, and McNemar's test to analyze within subject changes in MRS categories, that is between discharge and follow-up. This is the 2015 NMOSD criteria adopted by Venkatesh et al. And this is the modified ranking scale which I used for my study. Results: this is a strobe diagram. Retrospectively, I screened 34 patients and prospectively 36 patients. After applying the inclusion and exclusion criteria, an eligible patient cohort of around 44 was required. And then subjected to the in-hospital mortality of 3 patients, probably because of sepsis, sudden cardiac death, and hospital pneumonia. A final follow-up of around 41 was decided. But MRS in 3 months and 6 months were available for a few, and few lost to follow-up. So final follow-up cohort was 34.
In my study, females were predominant, actually 95% compared to males, that is 5. And the majority of them fall into the category of 21 to 30 years. And between 21 to 40 years, 60% of the patients were there. And the mean age of my study was 32.86 years. Among the patients, the first presenting symptom was limb weakness, followed by blurring of vision, and then nausea and vomiting. Among the presenting complaints, blurring of vision was seen in 68%, limb weakness in 75%, and paresthesias in 56%, followed by nausea and vomiting. Coming to the optic nerve involvement, optic nerve was the most common cranial nerve involved in NMOSD disorders, and the unilateral optic nerve involvement is seen in 57% and bilateral in 42%, with right more than left, and other cranial nerves are infrequently involved in my study. Coming to CSF parameters, among the patients undergone CSF parameters, they are predominantly lymphocytic, and CSF pleocytosis were seen in 52%, and elevated CSF proteins in 73%. Albuminocytological dissociation was present in 55%, and CSF OCBs are present only in 13%. Coming to the accoporin 4 status, both in CSF and serum, CSF accoporin status were available for 10, of which 40% are positive. Serum was available for 42 patients, and 10 were seronegative, and 32 were seropositive. Coming to the MRI findings, optic nerve and LETM are the predominant MRI findings in my study, followed by involvement of dorsal medulla, that is area prostrema, in 31%. Coming to spinal cord involvement, LETM showed a clear predilection of cervical and thoracic spinal cords, attributing to 27 patients for cervical involvement and 19 patients in thoracic involvement. So predominantly cervical was seen in 62% of the patients. This is the 6 core clinical characteristics in the Wingerche criteria, and predominant patients had optic neuritis and acute transverse myelitis as the major manifestations, followed by area prostrema syndrome. Coming to the treatment breakdown, all 44 patients received IV methylprednisolone as pulse steroid treatment, and 72% of them underwent PLEX, and IVIG in 5 and rituximab in 18 patients, that is 40%. And 5 cycles were given for predominant of the patients, that is 19 patients with 59%, and azathioprine was the most common maintenance therapy used in my study. And this is MRS discharge. Predominantly, MRS score of 3 was the predominant MRS score at discharge, that 15 members, that is 34%. And at 3 months and 6 months, majority of the patients improved to a score of 2. This is a comparison of MRS scores with discharge and MRS at 3 months. It shows that there is an overall improvement in the functional status among the survivors. Coming to the gender, male patients are all seronegative. Optic neuritis was more common in seropositive patients, and LETM was more common in seronegative NMOSD. Plex was more commonly required in seronegative NMOSD, and MRS discharge clearly showed a better functional outcome in seropositive patients. And patients who received Plex actually had a greater baseline neurological disability, suggesting that Plex was more commonly used in clinically severe cases. And the higher discharge MRS, that is 25% in the discharge group, indicates that is not because of Plex, it is because of the greater baseline severity for which the patient has been attributed to. Summary, accoporin IgG positivity is seen in 76% and CSF OCBs are seen in 86%. That is a non-multiple sclerosis inflammatory profile. Limb weakness and visual symptoms are more common. MRI, optic nerve involvement and LETM are more common. And all 44 inquired received pulse steroids and 72% with Plex, and rituximab was used in 40%. Azathioprine was the most common maintenance therapy used in my study, and MRS score of 3 was the most common score at discharge. Small sample size and the partly retrospective data and variations in treatment between the prospective and retrospective groups are the limitations of my study. The study provides a contemporary data on the clinical, radiological, and serological profile and outcome of NMOSD. Early diagnosis using accoporin 4 antibodies and 2015 international cancer diagnostic data is very crucial, and misdiagnosing NMOSD as multiple sclerosis may lead to very worse outcomes. Take home, any young woman between 20 to 40 years of age presenting with unexplained blurring of vision, diplopia, and optic neuritis will always raise suspicion of NMOSD. Persistent nausea, vomiting, interactive hiccups without peculiar gastrointestinal cause also should raise suspicion of area prostrema syndrome. And NMOSD is not exclusive neurology disease because patients often present to ophthalmologists, physicians, gastroenterologists, and general practitioners, leading to a potential delay in diagnosis. And there has been a high index of clinical suspicion, and there is no mandated need of CSF analysis, so there is no need of expertise to know the lumbar puncture. Even a simple serum accoporin antibody test can diagnose this NMOSD, and then it can improve the disability and improve the long-term outcomes, particularly in the reproductive age group young women. Thank you.
Thank you.
Was the descriptive study, right? Like, what the additional information from your study which is not already available in the literature? What are the new findings?
Yes, sir. Actually, we thought that the accoporin status, actually, 1894 is the first time this disease was described by using Devika. Later, they thought that it is a variant of multiple sclerosis. They named this as opticospinal MS. And then later only find out that it is different from MS, and they devised the category as NMOSD. But they were not sure that how to diagnose this. Then in 2004 only, they found an antibody called as accoporin 4. Then these criteria all were devised. So they thought that acoparin 4 are very sensitive in these patients, and then CSF OCPs are only 10% positive. So acoparin 4 are very important for diagnosing this. They thought that acoparin 4 will be very helpful in diagnosing treatment modalities also. But all the plex
study designed to see the usefulness of this
not like this. But what is because the plex the decision making mainly the plex what we thought is not attributable to seropositive or seronegative status. It actually is decided by the clinical severity. Even patients coming with optic neuritis who will have a better MRS score comparing to that, they will require more plex sections compared to a patient presenting with limb weakness.
Thank you.
Yes. Do you think if you have had more patients, if you had could you recruit only from medicine?
Yes, sir. Yes, sir. Yes, sir. Neurology
may be seen.
Yes, sir. Predominantly because patients coming to optic neuritis, a young woman presenting with optic neuritis, first of all, go to an ophthalmologist. From the ophthalmologist, basically they used to send serum acoparin antibodies and then directly they refer to neurology. If at all I would have included patients from neurology, I would have get a better sample size.
Do you find anything different from existing this is South Indian data?
This is actually very few data is available only from Lekha Pandit from
It's a description, but the EV profile, the antibody profile are very different from what is explained in literature elsewhere.
One thing what I found out is actually seronegative patients required more plex compared, and then they had an extensive spinal cord involvement. And one thing I recruited patients from 2018. What I found was who were labeled as seronegative in 2018. After subsequent, when they presented different relapses, and every time CSF was repeated and serum samples were sent, some of the patients were labeled as seronegative, later turned out to be MOGAD. That is a different entity totally. So I have 10 patients with seronegative patients. Might have a new marker or someone has been developed. They might also be developed a different group of disease totally.
Okay. So let us end up Julia's presentation. Thank you to all the judges present over there, and the audience and the presenters. I hope you had a nice time. So signing off, Raj. Thank you.
I'm just thinking about this one. Not safe.
No, not that. Wireless.
I'd like to sincerely appreciate the intellectual curiosity of the junior residents amidst the whirlwind of clinical duties. Thank you, moderators, and my heartfelt gratitude to the judges for diligently writing the presentations. As we dive into the third session of oral presentations by postgraduates, the air is thick with fresh ideas and the relentless pursuit of academic excellence. To guide this shift through the vast ocean of intellectual discourse, I warmly welcome the moderators, Dr. Shramana, Ms. Naima, and Dr. Gadhar to the dais. And now, for the heartbeat of our evaluation, please join me in extending a cordial and respectful welcome to our distinguished panel of judges, Dr. Nivedita Nanda ma'am from the Department of Biochemistry, Dr. Hari Venkatesh sir from the Department of Pharmacology, Dr. Deepanjali ma'am from the Department of Medicine, Dr. Murali sir from the Department of Obstetrics and Gynecology, and Dr. Balaji Bharadwaj sir from the Department of Psychiatry. The floor is set, the minds are ready, and let the brilliance begin. Over to the moderators. Good afternoon. Respected Dean Research, esteemed faculty members, distinguished judges, colleagues, research scholars, and dear participants. A very warm welcome to this oral presentation session of the 11th JIPMER Research Day 2026. It is our privilege as chairpersons to lead this important academic segment for the postgraduate scholars of JIPMER. Their research work bridges community and clinic
policy, and practice in science and society. We would like to acknowledge the institution for fostering a vibrant platform where scientific inquiry, innovation, and collaborative research are celebrated with rigor and enthusiasm. A few important instructions before we begin. Each presentation is 10 minutes in total, 7 minutes for the presentation, and 3 minutes for discussion. We will strictly adhere to the time schedule in the interest of fairness and family discipline. A general reminder will be given at 5 minutes, which will be a single bell, and a closure requested at 7 minutes, which will be a long bell. Only the presenting order will respond to questions. We encourage concise deliberations and focused discussions so we can maintain the integrity of the schedule. Now, we feel that district hospitals are being strengthened for diagnosis of epidemic prone diseases with respect to efficient equipment, manpower, and funds for improvement. I invite Dr. Sandhika to present a concurrent clinical study on reporting compliance and operational capacity of private labs in IDSP, IHIP, surveillance launch.
Good afternoon, all. The title of the study is Reporting Compliance and Operational Capacity of the Private Labs to IDSP IHIP Puducherry, a concurrent mixed method study. In the background, according to the Institute of Health Metrics and Evaluation, in 2019, infectious diseases cost about $704 million, which is about 28% of the all-cost dollars. Surveillance is the backbone for the prevention of the infectious diseases. In India, Integrated Disease Surveillance Program was implemented, under which Integrated Health Information Platform as a portal was launched. It captures about 33 plus infectious disease conditions through 3 forms, SP and L. S as the level of the health workers, P as the level of presumptive, at the level of the clinicians, and L at the level of the lab technicians. And the rationale of the study, IDSP that mandates the reporting from the public sector, but it is the voluntary for the private sector. And in Puducherry, 95% of the reporting that comes from the public sector, but only 39% from the private sector. And for the novelty, the study identifies the gaps in underreporting and recommends the strategies to increase the percentage of the reporting, and the main objectives are to assess the current reporting practices and the operational capacity, to examine the barriers and enabling factors. And the methodology, the study design is concurrent parallel mixed method study, and the study period duration is about 1 year, and the data collection period is about 3 months. And for the inclusion criteria, standalone labs, labs attached to the clinics, and labs attached to the multi-specialty hospitals. And for the exclusion criteria, collection centers, centers which are doing only the routine test. And for the sample size, for the quantitative part, approximately 150 laboratories are present in Puducherry. The target is about 1/3. We achieved a target population of 43 labs. And for the qualitative, 8 participants recruited for the in-depth interview, data collected till the saturation. And for statistical analysis, quantitative summarized as frequency and proportion, and for the qualitative hybrid approach was used. This is the methodology study procedure. Convenient sampling was used for quantitative. Approximately 80 private labs were accessed in about 20 out of 40 municipality wards. Each lab visited for 2 to 3 times, and 43 labs were consented. The study tool used was semi-structured questionnaire. Epicolic 5 was used for analysis. Stata 17 software was used. And concurrently for qualitative, through purposive sampling, 8 participants were recruited for the in-depth interview. Interviews were audio recorded and manually transcribed. Hybrid approach was used, and finally joint display was used for integration. And coming to the results, the table 1 represents the social demographic details and the capacity of the labs. Among all the participants, 31 participants hold the degree of DMLC, and one more observation, the participants hold a variety of basic science degrees who are running the labs, and 39 participants from the standalone labs, and 29 labs have no separate data entry operator, and almost all the participants are having a computer in their labs. And table 2 that represents the awareness among the laboratory personnel. Here we can see the declining phase. Only 33 participants have the awareness. Out of that, 26 only have the access to the portal. Only 22 are currently reporting. But 39 participants perceive that reporting from the private sector to the public is very important. And in future, 33 participants are willing to report. And table 3 that represents the barriers in reporting, more than 50% of the participants said that high staff turnover and patients' reluctance for providing the address and the lack of awareness. And table 4 that represents the facilitators, more than 40% needed clear instruction, timely reminder, and direct training classes and recognition in the public meetings. Only 8 participants said the financial incentives are needed.
And coming to the qualitative results, inductive quotes are generated and thematic analysis was done under the major three themes: perception, barriers, and facilitators. These are the categories, and sub-themes and quotes were generated. And for the thematic analysis under the perception, health department tracking and person level detection were notified. And for the facilitators, they need the integration in the basic science and hands-on practice and awarding the top performing labs. And for the barriers, they said staff turnover and lack of communication, lack of gap in the private sector. And all the results are mapped into the combi model, that is the capability, opportunity, motivation. For the physical capability, continuous training and sensitization is needed, and the help from the health department can be given. And for psychological capability, awareness can be created and addressing the patient privacy concern. And for the social opportunity, surveillance topics can be included in the curriculum, and the messages can be shared through the WhatsApps. And for physical opportunity, decreasing the annual renewal burden and lack of standardized tickets. And for automatic motivation, reminder can be sent and incentives can be provided. And for reflective motivation, recognition should be done, and they should believe that reporting should save their lives. And this figure that shows the driving and the restraining forces, the number that denotes the number of times it has been repeated in the IDA. Regular training for staff is needed because there is insufficient training sessions, and curriculum integration is needed because there is a lack of awareness, and incentive-driven participation is needed because low salary constraints in the small labs, and recognition in the labs needed because their work is not even recognized during the pandemic. Free ads to media channels needed because patients' resistance in sharing the details, and mandating the reporting needed because it's still voluntary, and standardization of the protocols needed because lack of confidence in the test results. Area-based personal postings can be given, and communication gap in the private sector can be addressed, and training enforcement in the videos can be done, and difficulty because there is a difficulty in the understanding the first few sessions. Table 5 that represents a joint display as a meta-inference. Barriers are present at the systemic level and even at the individual level. Under the facilitators, capacity building and motivational strategies are needed. And for the discussion, mostly the time-consuming process, this was mostly observed throughout the studies. And only here, the list participants have said that monetary incentives are necessary. Here, they wanted the public recognition. Not all the trained staff are having a proper reporting status. And one more thing, in the initial phases of all the portals like NCD and NICSHE, they have, even though they have the barriers, 85, more than 56% of the people they're willing to report in the future. Here the result is 85%, and 56% is needed training in this so that we can achieve the Vision 2035 Niti Aayog's vision in providing a good public health surveillance. And for the conclusion, despite there is a high willingness, there is a declining phase, and strengthening of the IDSP can be done through periodic training, recognition. And for the recommendation, here majority of the participants were from the standalone labs, so inclusion of the labs at the hospitals can be considered, recognition of the labs during public health meetings, and posters ads can be done to create awareness among the public. And limitation, small sample size, standalone labs, so limited generalizability, social desirability bias may be present, a high non-response rate that shows maybe lower engagement or lesser awareness among the participants. Thank you.
Thank you, Dr. Sangita. This work underscores the need for awareness, training, and collaboration to enhance surveillance coverage. The floor is open for questions.
Thank you, Dr. Sangita. Here, please. Here, exactly. So you said you have chosen 1/3 of the private labs which are present in Pondicherry. So on what basis did you choose these labs? Was it a random sampling, or on what basis did you narrow down to the 1/3 of the private lab?
So actually we planned for a probability sampling, sir, but the problem is we were not able to get the line list, and we done the piloting. I'm able to bring a lot of non-response rate. Nearly approached 80 labs, but I able to complete only 40. So this was able to understand in the piloting stage. So we are not able to cover almost like 100 labs. So we reduced at least 150, 1/3 of the lab can be done at the initial stage.
Based on your
Convenience sampling, sir, because we're not able to get the list that time.
So the study period you said is from February to 2025 to 2026, but the data collection time you said is only for 3 months.
That is the data collection period allocated for NPH, sir. So during that period, so it's nearly 80 labs. You can consider 43 labs into 3 visits and nearly 120 visits, and waiting time is also 2 to 3 hours. So this was happened during the data collection period. So that is why the sample size we restrict to 43. But almost I covered 2/3 of the Pondicherry. Almost all the areas I went and collected, sir. So non-response rate is higher in this.
Suppose based on your study, you want to give a recommendation to the government that if you adopt this particular strategy, there may be more, reporting from the private lab. So which strategy you recommend?
I will recommend one thing is the awareness program, sir, because I'm able to appreciate the around some 5 to 6 kilometers nearer to the DMS, people are aware about the IHIP. And away from the, like 5 kilometers away from the DMS, I can say that people are not even aware about the portal. So they should call upon everyone and they should create the proper training sessions. So that itself can create some awareness, and most of the participants what they felt is they wanted to be recognized in the public meetings or in the portals. They needed some certificate or they wanted to tell their name. So the proper recognition, the motivation strategy and the capacity building as in the case of the training will definitely will increase the reporting percentage. Thank you.
Thank you. I have two questions. Why did you choose to go for in-depth interview instead of focus group discussion? And second question is, in one of the teams that emerged was they did not report because they were not confident of the test results. So we have to highlight on both.
Now, the second one, the confidence part. So most of the participants, what they have said is that typhoid, for testing the typhoid, they're not confident on telling the result. Sometimes it will be positive and the clinicians will call them, it is negative. So because of that, they wanted a standardization of the kits. If some of the tests are very prevalent in Puducherry, they wanted the government to suggest some of the kits so that they can test and confidently they can say that the case is positive. So that is one case, ma'am. For in-depth interview, even accessing this population takes a lot of time. So because of that, everything is not possible. We felt so we went for IDA.
Thank you. We proceed to our next presenter. Thank you. In India, indoor air pollution results in 6.1 lakh premature deaths due to pneumonia, chronic obstructive pulmonary disease, and lung cancer. I invite Dr. Vaishali Chaudhary to present her cross-sectional study on indoor air quality of shops located near roads in urban Puducherry.
Good afternoon to everyone. My thesis topic is indoor air quality of the shop near the roads in urban Puducherry under the guidance of Dr. Palide and Dr. Maharashtra. Air pollution majorly contributes to 8.1 million outdeaths every year worldwide according to the 2021 stats. And nearly 38% of the deaths are attributed due to household air pollution. And it increases the risk of stroke, ischemic heart disease, COPD, lung cancer, and respiratory infection. South Asia region is the most polluted region globally as it goes above the cutoff levels of annual for PM 2.5. These are the recommended cutoffs for particulate matter 2.5, 10, and CO2 by the various organizations. My primary objective was to assess indoor air quality located near the roads in urban Puducherry, and my second objective was to assess respiratory symptoms and lung function among the shopkeepers. I did cross-sectional descriptive study among the 6 streets of the roads by the convenience sampling in urban Puducherry, and shops were located within the 50 meters of the 6 months on the major road. For my secondary objective, shopkeepers 18 years and above were chosen for respiratory illness and lung function parameter. I used clear indoor air quality monitor and in-source questionnaire for respiratory symptoms and spirometer for lung function. My dependent variables are levels of pollution parameters and presence of respiratory illness and abnormal lung function. This is the full chart for my metrology. 6 areas for the urban Puducherry by the convenience sampling was selected. These were JIPMER, JN Street, ECR, 100 Feet Road, Bus Stand, and Valtabu Road. From the either side of the road, the shop was selected by the systematic random sampling. In all of the shops, the indoor air quality monitor was kept, and it was measuring the all pollutants for weekdays. For indoor, 24-hour measurements were taken, and for outdoor, point measurement was taken outside the shop. For my secondary objective, questionnaire among the shopkeepers were taken regarding the structural and the social demographic characteristics of the shops, followed by respiratory symptoms. And spirometry was conducted among 101 shopkeepers. 90 came out to be valid, among which I took the analysis. This is the spatial distribution of the shop in selected 6 streets in urban Puducherry. Now coming towards the result, characteristics of the shop located near the roads. It composed of approximately 28% of the shop was ceramic clothing and hair salon, followed by 22% of the shop were beater, and 25% of the shop had
square feet of area more than 725. Both of the shop included type was closed and partially closed. About 50% of the shop had that, and 42% of the shop had 2 to 3 employees working in the shop. Approximately 50% of the shop had 30 customers visiting their shop daily. We also assessed ventilation characteristics and indoor emission characteristics such as presence of ceiling fan, exhaust fan, AC, and cooking inside the shop. 50% of the shopkeepers used to clean the shop daily with sweeping and mopping. Now coming towards the distribution of air pollutant, here we can see that particulate matter, outdoor particulate matter is higher as compared to indoor, whereas if we see carbon dioxide, indoor it is higher as compared to outdoors. It may be due to the ventilation exchange and air exchange status. Now coming towards the box and whisker plot for indoor 2.5 levels. Here we can see x-axis depicts the streets and y-axis depicts the 2.5 levels. Red line depicts the WHO recommended cutoff for PM 2.5, that is 15 microgram per cubic. The median values of all the street shops are above the recommended cutoff levels. This is the individual data of the shop representing the median concentration of the shop, where color of the bubble represents street and the size of the bubble represents the concentration of 3.5. And 95% of the shop were exceeding the WHO cutoff for PM 2.5 level. This is the line graph depicting the 24-hour levels with the 2 hour of interval. Here we can see two zeniths from 8 o'clock to 12 o'clock noon. And the second peak we can see from 6 o'clock to 8 o'clock in the evening. While coming towards the PM10 levels, here also we can see approximately all of the streets in the shop. So the median level crossed the recommended WHO cutoff for PM10, that is 45 microgram per cubic. And 75% of the shop were above the WHO recommended cutoff. Similar results were seen for the time interval for PM10 as compared to 2.5. Here also the peaks were seen from 8 o'clock to 12 o'clock in the noon and 6 o'clock to 8 o'clock in the evening. When it comes to CO2 levels, here we can see the maximum levels of the concentration of carbon dioxide from ECR and JIPMER were exceeding the recommended cutoff, that is 1000 parts per million. Here we can see ECR, JIPMER and JN Street. Some of the shops are above the recommended cutoff for CO2 levels. The single peak can be seen over here from the 8 o'clock to 12 o'clock. It may be due to the ventilation status and the peak rush hours during this time. Now coming to my secondary objective results, social demographic and occupational details. Most of the participants were below the age of 45 and majority of them were males with the average working hours of 10 hours. So we also assessed total exposure period and I expressed it in the form of the tactiles. The respiratory symptoms, 14% of the shopkeeper had any sort of respiratory illness and 6 to 7% of shopkeeper had bronchial asthma and chronic bronchitis according to the insert question. We took 90 spirometries and 31% of them came out to be had abnormal lung function, predominantly with the restrictive pattern. So in our study, if we compared with the other study, Greece and New Delhi showed the increased level of PM 2.5 levels. And in our study, 14% of shopkeepers had respiratory symptoms, whereas in study conducted in Bhopal showed 4 times higher than the proportion as compared to ours. So I want to conclude that strictly particulate matter and CO2. In all the shops, it somehow exceeded the recommended cutoffs, and there was reduced lung function among all the shopkeepers. So a recommendation from a study will be periodic indoor air quality monitoring should be considered in commercial shop, and shopkeepers regular respiratory health screening should be done in the shopkeepers, and traffic emission control measures should be strengthened in high density areas. These are my references.
Thank you. Thank you, Dr. Vaishali. The study emphasizes need for ventilation improvements and periodic health screening among exposed populations. The floor is open for questions.
It was conducted from September 2025 to February 2026.
Because in parts of India there is something like variation.
Yes, sir.
So if something like that reported the quantity of very big.
Is there any such variation? India?
Seizure variation are very important parameter for indoor air access, but it was not conducted for my study. So it is one of the limitations for my study. Methodological characteristics have to be taken. In other part of the study, for example, in Delhi and all, these characteristics have been taken.
You mentioned that it was 24 hours measure for the outdoor, but outdoor only 1 point is estimate. So what was that point estimate timing and whether it was uniform across all the things?
It was not uniform. Majorly I took the point measurements in the morning when I used to keep the monitor inside. 1 point measurement around 8 o'clock I used to take it.
8 o'clock in all the shots?
No, sir, it was not.
So you will take some diagonal variation.
Yes, sir. So diurnal variation is only for indoor air quality. It is not for outdoor.
You have only a point.
Okay, sir.
Nice presentation.
Thank you, sir.
I envy that you took this on. None of the different part of this work. Anyway. So, few things are there actually. One is when you say most of your 40%, around 20%.
Yes, sir.
They had either asthma or bronchitis.
Not 30%, sir. 6 to 7%.
Yeah. So 6%, these it's just like this are there, temporary respiratory. And disorder in such showed that 7% have asthma, chronic bronchitis, and allergic rhinitis. Right?
Yes, sir.
And 31% had
Abdominal lung function from the spirometry.
spirometry. And the most common finding was restriction.
Restricted.
None of these diseases, asthma, chronic bronchitis, allergic rhinitis, was restriction. How do you justify that?
For spirometry, I excluded the already asthmatic patients, sir.
Still, so, I mean, all of the people who are having restriction, then what was the diagnosis section? So you excluded these.
Yes, sir, I did excluded these participants. All participants had respiratory symptoms. The people who already had asthma, I excluded them from spirometry. So spirometry showed
that 13 out of 9 13 you remove 13, 14, maybe approximately 60 patients you remove. Spirometry was done for 90
participants.
And normal 28 and mostly restriction.
Predominantly restriction.
So who looked at the quality of spirometry?
So we have easy on PC spirometer with it has the grading levels. So according to the grading level, it shows that whether the spirometry is valid or invalid. The person I took was trained for the spirometry.
No, he was trained.
Yes,
and even the machine is trained to say it's a normal. But most common cause for a restrictive pattern is poor effort.
Yes, sir.
So what efforts were taken for making a proper diagnosis? Because that is abnormal.
Yes, sir.
Where you could have this impossibilities confirmed with any of the pathologists.
Okay. Yes, sir.
Because that is a bad thing actually, because most of the patients who are not able to perform get to a certain level, if poor effort is there, it will be shown by system as restriction. Okay? Because if you're not completing your expression totally, so it will come like ratio being higher.
Yes,
if you are obligated, it will be higher than 80%, and that will be shown by machine and by technician as restriction.
Yes.
So I have no doubt on that.
So we excluded those participants. We considered those this as invalid. If they were not able if they were not able to complete the spirometry cycle completely, even with the 3 or 4 trials.
I think you need to review before you want to go for publication.
Yes.
Thank you. Let's move forward. Heavy digital technology use has been associated with suboptimal parent-child interactions. I invite Dr. Janvi to present an analytical study on parental screen-based technoconference and social behavioral abnormalities among children aged 1 to 5 years in function.
Good afternoon. The title of my dissertation is Parental Screen-Based Technoference and Social Behavioral Abnormalities among Children aged 1 to 5 years of Rural and Urban Puducherry, a cross-sectional analytical study. Childhood is a foundational period that shapes any person's adult personality, and the parents' presence and sustained engagement during their shared time with their child is essential for healthy early childhood development. Technoference is defined as interruptions in everyday interactions or time spent together that occur as a result of digital and mobile-based devices. Parent distractions, especially due to smartphones and other devices during their interaction with their child, disrupt their responsiveness and reciprocal interactions. And the compromise in the quality of these interactions can hamper the social and behavioral development of the child. The objectives of the current study are to identify the association between parental technoference and social behavioral abnormalities among children aged between 1 and 5 years of rural and urban Puducherry. It is a community-based cross-sectional analytical study, and the data collection period was between September 2025 and January 2026. The study setting includes service area of JIPMER rural and urban health centers. Study population included parents of children aged between 1 to 5 years. The sample size was calculated to be 294 with a 39% expected prevalence. Study tools. The DISRUPT questionnaire was used to assess the exposure variable, which is technoference. DISRUPT stands for Distraction in Social Relations and Use of Parental Technology. It is a 4-item questionnaire, where the first question addresses preoccupation with messages or notifications during interaction with their child. Second one is for difficulty in staying away from checking screen. Third one is for excessive screen use during parent-child interaction. And the fourth question is pertaining to missed interaction with the child as a result of being engaged on a screen-based device. Each question is scored on a Likert scale ranging from 1 to 6, where 1 denotes strongly disagree and 6 denotes strongly agree. The outcome variable was assessed during the SWYC questionnaire, which stands for the Survey of Well-Being of Young Children. Here, 12 to 17-month-old children were assessed using the baby pediatric symptom checklist, where a score of greater than or equal to 3 on any one of the domains is considered at risk. And for children aged between 18 and 66 months, a total score of more than 9 on the preschool pediatric symptom checklist indicates that the child is at risk for behavioral abnormality. Additional domains that have been assessed on the SWYC includes developmental delay, parent observation of social interactions, and food security, parent depression symptoms, etc. Sampling strategy. Line list was obtained from all the Anganwadis that come under the JIPMER rural and urban health centers. Inclusion criteria includes either mothers or fathers of children aged between 1 and 5 years. They should own a smartphone or another screen-based device and residing in the JIPMER rural and urban service center, health centers. Exclusion criteria includes parents with children who are diagnosed with the neurodevelopmental disorders as reported by parents during their screening visit. Study participants were chosen using simple random sampling. 147 participants each from the rural and urban service areas were chosen. House visits were conducted, informed consent was obtained, and structured interviews were conducted. Moving on to results, 59% of the participants were mothers, and 47% had studied till secondary school, which is less than or equal to 12 standard. 45% were housewives, and 60% of the children resided in extended families. 71% of the household had less than or equal to 2 phones, and 90% of the household had a functional television. Moving on to social demographic characteristics and screen use patterns of children. Half of the children were male and half of them were aged between 24 and 48 months. 65% of children had a sibling, and the mean age of first exposure to screen was 20.9 months. About 81.6% of children had excessive screen time, more than what is recommended by the Indian Academy of Pediatric Guidelines. 92% of parents claim to supervise their child's screen viewing, and about half of the parents viewed screen along with their child. About 56% of parents claim to successfully restrict the child's screen time, and 58% of children were screened to be at risk for behavioral abnormalities. The next pie chart and bar graph show the screen use pattern among children. About half the children had dominant screen to be smartphone and television, while 35% children consumed content only on smartphone. The dominant content consumed was cartoon, followed by short form content and others. Next is the circumstances when the child was viewing screen. The most common circumstances were during mealtime, following when parents are busy in work or other chores. And then the others include before bedtime, after school, to calm the child when the child is crying, etc. Next is the regression analysis to identify association between technoference and screen time of the child with behavioral abnormalities. Here, parents were divided into tertiles based on their technoparent scores. So the scores of all the 4 questions were summed up, and all the parents were divided into tertiles. Compared to low technoparents, parents with moderate technoparents did not show any statistically significant association with their child having being at risk for behavioral abnormalities. But when we compare high technoparents with low children, their children had 1.52 times the chance of being at risk for behavioral abnormalities, and this association was statistically significant. A similar association was seen for the screen time of the child, and here it was categorized again based on the Indian Academy of Pediatrics guidelines. When children had excessive screen time, they had 1.79 times the chance of being at risk for behavioral abnormalities, and again, this association was statistically significant. Other variables that we found significant included the educational status of the mother or father, and the higher educational status was found to be protective with an adjusted prevalence ratio of 0.81. Next is the parental concerns, where 2 questions were asked whether the parent was concerned regarding the child's learning, development, or behavior. And when the parent was concerned regarding the child, there was 1.3 times higher chance that the child was at risk for behavioral abnormality. Again, this association was significant. And when the child was in an environment where adults were regularly indulging in verbal or physical abuse, then the child was 1.36 times at higher chance of being at risk for behavioral abnormalities. Again, this association was significant. Discussion. The current study found that higher behavioral abnormalities attributable to technoparents was observed with a potential dose-response relationship. As low versus moderate, we found an adjusted prevalence ratio of 1.18, and for low versus high, we found 1.52. A similar study was conducted by McDaniel et al. In the United States in 2016, where they found greater technoparents in mother-child relationship predicted behavioral abnormality. However, they didn't find any significant association for technoparents in the father-child relationship. Cost et al. Also conducted a study where it showed that higher behavioral difficulties were seen among parents who used more handheld devices than televisions. One et al. Conducted a study which showed that technoparents was positively correlated with emotional and behavioral problems. However, the scale that they used here is different. It was called the Fubing scale. And Wu et al. Also found a significant correlation between technoparents and problem behavior in children. Conclusion and recommendation. More than 50% of the screened children were found to be at risk for be at risk for behavioral abnormalities in the current study, and about 4/5 of the children had screen time beyond what was recommended by the Indian Academy of Pediatrics guidelines. And hence, incorporation of positive parenting practices is crucial. Hygienic screen use by both parents and children must be popularized and brought into practice. The strengths of the current study are that here we have assessed parental screen use and how it interferes with the quality of parent-child interaction and time spent together. The limitation of the current study is that there may be response bias and social desirability bias, as this is a parent, as the interviews were conducted among parents. This is a cross-sectional study, and only association could be ascertained, no causal inference could be made. And how screen use and other variables independently contributed to behavioral abnormalities in the child was not appropriately assessed. These are my references. Thank you.
Thank you, Dr. Janvi. This work highlights the need for hygienic screen use and mindful parenting practices. The floor is open for discussion. We have only 2 minutes for this.
So I want to ask you, say that about 60% of children are at risk for behavioral abnormalities. How can you attribute it to the technoparents or screen time? It could just be that the population has 60% of children at risk.
Possible, sir, but in our regression analysis, after adjusting for other variables, including the screen time of the child and variables like socioeconomic status and educational status, etc., we found that there was a significant association.
So when you adjust it for variable, but is there any comparative group?
No, sir.
Do you have any historical controls? Are there older studies, 20 years, 30 years back, which they are different prevalence of at-risk children?
Yes, sir. In the other studies that I have seen, the prevalence was much lower. I would say ranging between 38 to 40, but this study has found a higher prevalence.
Parents had concern having higher, the children having higher behavioral abnormalities. I was expecting those who are concerned would be more careful and therefore the behavioral abnormalities would be lesser in those children.
Ma'am, I agree with your this one. But ma'am, I think that maybe these concerns were a result of the child's problem behavior so that is what my thought was on this now.
Thank you. And presentation shifts the lens to mental health services digital era. Telepsychotherapy might come to the aid, ensuring therapeutic continuity and the possibility to reach people who might benefit from psychological support. May I invite Dr. Jawaharlal, President of the Qualitative Study on Stakeholder Identified Benefits and System Gaps in Telepsychotherapy.
Good afternoon, everyone. The title of the study is Stakeholder Identified Benefits and System Gaps in Regulation, Training, and Safeguards for Telepsychotherapy, a qualitative study. Coming to the introduction, the mental health problem has increased in recent years, and with technology innovation, the telepsychotherapy has become common. Even the government of India has initiated telemedicine services to enhance the access of mental health services. However, there is a paucity of studies done on telepsychotherapy experiences, particularly in Indian context. And the objectives of our study are to explore the experiences and perception of mental health professionals on telepsychotherapy, to explore mental health professionals' views on client preference for telepsychotherapy, and to explore the challenges, ethical and professional concerns in telepsychotherapy. Coming to the materials and method, this is a qualitative study with descriptive approach by using one-to-one semi-structured interviews. As the participants were selected across 6 zones of India, that is North, South, East, West, Central, and Northeastern, the study was conducted purely through telephonic or online interviews. And there are 2 major groups in this study, psychologists and psychiatrists. Under psychologists, we have segregated into 2 groups who are majorly online practicing and who are majorly in-person practicing. And under psychiatrists, we have segregated into 2 groups, those who are involved in academic activity and those who are practicing psychiatry in the field. And in psychologists, we have included both clinical psychologists and psychologists who have just done the masters as they are practicing therapy in the field. The final sample size of the study was 40, which is based on thematic data saturation. And this is the flowchart of the procedure. The participants are recruited purposively to ensure the representativeness of all the 6 zones. And the initial participants are identified through online platforms such as Reddit, RHC directory, Nimhansara website, and also through alumni group contacts and research team contacts. And then subsequently, we have followed the snowball sampling. And the interviews are systematically recorded and transcribed verbatim within 7 days. And further, the data was analyzed by using thematic analysis. Coming to the results, the participants were aged between 25 and 37 years, except one participant who was aged above 40. And these 2 tables depicts the distribution of work characteristics of the participants. In total, there are 24 psychologists. Under them, 11 are majorly online and 13 are majorly in person. We have also stated how many of them are clinical psychologists and psychologists. And under psychiatrists, there are total 16 participants. Under them, academic professionals, psychiatric practitioners are of equal proportion, that is 8 participants, 8 each. And here the bar graph depicts the number of participants from each zone of India. Majority of the participants are from southern zone and the rest are from central. And majority of them are preferred using Google Meet as their mode of technology to conduct the online sessions. And this is the conceptual framework of thematic analysis on telepsychotherapy experiences. There are 5 components here in total, and we will be checking out one by one in the following slide. Coming to the therapist benefits, the online therapy enables the therapist to manage their work-life balance easier, particularly among female therapists who has childcare and domestic responsibilities. It also enables the therapist to start independent practice easily, as there is no need for investment for physical office. Coming to the challenges, the major limitation was noted non-verbal cues, as there is a limitation of bodily cues observation due to screen limit. There are instances regarding online sexual harassment and digital stalking too, which makes the online environment unsafe for the therapist. There are payment issues. And coming to the therapeutic environment on online, it is completely different from the in-person, where it is more compartmentalized and where the therapist has much more control over client surroundings. They also stated challenges regarding boundaries too, such as smoking, alcohol consumption, and also unreasonable demands from the therapist, stating that the client wanted the therapist to remind them for every 6 hours for the appointment. When the therapist tried to put the boundaries, the client got angry. If you want to refer the codes, you can scan the QR code, which is given on the slide later. And coming to the client's benefits, the major benefit was accessibility, as there is no geographical restriction, which reduces the time and travel burden. It also enables the flexibility in client's choice of therapists, such as when the client relocates, they can continue the care with the same therapist. Especially for LGBTQ individuals, they find it very easy to connect with queer-affirmed therapists on online. It also reduces the stigma-related barriers too. And coming to the challenges, the major limitation was lack of private space from the client's end, stating an instant that the client was talking about his mother with the therapist, and the mother was standing outside the room and hearing everything. Technical issues, which is both common from both therapist and clients, and network issues and device setup challenges, majorly among the elderly and those who are of low digital literate people. And coming to the ethical and professional concerns, the participant had concerns about unauthorized session recordings, stating that I don't know on online calls whether they are using my photo and doing some AI mostly. So they can make an AI chatbot of my face and prepare their own website and say this is our therapist. They also had confidentiality concerns about telecommunication platforms such as Google Meet and WhatsApp, since they are come under Meta AI. The majority of the participants stated there is a need for training for online therapy, as they have stated that the translation of in-person skills over online is not straightforward. Even the psychotherapy training also lacking, especially among psychiatrists. And there is concerns about data storage too due to Google Drive, since there are recent changes in Google policies and Meta policies. Coming to the regulated gaps and issues, a major of the participants stated inadequate telepsychotherapy regulations, stating that it's only the individual ethics that is keeping any kind of control over it. They also had concerns about lack of verification of therapist credentials, particularly on online platforms, stating that they don't fully verify the qualification of the therapist. They will have a person who's done just 1 or 3 certificate course and they will employ them as a therapist. Adding on to that, they also stated that due to bad experiences with such untrained individuals, it will increase the existing stigma around mental health care, again increasing the gap. And majority of these online websites are run by non-psychological individuals who are from major business background or technocrats who majorly focuses on how to expand business rather than on the mental health care. They sometimes would also appoint semi-qualified, unqualified therapists because they are not themselves from that background, or they don't have the checks for that. Adding on to that, the therapist also had concerns about underpayment, stating that they expect the therapist to give free sessions without any payment, so it makes you feel like your work and your labor is not valued or paid. There are concerns about regarding issues comes up with interjurisdiction, as a few of the participants had clients from abroad too, who are NRA and also international clients, stating that we are not always aware of the health guidelines of each and every country around the world. So coming to international clients, there has to be guidelines, especially in regards to crisis situation and personal referrals. They stated they are having difficulties to how to connect these mechanisms. A participant also stated there is a need for updation of guidance, which is released by enhanced during pandemic period. Adding upon the guidelines, a participant stated that online therapy regulation has to be inclusive. If those guidelines are based on too much qualification, it may sorry. Okay, coming to the discussion will be focused on regulated aspect. Hence, we reviewed the enhanced document which is released during pandemic. We used a policy triangle framework with the current data. Coming to the policy concept. Okay, these are the contents which are there in the guidelines. And the guidelines also stated that it doesn't cover issues beyond the jurisdiction of India, data management issues. Adding upon to that, there are no guidelines for online platforms regarding the qualification. So these are our recommendations. Need for incorporation of online therapy into academic curriculum, safety protocols and safeguard mechanisms for therapist safety risk, mandate transparent disclosure of therapist qualification on platforms, increase awareness among clients about therapist credentials, verification mechanisms to authenticate the owners of the online platforms, and update the existing guidelines for telepsychotherapy. This is our conclusion. Thank you.
Thank you, Dr. This study reminds that training and regulatory safeguards are essential, while telepsychotherapy enhances the accessibility. Let us kindly keep up with the time. We have 1 more minute for discussion.
Most of the people interviewed were young professionals. So there are also old professionals. Like one of the points you raised was about digital literacy. So psychotherapists or psychiatrists who are older, how comfortable they are with digital provision of psychotherapy. So they were not included in the sample. That would be a limitation. They could have them. Where did you get their contact?
We got contacts from online websites like Reddit platform, Nimhan's Raw directory, and this RCA directory, and also through alumni group 2 of the institute, and through contacts of research team. We have contacted them whether they are interested to participate or not. If they are interested, then only I have interviewed them.
And all of them are doing this percentage?
No, sir. No. Only psychology.
Of them are doing?
In psychologist group, all of them are like doing the like except 2 participants, all of them are like doing online consultation. Under psychiatrist, like we have divided into teaching and non-teaching because majority of them don't do teleconsultation. So that age group, that senior faculty you have said, so she comes under psychiatrist.
Thank you. We now invite our final presenter for this session. Gestational diabetes mellitus is a condition specific to pregnancy with long-term complications. I invite Dr. Muhammad Long to present a sequential explanatory method study on postpartum uptake of blood glucose testing among mothers with gestational diabetes mellitus.
So good afternoon, everyone. The title of my study is Postpartum Uptake of Blood Glucose Testing, Associated Social Demographic and Health System Related Factors Among Mothers with Gestational Diabetes Mellitus, Community-Based Sequential Explanatory Method Study, So gestational diabetes mellitus is one of the most common complications during pregnancy. Globally, 1 in 10 pregnancies is affected by diabetes, and nearly 90% of them are due to GDM. So women with a history of GDM have a higher risk of developing type 2 diabetes mellitus later on in their life. As per the American Diabetes Association and the World Health Organization, their guidelines recommended a postpartum glucose screening between 6 to 12 weeks. And our national guidelines recommend a postpartum glucose screening at 6 weeks. Despite these existing guidelines, the studies across different parts of the countries have reported screening rates below 50%. In India, the timely postpartum glucose screening rate ranges between 24 to 79%. So this study investigates postpartum GDM screening rates and provide a context-specific evidence for identifying the gaps in postpartum glucose testing uptake. So our objective is to determine the proportion with uptake of blood glucose testing at 6 weeks of postpartum to assess the association of social demographic and health system related factors and to explore the facilitating and hindering factors to uptake of postpartum blood glucose testing. So our study design is a community-based sequential explanatory method study, and the study participants are GDM mothers registered at 12 selected PHCs of good care. So the inclusion criteria are all mothers with a documented history of GDM whose ages 18 years and above, who have completed at least 8 weeks postpartum and were within 1 year. We have excluded those participants whose phone numbers were invalid, unreachable, and switch off. Our estimated sample size was 254. However, due to time constraints, our achieved sample size was 246. For the sampling technique, we selected a PHC using a purposive sampling. After obtaining line lists of the participants from several PHCs, we have selected our participants using simple random sampling. For qualitative component, we have selected 8 participants for in-depth interview, and they are selected using purposive sampling. Coming to the procedure, we contacted mothers using a telephone at around 8 weeks of postpartum. Each interview lasted approximately for 20 minutes. The participant details were cross-checked with the PHC records for accuracy. Those participants who have not undergone testing were encouraged to do so. For the qualitative component, as I've mentioned, 8 mothers have undergone for in-depth interview. Both were stratified into testing and non-testing components. So the interview was scheduled at the participant's preferred time and location. Face-to-face interview were conducted and the consent was obtained. Each interview lasted approximately for 20 to 30 minutes. So my independent variables were socio-demographic, legal, obstetric, and health system related factors, and the dependent variable were proportion of postpartum blood glucose testing after 6 weeks.
So the analysis was done using a univariate and multivariable logistic regression and were expressed as adjusted prevalence ratio. The interviews for the qualitative part were transcribed verbatim within 3 days, and manual thematic analysis was performed using a social ecological framework. So coming to the results, this is the flow chart which depicts the flow of my participants. So out of 246 GDM mothers, 196 GDM mothers have undergone testing at any point of time after delivery. However, 50 did not undergo testing. Out of these 196, the first test was done by 108 mothers within 6 weeks. And 41 mothers have undergone testing within 6 to 8 weeks. And similarly, 47 mothers have taken their first test beyond 8 weeks. So out of these 108 mothers, 15 mothers have retested between 6 to 8 weeks, and 25 mothers have retested beyond 8 weeks. Similarly, for those participants who have who have got their first test between 6 to 8 weeks, 24 mothers have retested beyond 8 weeks. So this is the table which shows, which answers my first objective. So we've set an operational definitions for the timely postpartum as 6 to 8 weeks. So our findings reported that 56 mothers out of 246, that is 22.7%, have undergone tested as per the recommended guidelines, with a 95% confidence interval ranging between 70 to 28. So coming to the factors which are found to be associated were only age, number of postpartum follow-up, and counselings were found to be associated in the multivariable analysis. However, some of the variables which were found to be associated in the univariate analysis was not found to be associated in the multivariable analysis. Similarly, those mothers whose age are more than 30 years are more likely to undergo testing when compared to those less than 30 years. So coming to my qualitative findings, so we have generated 2 themes. One is the facilitating and the other is the hindering factors. So the most common facilitating factors encountered from our studies were fear of future diabetes, awareness of complication, concern for baby's health, and counseling. Similarly, for hindering factors, lack of awareness, low perceived necessity due to absence of symptoms, childcare responsibilities, and then baby-centered counseling were most of the factors. And then we have categorized the findings based on the socio-ecological framework, as there was a multi-level factors influence. So most of our findings, for the first objective, our findings are more or less consistent with the findings found in different parts of the countries. However, direct comparison cannot be made due to differences in the operational definitions. For the second objectives, some of our factors are found to be consistent with the other findings. However, the one peculiar findings which was found in different parts of the study, especially in Western countries like the null parity, who are more likely to get themselves tested, were not found in our studies. And similarly, for the insulin treatment, our findings have found it to be associated in the univariate but not in the multivariate analysis. So for my third objective, our findings are consistent with the findings across different parts of the country. However, there are a few findings like the case of the OGTT as well as the fear of the needles was not found in our studies. Most probably maybe due to the smaller number of participants interviewed. So in conclusion, postpartum glucose testing at the recommended 6 weeks remains suboptimal. Postpartum glucose testing behavior is influenced by multi-level factors. So we recommend a standardized structured counseling during ANC, delivery discharge, and early postnatal visits. PHC-based tracking and reminder system is required, and there should be a shift from baby-centered to a mother and baby integrated postpartum care. So we recommended training for provider, and then we also recommended influencing family in for counseling.
Thank you, Dr. Normal. The study highlights a need for counseling, reminder systems, and family support to improve adherence. The floor is open for questions.
I've assessed so the 108 and then before these people. The total we mentioned 22% includes anyone who has undergone between 6 to 8 weeks.
Yes.
Regardless of whether they are one more.
We include the retested participants as well.
So if you think that is the ideal,
Yes.
many times mothers in the postpartum period they find it difficult to travel back to birth.
Yes.
So as long as they don't have any symptoms, they may not find it necessary to go for test. So, and you have mentioned something about what advice we can give them. So, do you have a list of 4 or 5 recommendations to make to ensure better adherence?
By doing a qualitative interview, we also encountered like from the participant side, what they suggested was to integrate the I would say the testing with the immunization period. And this was also found in the quantitative part, where most of the mothers came for vaccination and then they get themselves tested. And the second one is like they prefer the home-based testing, collection of samples. And the third one is like they prefer a message reminder more than a phone call. So these was from the participant side. And then from my side, while doing line listing, I've encountered that most of the healthcare providers themselves were not aware of the guidelines, and then there were contraindications in the information. Like some of the healthcare provider informed them to come for testing after 6 months, after 1 year, and some were saying like blood glucose level will subside normally, so there was not any for this.
Which factor was most characteristic among the mothers who went for early testing compared to those who went for late testing? Age. Anything from your interview analysis factors, how many factors you did?
Yes, there were like
Adult age. From what they told the factors?
From the qualitative.
Yes, from the qualitative analysis. Any single point which are common or most striking feature among the mothers who went for early testing versus those who went for late testing?
Actually, this was mostly they got the awareness, they are saying, but then like they don't really know what is the timing for the how to say for the postpartum follow-up was not mentioned. Therefore, most of the participants had to seek counseling and awareness, but then like they were not sure about the time. So most of them reported within 6 weeks because they thought that this was the appropriate time. And then later on, like we did not found any associate factor regarding that. However, counseling was consistently found associated with the testing outcome.
Thank you all. This session has showcased a remarkable breadth of scholarship from surveillance complaints and environmental exposures to parenting in the digital age, telepsychotherapy, and maternal diabetes care. This shows that the public health professionals are shaping interventions, informing policy, and advancing patient-centered and community-focused intervention. We congratulate all the presenters for this scholarly vigor and thank all the judges and audience for your engaged participation. Thank you.
Thank you to all presenters and moderators and for the judges for this engaging session. We'll now have a working lunch from now, and it will be for a couple of minutes only since we are already short of time.
No, it's okay. I think you can all proceed for lunch. And then we will reconvene because the next session also has to start on time. So you can finish the lunch and please join back.
It will be arranged in ground floor cafeteria. Please be back on time.
Next session starts at 2 o'clock. The judges will be here on time. So who was waiting for the innovation session can
Sometimes we might withhold the antidote, sometimes we might give away the antidote. So the results are not same every time. So the innovation principle that I'm trying to propose is a simple tox card screening test, which will be based on a simple biochemistry which we would have learned in our +1, +2, and our basic biochemistry. So it is not dependent on the antibodies. It doesn't require cold chain. It doesn't require any storage, refrigerator, no hyper stuff. There is no advanced technology. It is all the basic chemistry. So here what we intending to do is to detect what class of compound it is, whether it is a opioid-like or sedative-like or stimulant. So this is how the tox card would look like. It is similar to something like urine pregnancy test. So as you can all see, there is a sample for the provision. Provision is made for the sample wells. Okay, and if you are testing it on some patient who has unknown poison ingestion where you're not clear about the history, the toxin name will be designated below. So you just have to see the color reaction. If at all color reaction is happening and visible color change is there, then the test is positive. If no color change is happening, the test is negative. It is as simple as that. So it's all dependent on how actually it works is similar to UPT only. So here there is a sample provision well where you have to take the patient's urine and pour it. Urine will slowly diffuse and there is a reaction zone. In reaction zone, we have a nitrocellulose strip or a paper which will already be pre-coated with a particular reagent and that will be already dried up, laminated and put it in a cassette. So whenever the urine flows and reacts with the reagent zone in the reaction, it will produce a color change. Based on that, the interpreter will know whether the compound is present or not. Of course, as you all know, urine is such a complicated urine matrix. So it will contain a lot of pigments, buffers, proteins also. They might also interfere with the test and give false positive test. So as to decrease that, what we can do is we can watch the test by including the weak acids like chloractic acid, or you can also use diluted hydrochloric acid. If at all clear spot is left behind, it means that it is a false positive test because it's getting washed away. If the color is still prevailing, it means that it is a true compound which is actually present in the patient's urine. So this is all based on the biochemistry, and this is how exactly how simple it is, because you need not have a trained chemist or a trained personnel or technician to do this. It can be done by even a simple, you can train the residents, EMTs, some interns also to do this, because hardly it takes 1 or 2 minutes to complete the test and to interpret it as well. So here, one thing that I would like to disclose is that we are not trying to hit at 100% precision and accuracy, because that's what is not important for us in ED. In ED, such a fast-paced environment, we are more interested in detecting whether the compound is present or not. I'm not interested in knowing what is the level of the toxin so that I will decide upon using the antidote. So for me, drug detection is important, and the speed or the rapidity with which it is detected is also important, because I cannot be losing to afford to lose some 28 to 48 hours just in detecting the toxin. And one more thing is that, mind you, it is not meant for confirmatory purpose. It is only for the screening tool. If at all the screening tool assists the emergency physician in detecting the compound, then you can further send the patient sample to the higher analysis or for further confirmatory assay. So this is all about innovation doesn't lie here in the application of the chemistry. It is all about translating that basic chemistry into bedside clinical testing. So I tell you exactly how this is different from already commercially available kits which are available in the market. There in the immunoassays, they are detecting what compound is present and in what level it is present. Here, emergency physician is interested to know what group of compound it is. For example, marijuana or hashish or charas ganja, it doesn't matter a lot. Opioid or not, that matters to me. And one more thing, if it is alprazolam or midazolam, lorazepam, that also what exact compound it is, it does not matter. Whether it is benzo or not, that will matter. So that is how it will help in detecting the class rather than the exact molecular ID. So because the whole principle is lying on this detecting the molecular moiety. And one more thing is, since it is a screening tool, we will not be using it as a legal proof, because the legal proof will travel everywhere in the medico-legal documentation. This should be used as a corroborative evidence for the emergency physician to do quick decision making bedside, and should not be used to replace the confirmatory assays which are used in post-mortem analysis by the forensic experts. So as I already told, this is all based on the molecular moieties. The examples of which is quoted here. For example, benzos, it is Zimmermann reaction. Cocaine, it is cobalt cyanide reaction. In opiates, purple color will be given by fraud salt, and alcohol green will turn into red. This is how color change will produce the results. So coming to feasibility, as I already quoted, is super cheap. It is hardly 50 rupees, 30 to 50 rupees costing per person. 95% cost cutting is there when compared to the standard assays which are available in the market. It's almost 95% cost cutting because we are not involving any refrigerator, cold antibodies, and all that cost which is associated with handling this costly and fancy equipment is gone. And one more thing is, if you're handling the cassettes properly, the shelf life will go up to 1 year also. You can store it in room temperature. And how exactly does it make an impact on healthcare is that in emergency medicine scenarios, mostly emergency physician will be interested in knowing whether it is a medical legal case or not. First of all, to decide whether it is a case of toxicology or toxin ingestion or not, because many overlapping toxidromes will be there and alternative diagnosis will also be there. So first is it is to detect whether it is a toxin ingestion case or not. And even if it is so, what is the compound present? And even if the compound is detected, whether I should go ahead and give antidote or not. So, and whether I should make the psychiatric referral or not, whether I should be sending the patient to autopsy or not. So all these are the questions which will pop up in physician's mind. So this test will be the efficient answering tool for all the questions that comes to physician's mind. And this is how we can streamline. I would like to summarize by saying only this, that we are not intending to replace this completely with the forensic or the confirmatory assays, which are based on immunoassays, liquid chromatography, and gas chromatography. We are intending to say that it is trying to bridge the gap, especially in smaller volume EDs and also in the other settings like ambulances. It can be scaled. So maybe we can conduct a pilot study using 50 samples or so as to validate this. These are my references. Thank you.
So thank you. Very interesting. Over to the judges for the question.
I have a very quick question. So you mentioned that this is for bedside decision making and not for legal proof. But you don't have any control over whether this will be used as legal proof or not. So if I document, for example, that in a medical document that the patient tested positive for, let's say, benzodiazepine or cocaine, and I managed medically according to that, my medical treatment decisions based on that, that the court will still interpret as proof that the patient used that drug or would have been under the influence of that drug. So you may not really control it. So that means you cannot be any less stringent with respect to your false positives and all that. So if I have, for example, false positive document the patient using as being positive for cocaine, like he may still have consequences to face.
So actually, false positive test, even if it comes, there are different factors which will add to the false positivity or false interpretation of the test. First thing is we should be training the residents and training the personnel to be conducted in such a way that we decrease up to significant amount the number of false positives. How we do it, there are different methods. First, the physical methods, and second are the chemical methods. In physical methods, between the sample well and the reaction zone, which I recorded before, in between, we can.
Brief answer, please. So you don't have to explain the whole thing, but can it still be considered as legal proof? Does it still have to be good enough to reduce false positives? Because it can still be used in a court of law, the report.
We can, if at all it turns out to be positive, first we have to confirm whether it is false positive or false negative. True positive based on that, if it is turns out to be really true positive, we have to subject the test to the confirmatory analysis. That will serve as a legal proof. ED decision making will change. For example,
anyway, I have to confirm. How do you know it's false positive until you confirm?
Okay.
You only know it's a false positive if you send the confirmatory test. So then it defeats the purpose.
If it is false positive, then I will not be sending it for confirmatory.
How do you know it's false positive until you send the confirmatory?
Actually, all this testing is based on it will be conducted only in such patients where we are actually suspecting the toxic dose.
I don't know.
This is your developed it or going to develop?
Oh, sir. Plan, not a
Plan. And it is available already in the market such kits.
This coloring based kits are not available, sir. Immuno-based kits, the chromatographic kits are already available in the market. Urine-based, but not coloring.
Do you use it in the
No, in psychiatry department, the resident has started a thesis based on the urine tox screening, sir. But the principle is different, sir. It is based on antibody, it is based on immunoassays, that is based on producing a control line and a test line. That is, the principle is different, sir. It's based on antibody. Here, what we are producing is
the other one is there. Antibody, there is no toxic.
Yes, sir.
That's innovation in that.
Yes.
So urine coloring is currently not available in the market.
Not available, sir. It is used usually by the forensic experts in the crime scene and custom people for detecting the drugs from the passengers and police people to catch the culprits.
It's basically concept proposal, correct?
Yes, sir.
So that should include a development and validation. The validation plan is not there in this. You put a concept proposal, it should be a development and validation plan. What is your validation plan? How you are going to validate?
Based on CSO guidelines, regulatory guidelines, we can kind of design. We can design the study and even test runs. Activities on this. We'll be taking chromatography technique as a gold standard and then compare it with this technique.
That's the concept.
Yes, sir.
Yeah, idea. That's all.
Yes.
Thank you. With permission from judges, can we move to the next campaign? Dr. Amit Vishwanath. Enrolls in the title is AA Powered Dietary Counseling for Integrated Politics. Forward to on that. Which one is it? Good afternoon, everyone. I am Amit Vishwanath from Medical Gastro. This is the title of my proposed idea, AI-powered dietary counseling for inflammatory bowel disease. For some background, IBD is rapidly rising in India, shifting from a Western disease. And we currently have European and American guidelines which recommend individualized dietary counseling for patients with inflammatory bowel disease. But it is found that up to 90% of patients modify their diet without any professional guidance, leading to unnecessary restrictions. And even 70% of patients admitted with Crohn's disease have malnutrition. So the issue is we are seeing close to 100 to 150 patients with inflammatory bowel disease in JIPMER per month. We have an insufficient dietary workforce to meet this population. And we have a population which is predominantly low income and they need affordable, locally available food recommendations. So the proposed idea is a single arm pilot validation to test whether an AI system built on locally deployed large language model can generate dietary modification plan for inflammatory bowel disease that are safe and concordant with the guidelines. So in this present stage, no AI generated advice will be given to the patients. So this is a validation study initially where we are testing whether the AI generating proper plans and safe plans. There will be a physician in the loop. When an AI generates the plan, independent gastroenterologists will score them against a structured rubric. So this will be deployed locally, which ensures a compliance with the Indian rules. We plan to use the Sarvam AI, which is recently launched. It's a 30 billion parameter model, which will be released for free in Hugging Face. And this is trained in India and optimized for 22 Indian languages. And this model will be efficient to run on a dedicated GPU in the
campus with a 24 GB RAM. We plan to use a system called retrieval augmented generation. This means that we don't rely only on this 30 billion parameter knowledge of the model. In addition to that, we will feed the model with structured guidelines based on the European and American guidelines, so that it can refer to the European guidelines, it can refer to the Indian food database, and then formulate the plan accordingly. And for personalization, for each patient, we will be taking a 24-hour dietary recall so that it can learn the food preferences and affordability, other cultural preferences. So these are all data collected in the baseline, and they are modified according to the disease, whether it's a stricturing disease or a non-stricturing disease, according to disease activity and complications of inflammatory bowel disease. The dietary plan will be modified. So in phase one, we first need a rubric to assess how the plans are. So that we will use 5 experts to create a rubric. We'll validate it using a content validity index, and we'll calibrate on 10 vignettes. And we'll use CAPA for inter-rater agreement. And in phase two, we will use data from 60 patients with a plan generated for each patient, and 3 gastroenterologists will score independently using the rubric generated in the phase one. We'll also look for safety with any absolute violations like high residue diet or anything in a stricturing disease. So that we'll look. And every time a plan is generated and the gastroenterologist marks for modification, this is also recorded, and it enables the AI to further form an iterative feedback loop to improve further recommendations later. This is the PICO of the second part, where we'll recruit adults with inflammatory bowel disease. We'll use this Servam AI model for this. And the comparator so we are comparing it with the guidelines. So we're using that rubric, we are comparing the plan with the guidelines, and see the concordance between the gastroenterologists also to see how the items are concordant. And we'll look for the safety. So there will be no patient follow-up. This is only a cross-sectional study for one plan per patient. So this can have multiple applications beyond gastroenterology. Also, it can be used in conditions of chronic kidney disease, oncology, diabetes, and within gastroenterology also other diseases like non-alcoholic fatty liver disease, chronic pancreatitis, celiac disease, short bowel. So it can be modified and based on the different guidelines of the respective conditions. So if the AI generated diet plans are safe and guideline concordant, this establishes a foundation for a scalable physician supervised iterative learning system where specialist dietitians are not available, and it contributes to a validated assessment rubric for evaluating AI generated diet recommendation. And with this native support of 22 languages and feasibility, so this is directly replicable at any other public sector centers. I have a short demo of this. So this will be the window where the data entry is made and the 24-hour diet recall is done. So after entering this, it goes into retrieval augmented generation, where it queries into the guidelines and the food databases, and it can generate a plan after that. So it calculates the calorie, the protein required, the fiber content. So it can give out plans in local languages, it can give out plans in Tamil. So it can give either a daily plan or a general plan. So we have not decided on that. And after that, this is the physician validation where they score on each of the rubric item, whether this plan was concordant, partially concordant, discordant, and we assess the results after that. Thank you.
Over to the data. What is the AI? What is actually what is the base platform for AI? Because it looks like a calculator with number a lot of scoring systems are there. Your prefix it calculates and gives the information. So the exact AI component is question number 1 second. You have a GPU with you?
And no, we have to get a GPU for this.
GPU is very costly. What is the AI tool in this? Because you need some programs at the backend. For this, you put an AI, it has a training number and a validation number. So this looks prefixed. So whenever you generate something AI, and the training model plus value. So what is training patient number? What is the validation number? Another, you're trying to create a AI program. That's what I understand.
No, we are not trying to create a program. So this large language model is already available. It is free to download for anybody. So we are going to give it additional guidelines. So the food guidelines, the food database, these are the information we are going to give it additionally so that it can give a personalized recommendation for each patient. So
modifying large language model and by external inputs are widely available. That is, even at home you can do, but what is the difference?
No, we are not
going AI involved as well.
So the large language model is the AI part. So we are going to enter the data through RedCap or some interface. It is going to send the prompt to the large language model. The large language model will generate a diet plan, and then the physician will review it and see. So the validation part is initially we are not going to give it to the patient. Physicians will rate it initially the plans and see whether they are concordant with the guidelines, so whether they are safe to use. Only after the initial validation. Regarding the GPU, even a Mac Mini is enough for this, which will cost around 1.5 lakhs.
I have a simple question. So one of the you're using RAG so that you can ask it to look at your own guidelines and other things. But that also means I don't know how many guidelines you have or how large they are or how frequently they are updated. That means it will need constant updating.
It will need, so that is easy to update a guideline. So it just needs to be converted into a JSON file and it can be fed so that it can read into that. It is not difficult because we are not changing the base model. We are just asking it to read an additional file to look up. So that is easy. So right now we are focusing only on one guideline. Yeah.
Similar apps are already existing in the market or
no? So this this is a locally done model. So we cannot use a commercial model or an online model for this. So this nothing like this exists so far for local purpose.
You said you're going to use server. What is wrong in using the existing models that are available freely to improve? This is also free, but the more popular ones are the
JIPMER, we can
and everything. Anything advantage of
advantage is language training. So it is specifically trained on Indian languages. That is the major advantage with that. So we can create diet plans in Indian local languages. So that is the major.
You said that doctor in the loop is there, but one of the major premises that you initially started off was that we don't have enough dietitians. So I think we not have a dietitian also in the loop.
If possible, but for every
for validation and other.
For validation initially, definitely.
Because you already mentioned the physicians. But I think the key gap that you're trying to fill using this particular diet plan creation is it is a dietitian
for the dietitian
for replacing the dietitian. So you should also have a dietitian that looks for validation because another thing is this supposed to be what you're envisaging is when you are validating, so validation is one. You're applying it, is it a one-time affair or is it patient can use it again and again after going
so this is only in hospital. So patient cannot access anything. So we will have to create the diet plan and give it in a printout or something to the patient or a WhatsApp message, something that can be planned later. But right now we are not planning it to give it to the patient directly.
So basically the pain point that you are trying to solve with this innovation
is the non-availability of a dietitian.
Yes, and every
Customization.
yes, customized plans for each. It takes time. So see 30, 40 patients in an OPD to create a custom plan for everybody. It takes time.
Thank you.
Thank you, Dr. Ravi. Next, we move to the next presenter. Dr. Aishwarya K, Senior Assistant from University. The title is QR code based hospital treatment system to improve pre-hospital care and reduce emergency department waiting time. Over to you, Dr. Aishwarya.
Good afternoon, everyone. Today, my research innovation idea topic is about QR code based pre-hospital check-in to improve the pre-hospital care and reduce the emergency waiting time. This is the actual day in the ED, and this is like almost some 30 patients will be inside the crowding in the resuscitation area. Almost 30 to 40 patients will be there in the LO zone, and there will be a queue standing in the triage area. So the main problem is there is the triage area, which is the bottleneck defect which is creating in the ED, where the patient used to stand here in the long queue. Even the patient with a chest pain, who might be having an acute coronary syndrome or STEMI, who might be needing an emergent diagnosis and treatment, might be standing somewhere in the queue, because of which the treatment delay might happen. To overcome this, and also there can be a patient who has been transported in the ambulance and still waiting in the ambulance bay. To overcome this, emergency department at present in the worldwide or facing unprecedented pressure because of the multimorbidity and because of the aging and because of so much of shortage of the staffs also. Here, the recent research which was conducted in emergency medical overcrowding has studied that they have conducted a Koske mediated research module where the patient can be managed in a crowded versus a non-crowded ED. Compared to the crowded versus the non-crowded ED, the patient complications was nearly half the less in the non-crowded ED compared to the crowded ED. And there are various strategies which they have implemented in reducing the crowding, like pre-hospital assessment or opening the extra triage or implicating the extra physicians at the point of the surge or the floaters who are coming in between the shifts to take out the triage system or unlicensed triage personalities who are coming in between to help in the triage at the time of the high case load. And there are multiple other networks like Medline, and there is a NADOC, and then FASAP and Madeline described that triage bypass system. Instead of the patient coming into the triage and waiting in the queue, there can be a system where the patient can be at the first point of contact, who is the EMS personnel, can update the vitals of the patient before itself, so that we can like a telecommunication where we are getting a telecommunication intimation from the EMS personnel. The system is a QR code based pre-hospital check-in and activation of the medical teams and early arrival to bed and physician greeting time. The physician greeting time and early arrival to bed are the national metrics in evaluating the standards of the healthcare system. So by the QR system coding, where the patients can be like early hospital arrival can be facilitated and the physician bed time can be faster than the older systems. First, the first medical contact is the EMS personnel who will scan the QR code and who will submit the Google forms so that it will get updated in the spreadsheet. And this spreadsheet has an AI automated facility so that the patient, based on their vitals, whether the patient is, for example, patient is having a tachycardia or patient is having a hypotension or
patient is arrested, already CPR is started, or patient is on nasal oxygen. So that based on the vitals, this triage sheet will get updated and the color coding will be given based on red or yellow or green. And these are the these are the things which can be included in the proforma. First, the ambulance details, ambulance service name, and from where the patient, at what time the patient was noticed at the first contact, and from what route they are coming. And section 2 will contain the patient details like patient name, age, and then sex, and the comorbidity and type of type of emergency. Either it is a trauma or a poisoning or a STEMI or a cardiac arrest or some poisoning or obstetric or pediatric emergency or a medical emergency or other. And second will be the vitals of the patient, starting from the airway, breathing, circulation, and disability. Either patient was requiring an intubation, or patient's BP is very low, or the patient are like RBS and all other vitals of the patient will be noted. And the section 6 will be the intervention, what has been done by the EMS personnel at the first contact, whether the IV line was secured, whether the airway was threatened, or whether the patient was intubated, or any supraglottic airway devices were used. And then circulatory management, whether early vasopressors were started or any medication which was given. And estimated time of arrival, at what route is the patient is coming. Either the patient is really so sick, so the patient is requiring a tertiary care levels of support, or the patient can be bypassed to a PHC, rural care center, where the patient can be treated before that, so that the overcrowding in the tertiary care center can also be avoided. So estimated time of arrival and the route of arrival can also be updated, and additional notes. If any help is needed, we can, if the patient is requiring an immediate emergency, so that if a patient is requiring a mechanical thrombectomy, which is available in this area in JIPMER, patient can be transported, and we can tell the geo mapping also we can do, and we can shorten the timing of arrival so that it will avoid the extra confusions. And then other option will be either it is a stroke. There are many pre-hospital stroke scales available to predict the large vessel occlusion, and then this will require the patient, they should go through the training for assessing the stroke, and then cath lab activation, because now in this proforma we had an added option that ECG can be taken in the ambulance, and the ECG can be updated in the Google form, so that ECG can also be seen. And also pediatric emergency team or obstetric team and ICU bed required. Either the patient is intubated, and how many ventilated beds are available. In our CDAC, now we are having the option to see all the availability of the beds, how many beds are vacant. And this is so patient, if the patient has a chest pain and cardiac arrest, first medical personnel will contact, scan the QR code, and then arrival to the GH, and then the hospital medical team will get activated, and then triage to the red zone or green zone or yellow zone based on the priority. Normally here, the patient will be standing in the line, even in the ambulance space. Sometimes the ambulance might be crowded, where the patient with the STEMI can be there. So instead of this bypass system can be used, where the QR code based pre-hospital check-in can prevent this. There can be a question that patient over triage can happen. Yeah, there have been multiple studies which have conducted that this digital triage systems can happen in over triage, but it's always done that over triage is better than under triaging the patient, so that the we are giving the best to the patient. And these are the benefits of the QR code based pre-hospital check-in. Reduces the wait time and improve the emergency medicine preparedness. If we want to assess the trauma case in shock, we can activate the blood bank, and better patient inflow, reducing the overcrowding, and low cost and easy implementation. This is a safety self-check in the kiosk utilization and their association, which is done in the US-based study, in which they have told the digital, comparing to the since after implementing the digital system, 58% shorter time was there in the ED waiting zone than compared to the conventional system. This is a triage dashboard where it is implemented in our JIPMER ED, which is showing the number of patients in the red zone, yellow zone, team like in the yellow zone and the green zone, and you will see how many were unattended and how many are in the red zone. It will be color coded in the red color, so that you will know the patient is, how many critically ill patients are there, how many are stabilized, how many are attended and unattended. If you scan this QR code, it will take you to the Google form. From the Google form, you can go, if you update the vitals of the patient in the ECG image, it will be directly transported to our spreadsheet, Google spreadsheet, in which we can triage the patient appropriately. Thank you.
Here, education universal problem just to be addressed especially the crowd will take and see. So how will get this? So your Google form has about 25 fields, which has to be filled by a fairly trained person, like DCM score and other things. So like a trained paramedic, someone who knows what they're filling. And some are pre-text entries also.
All are pre-text, these are option selection.
Right. So does this distract? So some well-intentioned things may have unintended consequences. So does this distract from that person actually looking at the patient and managing the patient? But is instead now entering a form. Like you work in the ED.
Yes, sir.
So if you're asked to fill a 10-field Google form in the middle of your work, I don't know if you have tried, but it is quite difficult.
There is like this pre-hospital system has that this would like when a patient in a busy ED, when we receive a pre-hospital intimation call, when already all the physicians were engaged in other resuscitation works, the like possibility of them going and attending a call in less than 1 minute will be lesser, and it is a kind of limitation. But this does not require that once they are stabilized, once the patient is taken into the ambulance, they there will be two people, one is the driver and another one is the EMS personnel, and that person can update the vitals while on their travel to once they have stabilized the patient and taken the patient, they can update the vitals later. It's not that before that they can stabilize. Once they are stabilizing and shifting to the ambulance.
They will also need to update it. Let's say in travel 1 hour later, the patient's vitals are different. They will have to update it. And once they arrive, the person who is seeing will also have to update, correct? Because
Yes,
as continues till when they reach the hospital.
For per cases, we can limit the responses also. Like if the there is a one form which can be filled if one patient has come, one ambulance has come.
I understand. I'm just asking if there is letting too much technology come in the way of instead just talking to that trained paramedic. Is that simple?
Yes, sir. But most of the times, like even if you're talking to the paramedic, telecommunication is done. The thing like getting into the spreadsheet and these things will be difficult. Once the telecommunication system is already there, where pre-hospital intimation is already being given, but this will help in the direct visualization and digital records, so that in the past or in the future also we can go and trace the records.
I thought emergency, when you say triage rate, immediately start associating, and if you keep doing all this, patient associates will suffer. If you look at the level over green zone is fine. If the patient belongs to the red zone, you have time to do all these.
No, this scanner code will be kept in the ambulance and in the public places and also in our hospital also. If the patient who is encountering, they will be updating the vitals. It is all automated. If you once scan this code, it will take you to the Google form. Once you update the vitals, it will get upgraded to my spreadsheet. In my spreadsheet, it will be color coded. We have code special for the upgrade. That is automated. Integrated spreadsheet. If the patient is having a tachycardia of 150, it will code red. If patient is having a chest pain, it will code red. So based on the vitals, high priority will be given to the red patients, so that we will know that this patient who is coming from this is taking this, and also geomapping can also be done at what route they are coming, so that we can estimate the time of arrival. If the trauma patient is 150 heart rate is coming, sometimes they can be triaged to green zone also. The patient can be walking but still can have tachycardia of pneumothorax. They could have been triaged because of some EMTs in the triage. So that can be bypassed. The patient who are requiring the immediate life-threatening condition can be easily solved. Sometimes over triaging can be better than under triaging.
Small clarification. This I think of study project that you're using is QR code based hospital check-in system. You improve. So first question is who is going to scan this QR code? Is it an emergency medicine physician or the thing or the patient?
First contact EMS personnel or any public can also, like whoever is witnessing the event, first contact personnel can be.
The thing is that currently are you using it in your emergency room?
As of now, we are using a telemedicine communication, pre-hospital intimation only, sir.
I'm a bit confused about the whole concept. So this is stated where this is your code. Is it on the patient's?
This is not used.
I'm asking, where are you planning to implement it? So I kept this particular QR code. Is it there in the patient's arm fan you are going to plan?
No.
Or is it going to be there in the wall of the emergency room?
It will be in the walls of the public places, like in kind of any emergency. In a bus stand, patient can crash and patient can be in arrest. So it can be at any place where the patient can arrest. It can be kept on the public places. It can be kept in the hospitals.
Not for improving it's only for pre-hospital care.
It's
It has nothing to do with inside the emergency room, right?
no, sir. Sometimes patient
So, calculating this particular QR code is not to be used inside the emergency room. It's outside the emergency room.
to improve the pre-hospital care and avoid the overcrowding. Patients who are in the life-threatening condition waiting at the ambulance, this can be easily traced and can be shifted directly to the red. Patient with a STEMI who is waiting between the 3 ambulances can be first shifted inside.
So basically, it is pre-hospital. It's not inside hospital.
It's
What is innovative? Because there are a lot of hospital HMI software, extended commodity, wearable device that can be directly connected to the hospital information system right now. Commercial products are available where the entire family can be entered in the hospital information system on purchase basis. And so what is innovative? It's already, this technology is highly advanced now.
Yes, sir.
Okay, it's not at the level, it's highly advanced. Okay, so what is new with this?
in emergency department, as of now here, it is not in pre like all the visitors visit, so many things are evolved already in the kiosk system, multiple services. But in the emergency system here, it is not used till now. And also for the pre-hospital care is also very underdeveloped in India. So this can improve the pre-hospital care and also reduce the waiting period in the ED who will actually require the immediate intervention.
I think more want to ask, but yeah, I'm pretty short of time. I'm pretty happy that sessions are looking much more interesting and interesting over the time. Thank you, Dr. Vashidati. So with the permission of the can we go to the next That's fine. So the next presenter is Pushpa, nursing officer from Big Four. The title is When Equal to Home, utilizing personalized QR code video tutorial to reduce caregivers anxiety and post-discharge rehabilitation. Over to you, Pushpa.
Next slide.
This is the next one of the page.
Good afternoon, everyone. I'm Pushpa, nursing officer NICU. I'm here to present my proposed idea, that is Equal to Home Bridge. The transition from neonatal intensive care unit to home poses great anxiety for parents. While the NICU environment provides a 24-hour expert surveillance care, the discharge for parents abruptly shifts the burden of managing medically complex babies to parents. So now I want you to imagine a mother who's been in NICU for around 90 days. She has been taking care of the baby for 90 days. Today, she gets to take the baby home. So she must be happy, but she is also terrified. She's in her hand, she's holding a stack of papers that tells her how to manage her baby at home. By the time she gets to the parking lot, she has already forgotten 80% of what we have taught her in the ward during the discharge. So this is not her fault, because this is a common side effect of continuous sleep deprivation, emotional exhaustion, and the stress that she has experienced during these 90 days. So I am here to show how this mother can be given her confidence back. This is the NICU compass.
problem statement is this research aims to evaluate the impact of a nursing officer-led QR code-based video education protocol, that is the NICU Compass, on reducing parental anxiety and 30-day unplanned hospital readmissions by providing the caregivers with the just-in-time visual reinforcement of specific neonatal care at home. So the problem is simple. The paper cannot move. What we provide to the patients, the patients cannot see how to take care of an irritable baby or how to give a specific medications on a flat piece of paper. So when these parents get home at 3 o'clock in the morning, when they are alone, they panic. During this panic, what happens is that panic leads to unplanned emergency room visits. So we need a bridge between our expert nursing care and their home. So what is the NICU Compass? It's not a 50-page manual. It's just a personalized QR library. Here, how is it done? We film our own unique nurses, the faces that the parents already trust, doing 60 seconds mini micro lessons that teach them how to take care of an irritable baby or how to give a specific medication, etc. And these, when the baby is getting discharged, we print these QR codes on their discharge that is tailored specifically for that specific baby. It is individualized, it is digital, and it lives on what every parent has in their pocket, that is their smartphone. Then what is innovative about this isn't the technology, it is the timing. This is known as the just-in-time learning for the parents. Just-in-time learning for the parents. What we provide when they are alone at home, not knowing what to do, instead of overwhelming the parents at discharge on a Friday morning with all the discharge instructions, we provide them with the QR codes that help them when they actually want to use them. Like when the parents are at home at midnight or 3 a.m. in the morning, when they are unsure what they are doing, they just scan the code. After scanning the code, their own nurses are visible on the screen, showing them exactly what to do. So it's like taking the NICU nurse home in their pockets. So the budget, about the feasibility of this project, it almost costs nothing. We don't need a film crew. We just have our smartphones. We don't need any applications. We use QR codes for this study, and we have expertise in our nursing staff. This only needs a few sheets of paper. Only cost it needs is a few sheets of paper and the time to film this mini lessons. And the savings that we do is every one single NICU readmission saves more money than this entire project to run. So it's low cost, high impact, and ready. We can start tomorrow also. So our goals are simple. We expect to have significant drop in unplanned emergency room visits by the parents for simple unnecessary readmissions. And we also, most importantly, we also need that the parents, when they leave the hospital, feel like more capable caregivers than just lucky observers. To wrap it up, the NICU Compass is simple, it's doable, and it solves, it closes a gap that the nursing section has existed for decades. Where we have the technology, we have the heart, and we have the need now. So this can be done. I wish to implement this as a standard of care where we stop giving parents just a stack of paper after post-discharge and we start giving them a personalized QR library for their use. So now I request you to scan this code so that you can see what every parent will see at their home when they scan the QR codes we provide for them. This is just a demo. Thank you.
Thank you. Thank you, Ms. Durga. Even though it looks like a simple, in real life, it's a very big problem and it's very innovative intervention which you are actually bringing up. So, over to the next. So, your the and so this QR code is kept in the point of the research.
Yes, sir.
Part of the research summary also.
At the discharge, lastly, it will be given, sir. It is tailored specifically for each baby. So if a baby doesn't get any medications, they don't get that code. For each procedure, if the baby requires, for premature babies, it will be different. For term babies, it will be different. So what the baby requires, only those will be personalized.
And this personalization happens how? How does it happen?
We actually discharge the babies. So we know the baby condition, everything. So these micro lessons will already be loaded up. So like teaching. No, we had to start. So only one demo, for demo, this one was done.
Are you using AI for creating the video?
No. This, if you scan, you can see that our nursing officers are.
Videos are created by different videos. So different videos are created by different.
We only create, sir. Only NICU nurses are there in this. We create the videos because we are the faces that only the parents trust.
So what I'm saying is different personalization. For each patient, the requirements will differ. And each person will get only one video.
Feeding videos are there, sir. Pace feeding videos, the rhythmic soothing videos. So babies who need those, like the baby will be always irritable in NICU also, we know those babies. So feeding issues which babies have. So those videos will only go to those patients.
Scanned by the parents?
By parents at home. When they want to see the red flags, if they want to know if the breathing is any respiratory distress or it's just normal breathing for a preterm baby. So those sounds and all will just load them up.
Will it be better with a coordinator or somebody? How grading shift, how you are going to handle? The shift may change. So how you are going to handle?
This in the counter, sir. The discharge where we are doing, that one counter is only there. So from there only baby will be discharged. So in that system, everything will be loaded up. So which baby, if the babies require only feeding and sleeping assistance, we'll take those QR codes and put it for that baby. So if the another baby requires medication assistance, for that baby, the medication QR code will be given. So like that, if the baby requires more than one QR code, more than one QR code will be given for the baby.
Thank you. It's in the local language, the videos?
Yes, sir. It's in local. This if you scan, you can see it in Tamil only.
Thank you. Next, we will go to the next person, Dr. Lokesh Kumar, Associate Professor, EAT. Title is EDFR targeted medicine after annual robotic platform for precision photothermal cancer cell killing melanin cancer. Over to you.
Good afternoon, dear judges, senior colleagues, and beloved friends. This idea was there since I was a resident. As a resident, ENT resident, we used to operate a lot of massive head and neck cases, head and neck cancer cases, where we remove a large part of head and neck region and then reconstruct with other parts of the body. So I would always think, what if we have a technology or a drug which when we apply near and there or the cancer cells, cancer tissue to eat away without harming the neighboring cells. So I would present an idea where I actually can do that with the help of one nanomaterial, that is amixine. I get to know about this because I'm studying on amixine and other nanomaterials as a part of my PhD program. Coming to the background, head and neck cancers, we know India is one has a global burden of head and neck cancers, with 5 young people dying every hour in India because of cancers. And the late stage diagnosis leads to very high mortality. Around 70% of the people die because of advanced cancers every 5 years. So there is a precision gap in treating these advanced diseases and recurrent cancers. The need for the R is to avoid systemic toxicity and to have a low cost, easily affordable drug which can help this population. So we know when we see at the head and neck tumor microenvironment, EGFR is the common gene that is overexpressed. It is overexpressed in 80 to 90% of the cancers, and it plays an important role in proliferation, aggressiveness of the cancers, and also it leads to resistance to radiotherapy and chemotherapy, and it causes decreased apoptosis, thereby enhanced proliferation of the cancer cells. So our area of target in this idea is EGFR. So what we do is we create a EGFR targeted nanorobot. This nanorobot has 2 parts. You can see here, this is amexine 2-dimension nanomaterial. It's a 20 nanometer size. It will generate, it has a unique property where it will generate heat up to 60 degrees centigrade when you expose it to near infrared radiation light at 808 nanometers. Another part is a navigator, is DNA aptamer. This navigator will take this amexine and it will go and bind onto the EGFR receptors for the head and neck cancer cells selectively. So these are the parts, these are the components. This amexine is FDA approved, bio-friendly, biocompatible nanomaterial. It has this peculiar property of giving heat energy when it is exposed to near infrared radiation. And the second component is aptamer. As I told you, these aptamers have got unique advantages because they are small. They can easily go and dock themselves on EGFR receptor. They are less costly because they are made of chemical synthesis. They are very stable at room temperature, and the immunogenicity is less when compared to other monoclonal antibodies. So the overall mechanism of action is search and destroy policy. Once you inject intra-arterially or intra-lesionally, they themselves go and bind onto the EGFR receptors on the cancer cells, and on exposure to the near infrared light, these cells will selectively die without injuring the normal cells. So my primary objective is to develop and validate this EGFR nanorobot for selective cancer cell killing in head and neck cancer. However, I have 4 time-bound specific objectives. First objective is computational modeling and in silico validation of aptamer EGFR binding to the cancer cell. And the second objective is synthesis of this nanorobot. Amexines and aptamers are synthesized and they will be chemically conjugated. The first one is done with the help of bioinformatics department in Pondicherry University, and second one is done at ICER Trivandrum. Third one is done at JIPMER Puducherry and ICER Trivandrum. There we do in vitro studies. We check cytotoxicity and characterization of this developed nanorobot. And then the fourth one is done at JIPMER Animal House, where we do in vivo studies. I come to the details in the next slide. So this is our 26-month roadmap where we start from phase 1 in bioinformatics department, where we do in silico validation, and then it will go through synthesis, in vitro validation, and then in vivo validation. By the end of 26 months, our preclinical data will be ready with us. So this is briefly about the phase one. Phase one, where we'll do computational designing with the help of EGFR structure that is available in protein data bank, and we'll do validation. The top 3 targets, the structures will be made with the help of isotrivandrum in by the help of PCR, polymerase chain reaction, and then amixins will be attached to this aptamers in second phase. The third phase will do in vitro validation, where we'll check for binding specificity of the developed nanorobot and also the killing efficiency by the help of MTT assay and ROS assay. Fourth stage, we inoculate these tumor cells onto the flanks of the mice. The sample size is around 6. And then these mice, once the tumor volume rises to a particular volume, then we'll inject intralesionally and then expose this tumor to near infrared light. So we'll see biodistribution after euthanizing the mice. We'll check for titanium levels in other various parts of the body, and also the endpoint will be tumor volume reduction, cancer survival analysis, cell survival analysis, and we'll do tunnel assess for histopathology. So by the end of this project, I would say I'll have a medical product which is ready and validated, and a patent, medical patent, and then at least 2 high impact journal publications in peer reviewed journals. So I believe that this idea will work out, and it is because it is scalable, it is indigenous, and it will decrease systemic toxicity to advanced malignancy patients, and this will help JIPMER and also the collaborating institutes to have a good name in Indian research. Thank you.
Sir, thank you, sir. It's a really innovative idea. Over to the questions. When is animal studies are done?
So this will be done in JIPMER Animal House.
So they are going to create a cancer model.
We have to create, sir. We have expertise with that. We have approval for inoculating the cancer cells into the animals. So we'll increase the volume.
This is a PhD project.
This is not a PhD project.
Why I'm asking that question, because you explain the core components of this. So what is all of the initial exactly in this at this stage?
At this stage, I can.
How do you need an EMT?
So because I know the burden of the patient, and another thing is I have the original cancer cells with me. I can inoculate into the animals like mouse cells. The original cancer cells that will take out from the patient, will develop them in the cell cultures, and then I will inoculate into the animals. But even the animals, I believe there is a role of clinician. And then once it is completed, then phase 1 trial to see the efficacy and safety of the drug, then that's my role.
These are purely experimental studies, and in targeted therapies, separate companies are established just with one IHC marker and targeted therapies or gene marker, bioluminescence and all the things are even just for one marker, big companies are established.
Yes.
So that's why they're putting a very big picture here, but that's what I'm.
Yeah, so this is very easily doable one, because the aptamers are nowadays being made by a lot of private companies at a very low cost, 25,000 rupees. I have searched about it. And then they can easily go and dock onto the EGFR receptor. EGFR whole domain sequence is easily available from the net, from protein data bank. So there won't be a problem with developing aptamers. And amexin synthesis is already being done in isotrivandrum. The professor who is collaborating.
The problem you are going to face is alternate pathways are going to act.
Which one, sir?
Alternate pathways are going to act. You have to understand that finally you have to achieve a cancer killing of this cell.
Yes.
That's all. You think you are essentially talking just to one pathway. That's like cooking. But that may not be the real situation. There will be several alternate pathways working.
Yes, sir.
That's why the patients are dying.
No. I'll tell you, because the antibodies, the cetuximab and everything, what we routinely see in our clinical practice is even if we give many of the cells, like 10% or 20% of the cells, if they remain, then it will come back. But here, the cells won't remain because they will all be killed and destroyed by the heat. At 60 degrees centigrade, there will be coagulative necrosis. At 55, the mitochondrial enzymes will release. Even if you achieve 50 degrees centigrade as a tumor microenvironment, then you are a success. I believe there will be a success. So we have to work out, sir. This is just an idea. And I am applying for this small grant this time. See.
Okay, you are using the light that is here in front of the light.
Yes, sir.
Activate the robot. That's it. So now, how do you propose that in a biochemical in the animal will be injecting the particular robot also insert itself.
Yes, sir.
In the animal, how are you going to provide that into the lesion? Are you going to?
We have handheld lasers. They are around 2 lakh rupees, which we use for experiment.
Are you going to this particular laser?
Yes, sir.
And then it is going to be shown on the surface, or are you going to use some
on the surface?
Not inside.
No, it has a depth penetration of 3 to 5 mm. So most of our malignancies, which are the buccal mucosa and oral malignancies, they will be around 3 to 5 mm penetration. This laser is used in dermatology practice and in PMR department for musculoskeletal pains, all those things.
I cannot mention like in the skin color, if it is like a pigment skin, I think it can interfere with.
There is no interference because it acts in the biological range. Biological range is 700 to 900 nanometers. It will go depth and then it will act. The absorption by hemoglobin and water is very less with this laser.
The aptamers and nanorobots are very, what are the expected side effects or other
scientific
side effects?
Side effects. The amexines are made up of titanium, sir. They are titanium metal carbides. So we have to see the biodistribution because we give only very small amount of drug around the lesion. We have to actually see what happens if we give them. But they are biologically safe. They are proven for other like biosensing work. Biosensing work it has been used now.
It's very nice, it's very comprehensive, but also very ambitious. I mean, you're looking at maybe a 10 years timeline between starting from here and let's say phase 3 trials and all that, right? So, which means many other things might also change during that time period. Yes. And is it limited to one particular kind of cancer and different from what others have done already?
Sir, we'll start with tongue or oral malignancies. And then with advancement in technology, maybe we can go them with the other regions of the body also. Because EGFR is a common.
Seem to have done this already.
No one has done this till now. This is
for this particular cancer, but for other cancers?
No, sorry, it's not done anywhere now till now. Only some Chinese and Korean people, they have proven the killing capacity of amexins in the cell cultures, not in the animals also.
You're chosen EGFR with the family.
Yes, sir.
And the clients that have targeted EGFR have resulted in 3 months increase in overall survival advanced cancers. Advanced in the sense that they are not available so that they are not a target cases of therapies. They can delay the progression of the disease by another 2. This is what is studied by blocking the EGFR receptor at the advanced cancer. So this may produce an increase in survival much beyond what is already produced by the molecular targeted therapy. That's my one observation. Rather, the question I wanted to ask is this the one that you're creating to block the EGFR, it has to be custom designed based on the computational structure record of the protein. The first part is ensuring the specificity of this one onto the samples. So that has to become successful. Yeah, I don't know how easy
is it to design a molecule that can attack any specific target molecule in the body in the internal milieu. External milieu is one aspect. Internal milieu is another. So if you could clarify on how easy is it to create a, if you can call it antibody or anti-structure for that matter, which is fight towards specific target molecule, that could have some more clarity on this. Can I answer this now? Or if this is not too long, I think both the audience may.
Yeah, so sir, what we took in EGFR has 4 parts: CR1, CR2, L1, and L2. So L1 and L2 are ligand binding sites. So because when the ligand is bound to this site, there is structural modification in the structure of the ligand binding site domain of EGFR. Whereas the CR1 and CR2, which are called cysteine rich regions, they are more or less more stable in their structure and more conform to their site. It has been proven in the studies, in the previous studies also. So the area of target for our this thing is the top models that we select through in silico validation are from these 2 regions, CR1 and CR2. So once we have a correct sequence in the CR1 and CR2, then we'll produce the same by means of PCR, and then we'll take this aptamers for binding efficiency. We have to see something. It's not that I'm 100% sure that it will work, but I believe it works because there are other studies which are proving this.
I think we will stop now because in the interest of time, we need to move on. Thanks very much, your patience. Move on to the next one.
Next one is the Dr. Shania D. Gonavdi, Assistant Professor, Department of Neurology. Title is Development and Validation of an solo beginner prediction tool using curve analytics in patients with acute stroke. Okay.
Which one is
A warm good afternoon to all. Today from Department of Neurology, myself Dr. Vishnu and my professors Dr. Sharanya and Ajeshri ma'am. Today we are going to present an innovative topic regarding development and validation of an AI-based swallow readiness prediction tool using cuff analytics in patients with acute stroke. So going to the topic per se, we all know that stroke definitely has so much complications. One of the complications that can happen to the patients is dysphagia. So according to the studies, what they have found, around 30 to 65% of the patients with stroke, they can have dysphagia on the follow-up. So what is the problem with dysphagia? So once the patient is having dysphagia, they are having more chance of developing an aspiration pneumonia or increased hospital admission rates and increased mortality rates following the dysphagia. So thing is like there is an indeed we have to find out those patients who are very vulnerable for developing dysphagia. So usually for every stroke patients we will assess dysphagia basically after 24 to 48 hours afterwards the admissions we will do. So usually what we will do is this water swallowing test, gas test. What they will do is indirectly we will do coughing or we can give water and assess or we will assess saliva, how they are swallowing. Problem with these tests is all of these tests are examiner dependent. So these tests can be depending upon examiner, it can be changing, the values can be changing and it is time consuming and it can be there is a particular personnel should be needed to assess this and they all rely on clinical judgment and this can be inconsistently performed also. So in case of a limited resource setting like in PHCs and all, they will not be having any people to assess this and they can have so many patients and it can be time consuming procedure. So what we are going to see is basically we know swallowing needs bulbar muscles. So Cough also requires bulbar muscles and respiratory muscles for the proper action. So swallowing and cough requires bulbar muscles to act. So here we are proposing that these abnormalities in cough characteristics can be a surrogate marker for dysphagia. So there has been previous studies in amyotrophic lateral sclerosis. They have done spirometric cough analysis to predict the swallowing assessment. And there have been previous studies in conditions like asthma, COVID-19, in pulmonary edema, where AI can detect cough and detect the disease. So we are proposing a new concept. Here AI-based cough analysis we can do, and based on the cough, we will tell how much the patient can have swallowing difficulty or dysphagia. So I'm moving my next topic. I'm giving baton to Dr. Rajeshwari for proceeding further.
Thanks, Vishnu. So the givens are that cough is non-invasive. It is naturally produced. It has got overlap with swallowing muscles. And cough analytics is not new. Acoustic analysis of cough has been around for a long time. It has already proven its value in COVID, TB, and has also been shown to be an effective marker in ALS. So given that, we propose this. So what we want to do is we want to go through 3 phases. First is the development phase, where we will look at acute stroke patients from our center. We will estimate their voluntary cough. We will record them using microphones, either laryngophones or external microphones. And then as a standard procedure, we will estimate their swallowing capacity using Gus scores, which is a validated standardized score that is recommended by the guidelines for estimating swallowing readiness. And in certain cases, as clinically indicated, we may also follow up with fluoroscopy. But our outcomes are more hardcore. We want to make sure that the patient is able to complete a fully mixed meal orally and has no clinically significant aspiration during this process. And this can be repeated as many times every day as required until the patient gets discharged or the patient is able to meet our outcomes. So this cough that is then recorded will be used as a signal. This acoustic signal will be used to predict for these outcomes using AI ML technology. So the next phase will be validation, and this again we are proposing as a multi-center validation project where we will evaluate this cough, which will be recording as we have been recording in the first phase. We will also do Gus assessment. Standard care of treatment will be followed, and the same outcomes that we used in the development phase will be evaluated. And this phase we will use to iterate the model, validate the model, and hopefully scale down the model. Once we have scaled down, this is our last phase. This is the translation phase. Our idea is to develop wearable device. This is a laryngophone, which will have edge computing, and it can classify based on the cough as whether the patient is safe to feed or patient is not safe to feed. I will then hand it over to Dr. Sarnia.
Coming to the feasibility, our center has a high stroke patient volume, and so the study is very well feasible in our center. Moreover, cough, sound recording, it's a very simple bedside procedure and only requires a recorder and a microphone, and the cost is also very minimal. And this is also done as part of the routine clinical care. There is a standard swallow assessment, and it can be integrated with the routine care. And we are also planning to collaborate, with biotechnology and AI experts to carry this forward. So the expected impact of our innovative idea would be the development of a low-cost AI-based bedside tool to predict swallow readiness in patients with acute stroke. So it helps clinicians to make safer decisions regarding initiation of oral feeding and thereby reduce the risk of aspiration pneumonia, malnutrition, and prolonged hospital stays and mortality in the patient. And it is very useful in resource-limited settings where we do not have dedicated nursing staff or dedicated speech-language pathologists just to assess swallowing readiness. And it can also be, scaled into a mobile application or a wearable device for a wider clinical use. And it can be expanded to not just stroke, other neuromuscular disorders with dysphagia like ALS, then other disorders like Parkinson's with dysphagia, etc. These are our references. Thank you.
What exactly you are going to capture and what is the capturing device? Are you contemplating that the noise produced by a cough is analyzed by AI platform and giving an idea that it will predict this data that is, but noise analytics in AI is not an issue. It comes to the modern difficulty in AI. That's why I'm asking, are you really sure that the noise analytics, because you're going to PhD and you need a capturing device there. How you're going to analyze? So it takes a soundproof environment.
Yes.
It takes a high-end mic.
Yes.
Okay. It's not easy to create a noise capturing analytics. Okay. So you have told the idea, except that how you're going to do the analytics is the critical AI component which we are interested in.
If I may answer that question. So, cough analytics, yes, it is difficult, but people have done cough analytics on mobile phone recorded cough. So, there is a lot of literature and there is a lot of knowledge already that is existing on how best to analyze the cough segmentation, which are the what is the kind of signal to use, whether to use a spectrum or the energy, or when to call it a cough completion, post cough sounds. So yes, there are difficulties in recording, but what we are proposing right now is essentially because we want to come up with a wearable device or a point of care device. We are planning to record both externally with a high fidelity microphone as well as using a laryngophone. Our idea eventually will be to utilize the laryngophone with maybe a very small, very gross classifier as safe to feed and not safe to feed.
You said that ultimately this is going to be used in the hospital, not at home, no, that physician.
It need not have a physician present, but any patient, any place where stroke patients are cared for and where we need to decide whether the patient can be fed safely orally, it can be used.
Currently, how do you decide that the patient is ready for?
So currently what we are doing is we are doing a bedside swallow test. This is essentially a supervised swallowing. So we will tell them swallow your saliva, swallow this water, swallow the semi-solid, swallow this solid, and we assess how easily they are able to swallow, what is the cough that is happening. So that is how we are scoring, and that is how we are saying if it is more than 20, it is safe to swallow. 15 to 19 means some risk is there. Less than 15, don't give orally.
That means this particular thing that you're going to develop, you're going to use the cup sounds plus the score as an adjunct or only the
only cuff. Idea will be only cuff for correlation purposes to see what we are measuring, what we want to measure. We will also utilize this GUS score to kind of validate what we are doing.
That means the GUS score that is given, that will be the ground truth against which you.
No, ground truth will be the outcome. Ability to complete a full mixed meal. Mixed meal, like not only liquids, not only solids, not only semi-solids, but a normal full mixed meal the patient should be able to complete without clinical aspiration.
No, that means R&B is ethical to ask somebody to take a meal and only aspirate.
No. Only if they are using by routine tests, they are safe to swallow. So during the development phase, we are going to follow the same. Validation phase also, we are going to follow the same. Only after we are fairly sure that it is working and when we are deploying it, then maybe we will ask them to utilize only the cup.
I think in the initial stages, we should have something more solid as a ground truth. For example, maybe some I don't know, I'm not an endocrinologist, but is there something EMG recordings of the.
So we discussed this. The problem with EMG is all the pharyngeal muscles are relatively deep. So when we place EMG, they may not be able to pick up. Plus, what is picked up in that cough, it's not new that we are suggesting. Many physicians actually do evaluate cough. We say bovine cough when the patient is not able to protect the airway. We say so many other types of cough. So it is not an entirely new idea that it predicts the pharyngeal musculature. So we are just trying to utilize that acoustics to make decisions for swallowing.
If a functional MRI or something, not functional MRI, may swallowing, some sort of imaging it can do.
Yeah, the subset of patients, we will also do the video fluoroscopic swallow assessment. Not in everybody because it's not feasible. That's the plan.
Ground truth in AI is the normalcy you create the technological platform. So how a normal can you create? What is the technological parameters, technical parameters of a normal and abnormal cough?
the data has to be there. Without that data, you can't just start go to the next step in life. Nothing but the ground truth. So that's what the question is. Do you have a ground truth available in the market, the software available anywhere? So the program should detect that somebody is talking. It is abnormal in a technical or technological parameter point of view. That is not a replacement for a normal patient. No. Computer will not read a ground truth. It is a ground truth data. That's not enough.
So there are two answers to this question. One is the normal cough is already available. There are plenty of normal coughs available free everywhere. So normal cough has been analyzed in many, many ways. Second part of it is the reason why we are not picking something like video fluoroscopy or something like that. As a clinician, I'm not interested in whether the food is going down the right way or not. I'm interested in, am I able to feed this patient? So that is why most of the existing studies, they are validating based on these kind of soft markers. And we wanted to look at hardcore clinical endpoints. Thank you.
The end of a very interesting innovation session. So this is a new session that we started this time, and very heartening to see that we had very good. I think not working. That's right. We had almost 47 applications this time, of which we could choose only 6 over application. But it's very heartening to see this new idea has caught on, and hope that many of the ideas that were presented both in posters as well as portals will go on to further development phases in JIPMER. So we are really hopeful that that will happen. Thanks to all the judges for providing very important inputs and suggestions to all the speakers. That brings us to the end of this session. And next two sessions are faculty research in progress and faculty published papers. I request everybody to stay on and encourage all our participants. Thank you very much.
I thank all the innovative presenters for the insightful discourses enriched with curiosity. It was indeed a stimulating exchange, and I hope they have sparked more neurons in all of us. We now move on to the last session, the faculty oral presentations. First, we'll begin with the researchers on progress. May I now invite Dr. Siranjani ma'am, professor from the Department of Dermatology, to kindly invite the chairpersons and the respective judges for the next session.
So, up next is a faculty presentation for research in progress. So, I welcome Sonali ma'am as the chairperson. I invite Dr. Sriram from the Department of Pediatrics, Dr. Jawaharlal from the Department of Endocrinology, Dr. Chitra from the Department of Obstetrics and Gynecology, and Dr. Hemachandran from the Department of CPDS to act as judges for the session. I welcome you all. The round will remain the same. The duration of presentation for each speaker is 7 minutes. There will be a first bell at the end of 6 minutes as a warning, followed by a concluding bell in 1 minute time to conclude your talk, followed by your discussion for 3 minutes. Thank you. Now I call upon the first speaker, Dr. Anusha from the Department of Pharmacology, to give her talk.
Such 2024, 2026. Sorry.
Remove my pen.
Good afternoon. I'll be presenting the study titled Implementation of Interdepartmental Collaborative Medication Review Reduce Potentially Inappropriate Medications in Hospitalized Elderly Patients, a mixed method study. So why this matters? Because we have about 8.6% of population with multiple morbidities in elderly population, and they are at a higher risk of polypharmacy. Because of this polypharmacy, they are tend to having more adverse events and increased costs and reduced quality of life. So in the recent study, it was seen that about 28% of prevalence of potentially inappropriate medications in the elderly population. So there's a screening gap. So in westernized countries, this collaborative medication review model is being done. So this has not been systematically evaluated in Indian settings. So based on this, the aim of the study was to evaluate the effectiveness and feasibility of interdepartmental collaborative medication review in reducing PIMs. And the secondary objectives are to evaluate the reduction in PIMs after CMR using the criteria like MAI and stop-start, to evaluate 30-day post-discharge adverse events and medication-related readmissions, to identify facilitators and barriers in implementing the CMR from healthcare provider perspective, and to determine the cost involved in CMR implementation from a healthcare system perspective. Methodology: the quantitative part of the study is a quasi-experimental pre-post intervention study with a total sample size of 282, 141 participants in each site, JIPMER being one site and PIMS being the other site. Purpose of sampling was done and the study was conducted from March 2024 to December 2025. We included hospitalized elderly patients above and equal 60 years of age and who had more than or equal to 5 drugs prescribed to them. We also did a 30-day post-discharge follow-up, and the tools that were used are Medication Appropriateness Index, Stop-Start Criteria, and AT-HARM 10-2. The qualitative part, we did 26 in-depth interviews of the treating physicians, 4 focus group discussions, including both the sites, and framework thematic analysis was done, and qualitative analysis was done till data saturation was achieved. A total of 1,128 verbatims were coded. So what is this collaborative medication review? This is basically a interprofessional process where a clinical pharmacist, the treating physicians, a pharmacologist or a clinical pharmacologist, they review the patient's prescriptions and give suggestions where they identify and resolve any drug-related problems that are picked up. So in this study, the clinical pharmacist took the lead of reviewing the prescriptions and compiled the report, which was then discussed among the CMR team. For the study, the CMR team included the pharmacologist, a general medicine physician, and a general surgeon. After this discussion, a report was compiled and it was given to the treating physician. The evidence-based suggestions were given to the treating physicians. So on day 1, when the patients were screened, the medical officer and the clinical pharmacist did the screening. The chart review was done, lab checks, everything was done, and the scores were done based on the baseline MAI and stop-start criteria. And the MAI score is basically will tell us whether the drug is appropriately given, the indication, dose, interaction, anything, if it's present or not. And with these suggestions, the CMR team will review all the findings given by the clinical pharmacist, and a written communication was written to the physicians, to the treating physicians. This was done on day 1, and this was continued every 3 days till the patient was discharged. Once the patient got discharged, on the day of discharge, again these scores were evaluated. The MAI score and stop-start was done. And after 30 days of discharge, we did a follow-up, a telephonic follow-up, to see if there were any medication-related readmissions. The medication-related readmission score was captured using the AT-HARM 10 score. Moving on to results, the medication appropriateness index, we found that 64.8% of reduction was present in the MAI score, which was statistically significant. The baseline MAI score was 3.01, which was reduced to 1.06. The coincidence effect was 0.655, which showed a medium to large effect, which means it is not only clinically significant, it also had a significant magnitude for the reduction from baseline to discharge. This MAI reduction was comparable at both sites. the number of potentially inappropriate medications identified, and the acceptance rate of this intervention, the CMR, the Collaborative Medication Review. So we found that 19.1% of the patients had at least one PIM, which was identified using the STOP criteria. 22.7% of the patients had some PIM based on the prescription omissions, where some drug needed to be started, but it was not started. In total, including both the sites, 755 recommendations were given based on the CMR team, and 67.8% of these recommendations were accepted. And there was an acceptance and implementation gap seen in the study. So if you see the JIPMER site, there was 83% acceptance of the CMR recommendation. A total of 311 recommendations were given, but only 46.9% were implemented. Even though they accepted 83%, we will see why only 43% were implemented. So these are some of the real examples that emerged from our study. So if you see, the first thing, dose adjustment. Famotidine dose adjustment was needed based on creatinine clearance. This particular CMR suggestion was accepted and implemented by the treating physician. But say, for example, if you take SGLT2 inhibitor not initiated in heart failure with reduced ejection fraction, this was accepted by the physician, but they were not able to initiate it because this drug was not freely available in JIPMER site. So there were certain instances where even they were able to accept it, but they were not able to implement it due to system constraint. So these are some of the examples, and these examples are only from JIPMER site. So based on the number of PIMs we picked up and number of suggestions we gave, we also evaluated how many ADRs we averted. So in total, 778 ADRs were averted based on the 311 interventions. Out of these, 53.3% were some of the areas which required hospitalization. So post-discharge, there were only 5% of patients who came within the 30-day post-discharge, but none of them had any medication-related readmissions. All of them were some other reason. They had disease progression or something. And the time taken to do the CMR was per patient was 64.8 minutes. And the total time taken was 638 hours for all the patients. So some of the facilitators were evidence-based approach. We told the suggestions with backed up evidence from guidelines. In collaboration between the departments, the clinical pharmacist mainly acted as a bridge between the suggestions and the treating physician, and each case was discussed in detail. So that was some of the facilitators. The barriers include time constraint, workload, some of the drug unavailability or affordability, cost analysis. We did activity-based microcosting. So if you see, the total cost for implementing the CMR was 1,700 in JIPMER when compared to 1,500 in PIMS. So we also extrapolated it to the cost saved because of the areas averted. So if you see here, the total implementation cost was 6.46 lakhs and the total saved cost was about 93 lakhs. So for every 1 rupee we spent on the CMR, we were able to save around 14 rupees by preventing the ADRs. So we can see that in all ways, this CMR intervention reduced AMI score, reduced the adverse events, and the clinical pharmacist acted as a bridge between the CMR team and the treating physician. So I would like to conclude this intervention nearly reduced 65% of the inappropriate medications, and there was a clinical impact because of the CMR review. And it is a scalable strategy, and it also improves medication safety. The next future direction for this study was to implement this as a national health policy. This study received funding from ICMR National Task Force on Safe and Rational Use of Medicines. These are the references. Thank you.
Thank you, Anisha. That was a very good presentation. It's very heartening to see this many audience in the last but one session of the scientific day session of the research day. So there must be definitely questions from the audience or from our judges.
Anisha, very nice study. Actually, it is quite innovative also. I just wanted to know, you have taken a quality experiment. Instead of doing 30 day RCT, do we think that would have had a very effect on the outcome?
Yes, ma'am, it could have had, but since we had both qualitative part also in the study, so this was the study methodology suggested by the TAC team and also that's why we couldn't do an RCT for this.
You know, there's acceptance ratio is better in JIPMER.
Yes.
And this acceptance was not so good.
Yes.
So you have mentioned some barriers.
Yes.
So how was that barrier could be overcome to have the same acceptance and what was in JIPMER also?
The acceptance.
JIPMER was better.
Yes.
Yeah, but it was not so in the other private
Yes,
sector.
yes.
It was some 40% something.
So the barriers in the other sector, what they mentioned was the physicians were not open to the suggestions given by the team. But here, our physicians were actually open to suggestions when we gave backed up with evidence.
And last question, I just want to know, you told like future national health.
Yes, yes.
Might be this study, you had a research staff, you had a grant,
Yes.
you have a dedicated person.
Yes.
So that's a maybe good.
Yes.
To really implement it, don't you think so? Adherence should be less or
Yes, ma'am. That is why, based on this study, the ICMR has proposed to ask us to develop a national policy, which will be might come in the future. So in that case, we might have to hire the extra clinical pharmacist if it comes as a national policy.
In some hospitals, there's no clinical pharmacy. What are you?
We have to use a pharmacist. We have to use staff. We need to have dedicated time and staff to do the study.
thank you.
You had 300 cases, right?
No, sir. The total number of participants included 141 in each site, so 280.
So, we didn't see the clinical profile of those cases. I mean, what kind of polypharmacy? You could show some examples.
Yes.
But, overall, what were the clinical indications for which these drugs
Most
were
patients
prescribed?
were, most of these patients, all of them were elderly patients, about 60 years, and most of them had diabetes, hypertension, heart failure, pneumothorax, so multiple comorbidities were attempted in medicine and surgical wards, inpatient wards.
If the results vary between different kinds of indications?
No.
Have you done any research analysis?
Yes, but the primary objective was to see the effectiveness of the CMR intervention, so I did not propose.
There was a very heterogeneous population of different kinds of polypharmacy for different kinds of indications.
No, not many. In surgical wards, what we found was antibiotics a little more, but that did not affect the intervention area.
Where was there any difference between the two centers?
No, there was not difference between the two centers.
I total number of participants were 280.
282, yes.
But the adverse reaction that would have been
prevented
was around 700 or something.
Yes,
and there was no, and the readmissions rate was not due to inappropriate use of the drug.
Yes.
How do you tell that it happens as the reaction averted?
So we did not see the areas actually happen. We cannot see the areas actually happen because we have prevented, we have given a suggestion and the drug has been modified. So an area would not have happened. So this is an extrapolation where if we stop this drug, so many areas were prevented.
Not even single readmission was due to
No.
inappropriate.
Only 5% of patients came back for the readmissions, but that was due to disease progression, not because of the medication-related readmission.
What is the most common inappropriate drug use actually? What are all these?
Most common, I would say, famotidine was the most common that we saw, where it was not inappropriate. The dose modification was needed in renal impairment patients. Yes.
So, what is the average number of medications each patient was taking?
The average number of medications was around 7 to 8. So, in total, I'm saying.
So, how many were surgical patients and how many were?
In our population, majority of the patients was medicine patients. So we couldn't get many surgical patients. Out of the 141, around 100 patients were medicine patients. Around 40 were surgical patients.
The total picture, but Tanisha, does it show where we can load the other? We can't move this side. So that when you answer the question,
yes,
I probably received the last question. Go ahead and we can load the presentation for the other speakers.
So in PMS, what are the distribution like medical?
PMS, the distribution of more equal in all the wards.
Thank you very much. Let's move on discussion. The last comment, I was thinking you said it is scalable, but to make these interventions actually what most needed before it can come as a national policy. Implemented. All this lady. So have you done that groundwork? I mean, before we come up with a policy and then say that it has to be implemented across all sections?
Right now, the time constraint would be the matter. Like even if you do not have a list of pharmacists,
tertiary level hospital or medical colleges, medical college hospital.
Not
Not completely bad of. Okay. Thank you so much.
Anyway, it is simple question. It's over. Now you can.
Thank you, Dr. Anushka. We next have Dr. Chakravarti Rao to answer this.
Yeah, that's it. We'll just take a break from the patients, clinical data, etc. Come back to the lab for all chemistry school, maybe. Thank you. Today I'm going to talk about comparative stability analysis of RNA in dried blood spots for real-time PCR-based molecular diagnostic testing. Okay. Number. Oh. Perfect. Okay. So for people who are known to the laboratory, maybe they know what is DNA, what is RNA. The most problem that we foresee, we come across when we use RNA is it's quite unstable. We need some methods to make it stable from the matrix that you are collecting. It could be saliva, your whole blood, or it could be any tissue that you are collecting. So for that purpose, there are some molecules or some solutions that are available, which are basically high salt content solutions that inactivate these RNAs in the environment so that you can make it stable. But the problem is you need cold chains, you need some temperature controls. And we know that dried blood spots in analytical chemistry and in the drug analysis labs and TDM labs, they have been using this matrix for stabilizing the plasma or whole blood. So that the molecules in this matrix becomes stabilized and you could keep them at room temperature without any cold storage requirement. So why not, the question we ask is, why not exploit the advantages of both systems? Why not we treat DBS cards with RNA later and to make it more elegant so that we can use DBS cards at room temperature so that you can ship RNA samples or a matrix in which you would like to extract RNA to a center where they can do molecular diagnostic testing. So that is the question we asked, and that's the objective to explore RNA stability in DBS samples stored at different temperatures. Because if you want to test, if you want to implement that, you need to test this hypothesis. And this is the pilot work, as I said, this is the research in progress. So we just began this story and journey, and it's a long way to go further when it comes to actual implementation. So what we did is actually we took anonymized blood samples from our transfusion medicine department. And then what we did is we used treated DBS, that means RNA later is treated on this DBS cards a day earlier. And then you apply the whole blood on them. And you also have untreated DBS cards on which you apply the whole blood as well. And you also have the whole blood by itself that you can use to compare with these two setups. So basically, you take the whole blood, you extract RNA from it, you place it on the DBS which is untreated, you place which is untreated, and then you extract RNA and you compare for the quantities and qualities between these three conditions. Of course, at different time points and different temperatures. And further, we also would like to test, okay, it's okay, the RNA maybe is available, but maybe it's fragmented, maybe it's not in a good condition to be available for your test, the final test that you are going to do. So further, what we did is we did amplification of in-house gene, ABL gene amplification using cyber chemistry reactor PCR. So we used this RNA coming from these three different points and matrices to amplify this gene of our interest. And this is what you could see the results. So look at the temperatures, the room temperature, because that is what our aim is in the end. Because, for example, some of this molecular test, which is prognosis, patient has to come to the clinic and give the sample, or somebody has to go and collect the sample and then use cold storage to deliver it to the laboratory. Why not patient himself can put it on the spot and then send it at room temperature? That is the ideal scenario. And if you compare the room temperature, the quantities and qualities are much similar between the three different conditions, at room temperature and also at other conditions. If you look here, blind icon plots here, you could say that day one RNA later treated DBS part, the RNA quantity is completely within the limits of acceptance, which is not the case with whole blood, which is available in the UDTA
directly register. So it is a cold chain, it is a temperature control, where the DBS does not require temperature control. And that's what we also compared by studying the APL gene amplification. Here on the x-axis, actually there is a CD threshold, and this is the CD value on the y-axis, and x-axis is actually the different conditions that we use in our setup, which is actually this is the heated DBS and untreated DBS, and this is the sorry, it's vice versa. This is the untreated, is the treated DBS, untreated DBS, and this is a full bed. So the lower the CD value, the better is the quantity, the gene which is present in abundance. So it has also, I would say that it's a proof of principle or a kind of a pilot study that proved us that provided some insights that maybe this idea is feasible to take it forward. So the next, what we would like to do is, we would like to design a complete study to be able to apply this method for amplification of PCR-ABL gene, for example, that is the molecular diagnostics that people usually need it. They need prognosis every 6 months or every year or every 3 months, sometimes in the beginning. So best way is that people test for such condition using clinical samples and with proper study design, of course, and validate this method for future implementation. So I thank you for patient listening, and I'm happy to answer if you have any questions. I also thank the Deep Research Office for providing learning research resource allowance for buying some of the reagents that we use for research. Thank you.
Thank you, Mr. Secretary. This is really interesting, and given the increase in number of molecular diagnostics that are coming up more and more for various diseases, clinical conditions, this will be very useful. But if I may ask the first question, what is the comparison between the quality and quantity that you obtain from RNA-related treated DBS as compared to a sample that is stored in a packed sheet in -20 or -18 degrees?
Yeah. So in our study, we haven't used the packaging tube because it also requires a specific requirement, because packaging tubes don't come for free. They are not that they are expensive. But what we have used is only EDTA tubes, the whole blood storage EDTA tubes, but at room temperature and at 4 degrees and at -20 degrees. So when the whole blood is at -20 degrees, we have a better quantity and quality compared to the one that is kept at room temperature. But the treated DBS cars, even they are left at room temperature, we have a similar quantity and quality compared to the -20 whole blood.
Any more questions? There are questions from the audience.
Yeah.
It's very nice presentation. And just thought that regarding the plant one, when you are discussing about the plant one, we thought that values are within the limits of agreement. That we are able to observe. There is a pattern also. And also in the plant one, the limits of agreement is just a statistical measure. That's not truly says what we want to. If the difference is even small difference makes a big sense for us in a clinical way, then we need to consider that more than just simply that the limit of agreement is within the point that is.
I completely agree with you. That is the reason we have to further test at the level of actually for the final purpose. What exactly you need this material for?
We wish you all the best for your success in this study. Are there any questions?
No, sir. So how do you explain the decrease in quantity of the RNA when stored at -20 when compared to room temperature? We expect it to be better than at room temperature.
Yeah, it's some variability could even occur at the level of processing, as you know that it was done by a return guy who has come for a return ship in our lab. So there is a kind of personal variability also could have been existed there, but ideally, if the untreated RNA later is not added to the whole bag, even if it is -20, the moment it falls for extraction process, this time point is good enough. This time frame is good enough to have the degradation of the product. These are the pre-analytical problems that I think most of the people are also not really focused upon when they plan any proper studies actually. In genomics or biologics.
I need to ask, how did you, what is the sample size
So as I mentioned, that was a pilot proof of principle study.
So for the pilot also you.
So pilot is n equal to 6 for each of the conditions that we have used.
What time did you take to get the sample size?
So we considered that we don't want much 10% difference between the fresh day 1 sample of the whole blood compared to the day 7 of room temperature treated PPS score. So the difference should be less than 10%.
I wanted to know if the day 7 is the ultimate or you can go day 14 also. Why do you
Yes,
take that?
that is our future step that we would like to do in future. Because our resources were finite, so we wanted to restrict to day 7. And the idea was that maybe the post will take maybe 4 days or 5 days to reach the laboratory, or more than that. So sure.
This like suppose it is n equal to 4 in each condition.
Sorry, that was there are 6 for 6.
So total it is 6 into 3.
Not 3, it's 4 conditions. So you have the room temperature at 4 degrees and 20 degrees, and you have treated, untreated, and then folded. So it's 6 at each condition.
And that these are normal healthy controls.
Yeah, these are all normal donors, anonymized blood samples that were left over in the blood bank.
So what is the difference between treated and untreated debase?
So basically what we did is the treated one, we applied 10 microliters of parenolate the previous day, and then we let them dry at room temperature, and then we use the same cards for applying the whole bed other. So basically, it's like applying 2 times the liquid on the DPS. That is because we would like to have the deposition of the salts from RNA later there, also having alteration of the pH in our DBS scores, because usually the DBS scores are neutral. RNA is going to be acidic, and we know that RNA's enzyme can be inactivated in acidic pH. Of course, because of the salts. But
the whole blood, the quantity of RNA is taking significantly more compared to the untreated and untreated DBase.
Yes, on day 1, precisely, yes, it's better matrix. If you use it freshly, you don't want this matrix. You can directly take the whole blood immediately and then process it for your RNA extraction. But if it's something that's done later time, we don't know yet, but it's maybe another possibility that we should test. And evaluate. Thank you.
Thank you. Now we call upon Dr. Geeta in the Department of Ophthalmology for our presentation.
This one. That's good. Yeah, but this is very
A very good afternoon to everybody. So I'm presenting an ophthalmology research study. So we are looking at the title of my study is that cataract affects the macular ganglion cell thickness more than the peripapillary retinal nerve fiber layer thickness. I'm sorry, this sounds like a lot of Greek and Latin to you, but I will explain in detail what all that means. So I'm not going to do that. So I will be talking about the spectral domain optical coherence tomography, which is a valuable cutting edge imaging tool for evaluating glaucoma and other retinal pathologies. So the image that you see on this image shows a normal fundus, what a normal disc kind of macula looks like. And this is something what glaucoma looks like. There is an increase in the diameter, in the disc diameter, and there is a bit of cupping there, and this will need to be evaluated. So this often will be evaluated using the spectral domain OCT. So what the spectral domain OCT does is we image an area about 3.4 millimeters from the margin of the optic nerve, and we get an output like this. So what happens here is we get quantitative measurements of the retinal nerve fiber layer. So this is the essentially the retinal nerve fiber layer, the topmost layer, and this is the average value in this circle. So that is what this measurement is about. And another measurement is related to there's another measurement called the macular ganglion cell layer. So this particular circle, this is the fovea, and there's a circle around it. So this area in between is where you have the maximum concentration of the ganglion cells, retinal ganglion cells. And this particular measurement, this gives you a measurement value of the ganglion cell layer in this particular area. The red here is essentially loss of the ganglion cells. So this is just an animation to show that this is the retinal ganglion cell in this area, and this is the axon, and this is how it will travel on the retinal nerve fiber layer as I showed you, and this will eventually become the optic nerve. And this is what is lost. What we call cupping is a loss of these axons at the optic nerve. So that's what glaucoma is about. This is just to explain things. So the measurement of the parapapillary retinal nerve fiber layer and the macular ganglion cell layer in a plexiform layer is valuable for evaluating glaucoma and other retinal pathologies. The acceptability of measurements is determined by the quality of the image, which depends on the media clarity. The influence of cataract is important because patients with glaucoma tend to be older and have coexisting cataracts. So what happens is when patients with glaucoma develop cataract, they may be mislabeled as progressing on the imaging studies. And this can lead to overtreatment. Following cataract extraction, the baseline imaging values will need to be reestablished for these patients. So the research question is there any change in the measurement of the parapapillary RNFL and the GCIPL following cataract surgery, particularly in patients with early cataract in whom the quality score is deemed acceptable by the manufacturer? So that's a prospective comparative study, and patients greater than 40 years presenting with age-related cataract who are planned for surgery were enrolled. And the exclusion criteria were other conditions affecting media clarity like corneal opacity, vitreous hemorrhage, etc. Any retinal or optic nerve pathology would also affect the retinal nerve fiber and the ganglion cell layer measurements. Signal strength of less than 6. Signal strength of less than 6 is considered unacceptable by the manufacturer himself. So we will not take patients with signal strength of less than 6. Basically, patients with very advanced cataract who do not fall in the category of manufacturer, what we call accepted imaging quality, will be automatically excluded, and patients who develop intraoperative and postoperative complications. So the methods: after informed consent, 47 patients with uncomplicated age-related cataracts more than 40 years were planned for surgery, and they all underwent complete ophthalmic evaluation. They underwent imaging with the Carl Zeiss Meditech Series HD OCT model 500 and and OCT scans of signal strength less than 6 were excluded from the study, and the scan with the best signal strength was selected from the 3 scans from each eye. Standard phacoemulsification and in the back foldable clear non-tinted tinted PCIOL was implanted. So even tinted PCIOLs may cause a decrease in the image quality. Post-operatively, the SD-OCT parameters were recorded after 1 month. The sample size was calculated using sample size calculation for parent comparisons based on a previous study where they found that there was a 3 micron pre and post difference and micron difference between the tested parameters. And the data analysis was done using the paired t-test or the WSR according to the normality assumptions. So out of the 47 patients, 21 patients were predominantly posterior subcapsular, 26 were predominantly nuclear cataracts, The mean age was 59 years and 61% were men and 39% were women. We compared the effect of lens status on the SDOC parameters and the effect of cataract surgery in altering the signal strength and resulting SDOT parameters in both groups. So we looked both at the signal strength and at the resultant measurements. I will just answer that. So the signal strength changed by only 1 point, but the RNFL thickness changed significantly in both the categories, pre and post-operatively. But the ganglion cell layer measurements were affected all across. All the ganglion cell measurements that are given by the machine were affected. So this is the RNFL, the measurement. This is just to show you how it changed in one illustrated case. And this is to show you the ganglion cell measurements, how they changed in one particular case. And irrespective of the type of cataract, whether it was nuclear or posterior subcapsular, the results were the same. The cataract surgery proved beneficial in improving the quality scores and increased the RNFL and GCIPL measurements, and there was no significant difference based on the morphology of the cataract. The glaucoma is known to cause thinning in the RNFL. Cataract has a bearing on the signal strength and measurements obtained by SDOC imaging. It is crucial to bear in mind the potential influence of cataract on measurements when making decisions regarding progression and management. And in our study, early cataract affected the ganglion cell measurements much more than the retinal fiber layer measurements. And the mechanism for this remains unknown, maybe an algorithm failure. In early cataract, analysis of RNFL thickness may be more reliable to estimate progression of glaucoma. Selective loss of GCIPL with relative sparing of RNFL early cataract should be considered. In advanced glaucoma, exclusion of cataract-related dampening should be seen before we say that it has flowed already. And one must re-establish the baseline following cataract surgery. So we found only 3 studies prior which have looked at this, but all of them were incomplete. 2 studies did not evaluate the ganglion cell layer, and 1 study did not look at the quality score at all. Limitations was that we did it on normal patients and not on glaucoma patients, so we need to do that further. And our study did not show a significant effect of the morphology of cataract on the OCT measurements. And by the maybe because it was not powered for a subgroup analysis based on the morphology of the cataract. So we conclude that the measurements of GCIPL thickness are more affected by the cataract than the RNFL. And it is necessary to examine for evolving lens changes before suspecting progression and going in for overtreatment. And we should also reset the baseline following cataract surgery. Thank you.
Thank you, ma'am. In interest of time, could we limit to just 1 question? Thank you.
It's a nice presentation. Actually, you told in methodology it is in comparative studies, but it is on only a single study. I think you don't have a comparison.
Post comparison.
That is much. I think so. If you had a control group, no, that would be more effective for the study. When you have a control group without cataract,
but there is no significant change in 1 month in such a group. Yeah.
And why do you take that 1 month as a date for reevaluation?
Yeah, because you need the healing time for the cornea and the other tissues for the imaging to be clear. If you do the imaging after 1 week, the imaging will not be successful or clear.
Very good study. So, good things. So, whether this hypertension, diabetic retinopathy were excluded?
Yes, sir. They were all excluded. All retinal pathology based.
And what the possible explanation being mismatch your finding the norm layer and the
Yes, sir. So that is what is the algorithm failure, the manufacturer algorithm. Because if you say it is affecting, it should affect both parameters and not just one. So we are saying it is some algorithm failure, which the manufacturer needs to look at. And from the clinical point of view, because this is a very well-established machine, it's used all over the world. So this is sort of like a caution to the users so that they know that this is what.
Thank you.
Thank you, Dr. Geeta. That was really nice discussion where there is a time we are not able to further proceed other questions. We go to the next speaker. We have Dr. Saranya R. from the Department of Anatomy from JIPMER Puducherry. Over to you, Dr. Saranya.
Very good afternoon, one and all. I'm Dr. Saranya, Associate Professor, Officer in charge of Anatomy. I'm going to present on the topic Operational Challenges and Qualitative Insights on Voluntary Body Donation in a Coastal Indian District. So, we all know that anatomy education is experiencing a paradigm shift. We are trying to shift from unclaimed bodies to voluntarily donated bodies to ensure the ethical compliance. And we know that post-COVID, there is a very heavy crisis in the budding institutions and there is a scarcity for the cadavers. And we know that bringing awareness will lead to pledging, but we do not know how many who pledge actually come to donate, and that number remains critically low. So in our existing quantitative surveys fail to capture the deep-seated psychosocial and cultural resistance with respect to this, and voluntary body donation faces a very low awareness and cultural hesitancy that necessitates a primed focus group discussions to explore the attitudes beyond just knowing the numbers. So the aim of the study is to qualitatively explore the psychosocial barriers, cultural stigmas, and generational dynamics influencing voluntary body donation in our Karaikal district. So our objectives were to pinpoint key restraints, that is a family veto, fear, to evaluate the prevalence of misconceptions and to analyze attitudinal divergence across the different generations, and to formulate strategies for the targeted awareness campaigns to convert the pledges to donations. So we chose a qualitative study with a prime focus group discussion, priming in the sense because there is absolutely very poor awareness about the body donation among the population of Karaikal district. We gave them an awareness talk for about 15 to 20 minutes, and after giving 2 to 3 weeks time, we intervened. We conducted the FGDs among the 3 different populations, and the transcripts were coded and analyzed using thematic analysis. We had a FGD guide that included questions on opening and knowledge assessment with respect to body donation and procedural awareness, and there were a lot of time spent to dive deep into the attitudes, motivators, and the barriers of body donation, and then we had a wrap-up session. So coming on to the results, the major theme that was identified in the majority of FGDs were about the knowledge and awareness gaps. So there is a lot of conflation among the public regarding the organ donation versus body donation, and there were procedural confusions, and there were some themes that were coded under the uncertainty in the elders about the donor eligibility, and there are also some themes that are derived under the misconception about incentives. So coming to the motivating factors, there were many among the FGDs. We could hear some motivating factors about the knowledge regarding the educational and research utility of the bodies, and there is we observed the pragmatism that at least some people thought instead of cremating the body, it can be usefully donated to the medical field, and codes like coming under the social proofing and the family pride, this played a very major role. They said that some examples in the social in their surrounding population would actually set examples for others to follow the same. So coming on to the restraining factors, in the youth population, we could observe a lot of young age fallacy, even in the adults. They said like, there is a plenty of time left behind. Why to think about this now itself? And the family veto power. This is the most important factor which we could observe in many of the group discussions. That even if I agree that they want to agree that they are ready, but their family members, the surrounding social and cultural beliefs and all were hindrance factors for this. And coming to the social stigma, that one unique observation that we could make is that beyond that, donating the bodies for the medical education, they believe that only destitutes or orphans and unclaimed bodies are only deserved for being donated for the medical education. Not that deserved, that just they felt it is only ideal, that is only possible. And coming to the discussion, in this existing literature, there are a lot of knowledge attitude practice studies conducted among the medical population and general population in some states of the country. And if at all there are some qualitative studies existing, it is with respect to the donors who have already donated the body. In-depth interviews have been conducted. So our study has addressed the gap in literature. We try to approach the family veto dynamic and how the attitude is changing with priming sessions. So coming to the advantages of our study, this primed FGDs actually helped us to assess the informed attitudes rather than baseline ignorance, and we could nicely understand the family veto dynamics, opportunity to address a misconception. This is we feel this is a gift for us. While we try to approach the population, we could actually get a chance to correct the myths in real time. And there were some lot of difficulties in conducting the study. And first thing is that to get the permission itself, it was very difficult. Then we had a mismatched expectations. People were expecting JIPMER doctors came for conducting medical treatment camps, but we went for giving them awareness camps on body donation. And using sensitive words like death and all was very difficult first in the initial phases to build a rapport, and there was a very latency for building the trust among the population. And our data is restricted to only Karaikal population because it is a qualitative study, and there is a selection bias in, especially in the youth people. We could observe that there is some social desirability bias. They were actually telling, but we do not know really inside their heart whether they will be willing to donate or not. So our conclusions and recommendations is we have to have an integrated outreach program to destigmatize the topic by coupling regular spaced awareness campaigns with community medical camps to reach the entire family unit. And the word voluntary whole body donation should be aggressively normalized. People have to be aware of the topic. Then later it takes years for them to accept and then come to donations in future. And the ritual accommodations, we could actually hear from people about the final rituals. So if we institutionalize the return of ashes or designate the specific memorial spot for the families to actually come and deliver their prayers, it would be more useful. And social proofing, elevating the donors to the hero status. It has been done in many of the central institutes nowadays by visible recognition such as wall of honor or ceremonial harmony salute for the donors. Actually will encourage the rest of the people in the public to follow the donation process. I sincerely thank the research DESAT committee for allowing us to do the study, because it is the main pavement for us to procure bodies in our district, where ours is the first government institution. Thank you so much. These are my reports.
Thank you, Dr. Saranya. That was really interesting study. So questions from the
Yeah, sir, it was nice. Actually, you did not tell me how many people were in that age group at elderly age, because that might have an influence on your study outcome. Because the perception you told of 20 minutes or how much they would have perceived. So yes, depending on that, we cannot generalize this is a thing.
Yes, ma'am. Actually, we had enormous data. This we are doing in all the populations across the entire district in periodical manner. So the best out, I mean, not means the best. We have beyond these groups. There is some data
So
set.
the majority in your group?
So majority, actually, we had equal numbers, but very less numbers in elderly age groups we got. Because whenever we tried to go to the rural population, we had more of adult people only. It was very difficult for us to get all the elderly together. For that, we went to old age home. In the old age home, they are already prepared to in that state of donation. So.
Do you think this could have had some bias on your outcome? Because you were less sane people, they would have been better understanding.
So actually, we in the elderly people's one group was less. We conducted more and more and more. Actually, we in the adult groups it is more than 12 or 15. Initial 5-10, it took time for us to understand how to do this FGDs itself. So we were finally able to reach the number, but still ours is continuing, ma'am. Majority we did in the adults.
Yeah, one more you told the ritual accommodation something.
Yes.
What is the last one? You do some hero thing.
Yes, ma'am.
Is it feasible to do all those things?
Actually, in AIMS, in West Bengal and all, they are doing, ma'am. AIMS Bhopal, they are doing. They are giving army salute for the deceased people, and that's how the relatives are feeling honored, and the public is getting motivated because of this.
But okay, it's done in a Karaikal, you cannot generalize yet.
No, if we have not done, ma'am.
No, I'm telling you, you told AIMS Bhopal. You are in Tamil Nadu, you are telling this is the way.
Our recommendation is we have to institutionalize if possible.
I think there are no other questions. Thank you, Dr. Saranya. We will move to the next speaker. Now, we call upon Dr. Jawaharlal in the Department of Surgery for his presentation.
Very good afternoon. So myself JIPMER, Additional Professor, Department of Surgery, JIPMER. So I'm going to present this study titled Effectiveness of Polyethylene Glycol combined with linaclotide regimen for adequacy of bowel preparation in high-risk and chronic constipated patient undergoing colonoscopy. It is a single-blinded randomized controlled trial. In our own study in our institute, we found that 1/4 of patients undergoing repeat colonoscopy because of inadequate bowel preparation. So currently the guidelines suggested a special regimen for special patients like chronic constipation with high risk factors. So many drugs have been combined with PEG like bisagodil, ascorbate, magnesium citrate for high quality bowel preparation, but that the use is limited because of significant side effects. The recently the linaclotide is a drug used for irritable bowel syndrome type C and idiopathic chronic constipation, which exclusively works on the intestine to increase more fluid secretion and speed up chronic transit, and which help in colonoscopy preparation with minimal side effects. That's why we want to analyze this drug with the standard care for bowel preparation. So coming to primary objective was to evaluate the effect of using linaclotide as a adjuvanting agent with PEG for adequate bowel preparation in high risk and chronic constipated patient for colonoscopy. The secondary objectives were patient compliance, acceptability, tolerability of bowel preparation, and patient satisfaction rate, acceptance and tolerance of procedure performed, total duration of procedure in minutes, willingness to repeat the same regimen or scopy, and polypadenoma malignancy detection rate, and finally surgeon satisfaction about the procedure. So coming to the methodology, this basically this is a prospective single-blinded double-arm randomized control trial. It was done in the Department of Surgery and Medical Gastroenterology for 2 years. The study included all the patients planned for elective colonoscopy with various indication with the history of chronic constipation and the high-risk patients. Especially we selected a Bristol stool form scale 1 and 2 only. We excluded 3 and 7. And other inclusion criteria was prior history of inadequate bowel preparation. The exclusion criteria were the 3 to 7 BSS scale score and previous history of colorectal surgery or bowel resection, or patients taking linaclotide within 7 days, or any drug allergy, or pregnant and lactating woman. So coming to the sample size calculation, we assumed that the success rate of adequate bowel preparation is 87.9 compared to 77 in the control group with the power of 80 and alpha error of 5. The final sample size was calculated as 430 and 215 in each group. These are study parameters before colonoscopy: complaints of bowel preparation, patient acceptance and tolerance of bowel preparation, drug compliance, sleep disturbance. During colonoscopy, and quality of bowel preparation by using a Boston Bowel Preparation Score scale, and endoscopy findings, fecal intubation time in minutes, withdrawal time in minutes, total duration of procedure in minutes, and surgeon satisfaction. So after colonoscopy, again patient satisfaction rate, acceptance and tolerance of procedure performed, willingness to repeat the same procedure, incidence of adverse events, polyp and adenoma malignancy detection rate, and patient satisfaction. This is a concert flow chart. Once the patient fulfilling the inclusion criteria, patients were randomized into one of the group. In the conventional group, this is a split dose we used with bisagodil, that is a Dalcolax. In the another group, interventional group, we used linaclotide drug. So after that, we analyzed primary and secondary objectives. These are baseline parameters like age, sex, BMI, smoking, alcohol, and comorbidities. All parameters are equally distributed in both groups. This is the quality of bowel preparation. So the total, Boston Bowel Preparation Score was in the linaclotide group was 8.78. That means it is excellent bowel preparation. Compared to standard is 6. That means it is adequate. That values are statistically significant. So coming to the intubation time, withdrawal time, total examination time, first time of defecation are almost same in both groups. So because of it having high transit time, that defecating frequency also very high, in the linaclotide group. So because of his excellent bowel preparation, that the polyp detection rate and adenoma detection rate also very high in the intervention group. So coming to bowel preparation adequacy, almost 75% of colonoscopy was adequately or excellent the preparation compared to standard group, that was 63%. Coming to colonoscopy success rate, that means how we frequently complete the procedure. That means almost we completed 95% in the interventional group compared to control group is 88%. This is a total post and bowel preparation score is more than 6 in the all segment. That colon is divided into right colon, middle colon, and left colon, and rectosigmoid. So each segment should have more than 2 score, and all the combined score more than 6. That means that bowel preparation is excellent. So we achieved that excellent bowel preparation almost 80% in linaclotide group compared to control group. This is the secondary outcomes. Patient satisfaction, almost 90% have well satisfied, and compared to tolerability, almost 38% have moderate compared to 55%. Coming to the complaints of bowel preparation, almost 43% have excellent complaints, and coming to the overall satisfaction, almost 96% having a good satisfaction overall the procedure. These adverse events, nausea, vomiting, bloating, is all equally distributed in both groups. So coming to is very important. Willingness to repeat the colonoscopy. Almost 94% patients are ready to undergo repeat colonoscopy procedure. So coming to this, identifying the risk factors and developing intervention and patient complaints and tolerability. These 2 factors are very important for bowel preparation. This linaclotide has demonstrated good efficacy and safety in this study. This limitation is single center study, and we didn't include the high risk and chronic. We included only high risk and chronic constipated patient only. So very difficult to reflect the broader population. Almost we excluded all gastroenteric motility disorder. That is also very difficult to substantiate our findings. And no data for indication of colonoscopy also. It's very difficult for daily clinical practice. So conclusion: this study demonstrates PEG with linaclotide regimen is superior to standard PEG with bisacodyl in achieving adequate bowel preparation. Thank you. So we received for 2 lakhs for this study as an income fund.
Okay, so for university study, how did you randomize? What is the type of randomization we will see? Whether it's a block randomization or
it's a block randomization.
Anybody mentioned that, right? And how was the allocation concealment ensure?
This standard envelope care.
And who was blinded? Single blinded?
It is a single blind, only patient only blinded.
Only the patient was blinded. But you were aware of what was?
The surgeon is aware of this.
Surgeon was aware of the interventions. Then is the sample size calculated according to the superiority design?
Yes, sir.
Huh?
Yes, sir.
So what was the superiority design? What was the sample size calculated? Can you have a look?
It is we expected 87% from the previous study, but compared to our own study, it is 77% of adequate bowel preparation. So based on this study only, we calculate the sample size.
Did you follow intention to treat analysis?
Yes, sir.
For the protocol analysis?
Intention to treat them.
So that means 215 in each group would have been there till the end.
Yes. We achieved this case because of we involved medical gastro also. So we achieved the sample size before this also.
This was study registered in the CPRI?
Yes, sir.
Good study there. So this bowel preparation before colonoscopy, is it every 5 or we have to add additional drug in all the cases?
Sir, I didn't get you, sir.
For the bowel preparation. So whether PEG is sufficient enough or we have to add the additional drug in all the cases?
Usually we'll give Peclet for 2 liters. This is a split dose. Night also we'll give, and the morning also they'll take. In addition, usually we'll give Dalcolus. That is a standard. So So we'll give in this group, we'll give linaclotide. This is a safe drug.
So here you have shown that your drug has the better preparation and the science fiction also score. So if you do like cost effective analysis, do you think it will be like
The
superior?
drug cost is almost 100 rupees, sir. That drug is. Dalcolas, it will come 10 rupees. But
So it is 10 times.
10 times. But if you ask the patient for repeat colonoscopy, because we included all high risk chronic constipation with high risk patients only. So rather than spending 100 rupees, calling the patient for repeat colonoscopy, it is more painful for patient also, for us also, because we have to give again backlog, we have to call, because every day we are doing some 5-6 colonoscopy. It's very difficult.
The every bit is expensive to prepare.
The 100 rupees is not that much expensive compared to calling the patient for repeat colonoscopy.
So that, but according to the result, the colon preparation is very good, so you can evaluate better the single colonoscopy.
Yes, sir, yes. Yes.
Thank you.
This is very has been done anywhere also. This is the first time you are doing it in our institute.
The Western countries they've done, but in India it's the first.
Okay. Our standard of care in institute is paid with Antipode is the standard. It's a standard. It's available in Japan. Linaclotide is also available.
Linaclotide we purchase from outside.
How is the detection rate is more in linaclotide compared to this thing? Because of the adequate bowel preparation.
Because of adequate, visibility is very good. So polyp detection, malignant detection is very high. It's based on the surgeon's feedback only. Also, we got a feedback from endoscopy sister also.
So why did you think of blinding the surgeon?
Patient is blinded. Initially, I proposed like a double blinded only, but it is technically is not possible, sir, double blinded, because that surgeon also will know, and whoever analyzing the data, that resident, the PGGCs, he is also know, is technically is not possible double blinded. I think in our center.
It goes for both discipline and also
yes, sir. Yes.
So if the same number of splitters being given.
Yes.
So definitely, and if the drug is covered.
Same, yes, covered.
Then the value of the paper would go right.
Okay, double blinded.
And regarding the assessment, the scoring system for the agriculture qualification.
But in the interest of time, we have to conclude. We can have discussion over TIS. Because there are few concerns that are which you would have to address before you go for publication, like objectivity of the outcome assessment and all that. But thank you so much for the discussion also. But we are really sorry to have stopped you. We have to finish because we are already late in one more session.
Thank you. Thank you.
Thank you so much. We move on to the next speaker. We have Dr. Prabhu from the Department of Physiology.
Good evening, everyone. My topic is prognostic impact of hematopones and CD34 positive myeloblast in bone marrow of a B-cell acute lymphoblastic leukemia without measurable residual disease after induction therapy. To give a brief overview about this topic, hematopones are nothing but a normal B-cell progenitors in the marrow. Similarly, the myeloblasts are also considered as a normal myeloid progenitors in the marrow. The CD34 is nothing but an immaturity marker which is used to identify the myeloblast. In the treatment aspect, especially for this B-AML patients, that is a B type of an acute lymphoblastic leukemia comprised of 3 phases, which includes a high-dose induction therapy followed by consolidation and maintenance therapy. So what we do is at the end of induction phase, we do the marrow to look for residual percentage of a blast. If less than 5% of blast is there, we call it as a morphological remission. In this subset, the another important aspect is that we should use the flow cytometry to identify the residual leukemic blast is present or not. If one leukemic blast is present in the background of 10,000 normal cells, that cutoff will come as 0.01%. This cutoff is kept as a measurable residual disease. If this percentage is more than that, that is considered as an MRD positive. That means the measurable residual disease is still present, which indicates that there is a high chances that the patient will go for a relapse. So, but the thing is, even if the MRD status is negative, still 5 to 12% of the patients in the literature says that these patients will ultimately relapse. So we need a special biochemical biomarkers to identify other than the MRD status to predict the relapse in such patients. So we chose hematogones and the CD34 positive myeloblast for this study. The rationale is that the hematogone, if it is present at a higher level, which indicates that the marrow microenvironment is a favorable condition, which will not allow the tumor cells to grow, indicating that there will be a better recovery. So subsequently, there is a better prognosis and a better overall survival. However, the role of CD34 positive myeloblast remains unclear, or it is debated in some of the papers. So we want to study these two parameters in the ALL patients. So the aim of this study were to investigate whether this hematogone and myeloblast at the end of induction in MRD negative BALL patients is having any correlation with the baseline biological parameters or not, with the marrow recovery at the end of induction. Then does it able to predict the relapse and subsequently its survival outcome? So the materials and methods, this study is completely in the retrospective forward study. We included the patient from Jan 2020 to June 2024 over a period of 4.5 years. And all these patients should have at least the minimum 1 year of follow till June 2025. So we included the entire cohort of BALL patients who are treatment naive, and the treatment should be done here with a minimum follow-up of 1 year, provided the MRD status is known to us, which should be negative. So we excluded those cases where MRD data is not available, or if the patient underwent hematopoietic stem cell transplant. So the study begins with 188 patients. We screened those patients for the baseline data. Some of the cases did not have the baseline data, so we excluded that. So 168 were the patients where the baseline parameters were available. These patients underwent induction chemotherapy. And then at the end of induction, MRD was positive in 34%, in 34 patients, so we excluded. And during the phase of induction, 3 patients died. So we also excluded those 3 patients. And then this percentage of hematogones and myeloblasts were determined by flow cytometry. And during the study period, there was a last follow-up of 6 patients. So we excluded, and the total remains 125 for calculating the relapse-free and the overall survival. So these are all the different protocols used. These are all the published guidelines-based definition for assessing the overall survival and relapse-free survival. So this is the flow cytometry data. We use so many field markers to identify the different type of cell populations. So this population indicates the hematogones based on this definition criteria. And this is a myeloblast. And then we calculated the percentage from the flow cytometry. So these are all the different statistical analysis used in the study, and p-value of less than 0.5 is considered as a statistically significant for this study purpose. Coming to the results, in this baseline clinical parameters, almost 60% were the pediatric population, and 40%, close to 40% were the adolescent and young adult population. And in our study, most of these patients, if we do the risk stratification, close to 40% were high-risk categories. And one of the important prognostic parameters is that the total count at the time of presentation, we will look at it. If it is more than 50,000, that carries a poor prognosis. So such patients were 20%. We constructed the ROC curve analysis, especially for the 2 parameters, that is hematogone and CD34 positive myeloblast, is to predict the relapse. So our study had a median follow-up of 31 months. Almost 31% of the patient relapsed. The cutoff was 0.12% for hematogones, and myeloblast cutoff was 0.06 in predicting the relapse. So we applied this cutoff to the entire cohort. In the entire cohort, there was no statistical significance. Then we thought we applied it separately to the children as well as to the AYA patient, that is adolescent and young adults. In children, if there is a higher amount of hematogones, that carries a better hematological recovery at the end of induction in terms of hemoglobin and the platelet recovery and deeper MRD response. Whereas at the lower CD34 positive myeloblast means there is an association with a longer relapse-free survival. So, and also we looked at the different parameters to identify the inferior relapse-free survival, which includes a higher total count at the time of diagnosis. These are the different PD markers we used. CNS involvement at the time of diagnosis, abnormal karyotype which was present at the time of diagnosis, and its risk stratification. In the overall survival, again, the only parameter was CD9 negativity, and we applied it in the multivariate analysis and the univariate analysis. As mentioned, all these parameters were significant in the univariate analysis for relapse-free survival. For the overall survival, the negative CD9 and the absent high-risk cytogenetics were the two important parameters for overall survival. And in the multivariate analysis, the only parameter which stands out to be independently predicting the survival is abnormal karyotype at the time of presentation. So discussion is that the cytogenetics dominate the prognosis even in the MRD negative ALL patients. The strength includes the homogeneity of the patient population, that is MRD negative patients were included. We used a high sensitive technique, that is a flow cytometry. However, the limitation is that if we dichotomize into children and the AYA patients, it becomes a smaller sample size. We did assessment only at the single point, that is end of induction. There is some degree of a treatment heterogeneity among these populations treated. So this requires other center validation also. So to conclude, this hematogones and CD34 positive myeloblast in the entire cohort did not independently predict the survival. However, in the pediatric population, higher amount of hematogone, if it is present, that indicates there is a robust marrow recovery, whereas a lower CD34 positive myeloblast indicated with a longer relapse-free survival. This association was not observed in adolescent and young adults. And abnormal karyotype, this is a significant finding. Even in the MRD negative BALL group, this turns out to be strongest independent predictor for the relapse. So, the laboratory implication is that it needs to be added to the cytogenetic risk factors along with the bone marrow regeneration markers. Thank you.
Very nice presentation. I just have only one question. You told MRD negative is one of the strongest predictor, but in spite of it become negative 30%, 31%, I think so they showed relapse. Why is it so?
That's what, ma'am. There are so many. Even if we look at the country status, it is almost 50% of even MRD negative. The literature says even lesser, but in our country overall status, 51% of the patient, even if it is MRD negative, tend to relapses. Our data is slightly better than this. The reason is that we do not know, other than this residual disease, some other factors might be there. We do not know still, right? So, this cytogenetics we do by the karyotyping at the time of diagnosis. If there is a high risk cytogenetic at the time of presentation itself is there, we do not know. We require still sensitive technique to pick up the MRD status. So that's the point that we extrapolate.
The subgroup analysis that you've done for children age less than 14 years, I'm sure within that also there will be a lot of heterogeneity. Like for example, children less than 1 year is known to be even worse. Children more than 10 is known to be higher risk group. The group in between may be better.
So generally it is 1 to 10 years carries a good prognosis, less than 1 and more than 10.
So that's why I'm asking, now you've chosen to analyze age less than 14, as if all of them are one group. Within that also there is a lot of heterogeneity, right? So did you observe any differences between age less than 1 year, 1 to 10 or 10 to 14? Majority of
the population fit within that 1 to 10 category. So that may have the
how many infants were there?
Infants were only less. It's out of 72 patients, if you look at it, we had 5 to 6 at the max. I'm not sure about the exact numbers, but I need to. It's not more than
10 to 14. Because 1 to 10 is not same as 10 to 14.
Yeah,
although
I understand. Not in all patients. 1 or 2 patients have a karyotype. We also send it for the fish analysis. If the cytogenetics is not available, fluorescent in situ hybridization, that will also used for risk stratification.
Thank you.
Thank you.
We have Dr. Vedita Phillips, the Department of Preventive and Social Medicine.
Very good afternoon, esteemed judges and moderator. It's immense pleasure. The topic is really depressing. Be ready for that, okay? And my topic is incidence and mortality and psychosocial factor of acute poisoning among adults living in Vilupuram district, Tamil Nadu, a community-based cohort study. It is actually acute poisoning is a global public health problem. It is not only India. So in India, the poisoning is second most common cause of suicide, particularly among young adult, most productive age group. And pesticide is commonly used agent in rural area of Vilupuram or India. And also poor socioeconomic condition is one of the most important factor contributing that. Existing studies are mostly hospital based and retrospective with a limited data on psychosocial factor and care pathways. This current study is focusing on the psychosocial factor and care pathway. So this is the objective among adults 18 years ago, staying in Vilupuram district. The first objective to estimate the incidence and mortality of acute poisoning, to determine the nature, type, and factor associated with acute poisoning, to explore psychosocial factor and pathway for care involved in acute poisoning. The community-based cohort study, it is actually carried out in Vilupuram district among adults. We have done around 2,770 based on the prevalence, the incidence 15,000 with a 30% relative precision. We have taken universal sampling. Almost all the taluk hospitals in Vilupuram, we have taken 10 taluk hospitals along with the bordering hospitals, JIPMER, Venkateswara Medical College, and PIMS. So in each taluk we have received around 250 to 300 cases from each taluk. And the hospital, especially Vilupuram Medical College and the Dindivanam Hospital, JIPMER, wherever there is a more caseload, we have put the 12 hours basis for the field worker, and we got the enough coverage for entire district. Data collection, all the alive patients will be taking social demographic characteristics, poisoning related information, and mental health assessment. Generally, we receive the patient first and stabilize them, help them for admitted. And second day, we try to collect the information. And if suppose the patient died, we collect information from the relatives and case records. So these are the topics we covered. And you see the study population. So more than 55%, so actually from 18 to 30, gender almost equal distribution. You can see the education almost, the distribution is almost, equal except primary education. With respect to occupation status, mostly unskilled worker actually committing, consuming poisoning, and homemaker followed by skilled worker. So this is the objective, the incidence and mortality. The overall incidence of acute poisoning 1.65 per 1,000 population. In the male 1.7 per 1,000 population and female 1.6 per 1,000 population. With respect to the mortality, overall mortality 0.5 for 1 lakh population. But the men, it is 1.08 for 1 lakh population mortality. Let's see the female, it is 0.11 for 1 lakh population. So men almost 9 to 10 times higher mortality, highest second rate compared to women. Most of the nature of poisoning mostly suicidal. But however, surprisingly, that 5.7% is actually accidental consumption of poisoning. The mode of poisoning mostly ingestion, 97.9%. And the most common cause, most of the nature of poisoning generally agricultural poisoning, organophosphorus poisoning, followed by household type of poisoning. And mostly the root cause for the poisoning is family problems. So we need to be very much cautious that family problem is the reason for poisoning. Of course, it has multiple contexts. It's a relationship problem, finance problem, all those things. And if we have assessed the mental status in the day 2 of the patient after consumption of poisoning. So depression is 31% and anxiety 29%, stress is 13%. But interestingly, that the patient not have all these problems also consume poisoning. Instantaneously, they had some trigger event, they consume poisoning. So not necessarily the person should have the mental problem. And healthcare facility, the clinical pathway care, majority they have reached tertiary care hospitals. Only 14.1% reached the primary health center, 18% they reached the community health center or district hospital. The reason we asked why actually you reached that hospital, why not you go to the primary care? Most of the patients they told non-available treatment option, they told almost 71%, and non-available beds around 28%. And healthcare facility, when the patient got treated, almost 88% treated in tertiary hospital, medical colleges. So where we need to focus that, okay, primary and secondary hospital need to be addressed. And mode of transport, almost 54% of the people, they travel to their own vehicle. Government transport, only ambulance, 27.9%. And length of stay, almost 1 day, most of the patients required only 1 day stay. Length of ICU stay around 1 to 2 days, around 30%. So young adult around 18 to 30 years are predominantly affected, consistent other Indian studies during the productive years. Both gender equally affected, but mortality is high among the men. Unskilled worker, homemaker is like majority of the cause for the poisoning. And intentional poisoning, almost 97% intentional poisoning. And most patients are received care at the tertiary hospitals. So, strength and limitation, the largest community-based study that measures the incidence of acute poisoning and includes the investment from primary care to the tertiary care, measure the clinical and social profile of the study participants, trained healthcare staff, data collection techniques rigorous, with the help of psychiatrists. Thank you very much. So, conclusion, this is my conclusion.
Thank you, Chairman. It's very sensitive topic presentation. You already the gender is equal, but the mortality rate is more in male. And you told possibly it is due to. But did you analyze the results? Did you really analyze why the male mortality was more compared to the female mortality?
We have the continuity study that in-depth analysis why actually the men is historically that the men the suicide attempt rate is actually success rate is more compared to women. The reason we need to go for in-depth interview actually the further studies.
I think we know the in-depth reason, then we'll be able to prevent this one thing. Second, about 94% of
basically that we have identified that okay the work stress and nature is more among men compared to women.
By birth, even between conception wise also female do better than men.
Yeah.
So you should do. So you don't
women will tolerate more compared to men, and men will attempt succeed. If you see the incidence almost similar. 1.7, 1.6 per thousand population. The boys they are very courageous to.
The reason telling you, the reason what you told for consumption is.
Yes, sir.
The reason is consumption is the reason, the similar both male and female. But why mortality is more in male?
Sure. We have data for
the type of poison, anything like that.
So basically, the amount of consumption of poison is more among men, and the data we collected, but we didn't put here because of the time.
Okay.
And also the subjective, it is a subjective. The patient may tell, depends upon their conditions.
Critical mortality vary as per the type of the poisoning. Plant-based poisoning are also multiple types, no?
Yes, sir. Yes,
So, which were the plant-based? Apis predator, case of this colonies or?
This
Polytherapy?
Arali, that is actually, yeah. Yellow lander.
So, was this the mortality?
We need to analyze in that aspect whether it is plant-based or, but the most mortality is organophosphorus poisoning. This is very common.
The paraquat cases.
It is also comes under organophosphorus.
Very good study. Even how you collected data from the patient who died
in the home?
No, the patient died.
Yes, generally, patient will come alive to the hospital after that died. Okay. Second day, we used to collect the patient data from the patient attender and also records from the physicians. The case sheet is there actually. So, and we used to collaborate with the family attenders.
No other question. Thank you very much, Dr.
Thank you.
I know there will be a lot of interest on this topic. We can have a lot more discussion after the event.
Thank you.
So we thank all the speakers, the presenters, and all the judges. And we apologize, we have not been able to give enough time for the discussion, but because of we are already running late, and therefore the little bit of hurry had to come here. Thanks to all the co-judges and all the presenters. So the interesting session. Please stay here for the next session, that is the faculty published paper. Those who have not had tea, please kindly go and have the tea and refreshments quickly in the 5 minutes, and we'll start the next session. Thank you all. Thanks, Dr. Sivaranjani. No, because some of us have not had the tea, that's why we have requested 5 minutes. So, just
presentations.
One, two, three,
Ram Kumar Radeshwari.
7. The program. One second. Yeah. Moves the slide.
Yeah, yes.
Try the other side. So probably where else you can use the cursor.
That's what.
Yeah.
Okay, I understood.
Yeah, thank you.
మన బ్యాచ్ కాదు మన బ్యాచ్ వాళ్ళు సెకండ్ లెక్చర్ రాననుకోవడం ఫస్ట్ దూరంగా కడాయి అంటే ఇంటిగ్రేట్ తెలుసు సార్ ఫస్ట్ అది తీసేయచ్చు కదా ఇది ఏమైంది సో ఓపెన్ చేసి ఓపెన్ చేసి పెట్టాలి ఆర్డర్ తీసుకొచ్చేసాను ఆర్డర్ చేస్తున్నాం అవసరం లేదు పెట్టే ఇది already gave them
Thank you to all the faculties of the previous session for their insightful presentations. We now move on to the final session of the day, faculty published papers. It's my pleasure to invite our respected moderators. May I request Dr. Nishad Lakkar, Department of Neonatology, and Dr. M. Jayanti, Department of Pharmacology, to kindly join us as the moderators for this session.
Good evening, everybody. We have come to the last session of today. So this is the faculty published paper presentation. So there are 7 presentations. So without much delay, I would like to call upon the first speaker, Dr. Adi Shiva, to present his paper.
Good evening. I've always enjoyed presenting in Research Day. The audience number is drastically significant in the national conference. So I'm really happy. So we'll talk on something regarding BCG for newborns. All of us know that BCG is a vaccine given to newborn babies to prevent severe forms of tuberculosis. But this presentation is going to be slightly off target, to be more specific, non-specific effects or the target immunity or the trained immunity which we'll be talking about. To keep it simple, imagine an iron dome, right? It can protect the baby from BCG missile, tuberculosis missile, as well as missiles from other bacteria, say Klebsiella, E. coli, etc. So that's what we are going to talk about. So this title was Effect of BCG Danish and Oral Polio Vaccine on Neonatal Mortality in Newborn Babies Weighing Less than 2 kgs in India. It was a multi-center, open-label, randomized controlled trial, BLOW2 in short, was published last year in BMJ. After due approvals from the Institute Ethics Committee and prospectively registering in the Clinical Trials Registry of India. This study was over a period of 5 years from 2017 to 22, which also saw a pandemic in between. And I think I can highlight the important findings over the next 5 minutes. So BCG for newborn, what's the big deal? Is there a clinical equipoise? Yes. The meta-analysis of 3 trials in Guinea-Bissau have shown that BCG Danish actually decreases neonatal mortality by 38%. However, other RCTs which were done with the same BCG but with different strains did not show the same neonatal mortality. So, in fact, the trial of BCG Russia in India, that's a blow one, which was done in the same NICUs, which I'm going to elaborate, did not show any difference in the neonatal mortality, but mind you, the strain was Russian strain. So this is the objective, the Picot criteria. It is giving BCG Danish plus OPV within 48 hours of admission to the NICU to newborn babies weighing less than 2000 grams as compared to delayed vaccination group, which is BCG Danish plus the same vaccine given at the time of discharge. And outcome parameter is all-cause neonatal mortality in the first 28 days of life. So you may ask me, sir, BCG should be given in the neonatal period. So what's the big deal? So the population here is the low birth weight babies, mostly preterm babies and SJ babies. In practice, BCG is not given to them at birth because of the low birth weight and the hemodynamic instability. It is usually given at discharge, but this practice has disadvantage. So the multi-center open label randomized control trial is a design. It was done in 3 NICUs, large NICUs in Southeast India. One was JIPMER. The other 2 are IOG, Institute of Obstetrics and Gynecology, and Institute of Child Health from Chennai. All 3 were in the government sector with significant admission rates. Inclusion criteria, which I have already mentioned, neonates with a birth weight of less than 2 kg. We need exclusion criteria, the neonates with less than 60 minutes or more than 21 days who are unlikely to survive for 24 hours, babies with major life-threatening complications, or who are already vaccinated with BCG, or the usual issues like a mother or baby known to have HIV, hepatitis B, etc. So how did we randomize? It was a computer-based randomization stratified by the NICU, the sex, and the birth weight. Block sizes are varying randomly for 2 to 8 newborn babies. BCG vaccine causes no obvious skin lesion. Masking was not practically feasible. Otherwise, we have to cover the BCG site, so masking was not possible. However, caregivers who assessed whether the baby died or survived were not blinded. Only the statisticians were blinded. So this is the consort flow chart. So we screened around over 7,000 babies. 6,647 were excluded for various reasons. 345 for previous BCG vaccination, 520 for severe malformation, 64 had infections or immune disorders, and 649 were death likely within the 24 hours. So after that, we had 5,420. It's a large number, out of which 2,714 were allocated to the intervention arm, which is early BCG and OPV. And for control, another 2,706. An intention to treat analysis was done, and a number of 2,700 plus in both the arms were there. So as I said earlier, the outcome parameters were all-cause neonatal mortality in the first 28 days. This was our primary outcome. The secondary outcome was death due to infections and deaths in newborn babies or mothers with a BCG scar. And censoring was done at the time of last to follow-up or any vaccination within 28 days. It was right censoring. Pre-specified list of cause of death was used. Sample size. So based on our previous study, the blow one, we expected the absolute number of the expected control group mortality was 15%. We expected reduction in the intervention group by 30%. So the expected mortality in the intervention group was 10.5%. So for a 95% power and alpha of less than 0.01, we need a total neonatal mortality of 510. So the babies were kept on randomizing continuously in all the 3 NICUs till we reached a mortality of 510. To be more precise, mortality in the control group was 300 and mortality in the intervention group was 210. Intention to treat analysis was done using Stata version 18. All statistical tests were two-sided. P-value of 0.05 was significant. Cox proportional hazard models stratified by NICU with age as underlying time. Pre-specified binomial covariates and tested for proportional hazards in Kaplan-Meier analysis. The potential for nonlinear relations in continuous variables were assessed using functional polynomials. Statistics is quite elaborate. I'm just highlighting a few. So coming back to the baseline characteristics, if you see here carefully, the sex, the median birth weight, and the prematurity were all similar in both the groups. Apgar status was similar. In the study hospitals, if you can note carefully, JIPMER contributed almost more than 35% of the babies enrolled for the study. I have not highlighted JIPMER for our institute purpose. Somehow Google had made it JIPMER, so I had to paste a text box there, JIPMER. So this is the primary outcome.
In the primary outcome, the early BCG intervention group, we see that the deaths were only 238 compared to 273 in the control group, which was statistically significant. Deaths from infections were also lesser in the intervention group, 73 deaths as compared to 133 in the control group, which was also statistically significant. If you go to the time for vaccination and death, the birth to vaccination is 0.93 days. 0.93 means most of the babies receive the vaccine within the first day. That's what we are doing in the early BCG arm. Compared to control, because it was given at discharge, it was 12.6 days. Infection was a common cause of death in these babies. So among the various causes, infection was quite common. We had a standard definition of infection, so which was used. In the early BCG, it was less compared to the control group, which was BCG to control ratio was 0.55. Seeing the Kaplan-Meier probability of survival, if you see here, the cumulative risk of death was less in the intervention group compared to the control, and the hazard ratio was 0.83. So what were the key observations in the study? The BCG Danish strain is very important. Actually, it is it causes the scar positivity is more with Danish, and OPV administered neonates, all-cause neonatal mortality was reduced by 17%. Neonatal mortality due to infection was reduced by 47%. The number needed to treat to prevent one death was 21. There was no tuberculosis-related deaths, and BCG Danish most beneficial if administered early. So we also had the Klebsiella as important cause. That also was significant in the intervention group. Less Klebsiella for babies who were given BCG vaccine early. So Danish strain is most effective. The presence of scar is better for the NSC of BCG, non-specific effect. And discontinuation of restrictive vial opening practice. This means one vial we have to wait for 10 babies. That should be discontinued, and we should open a new vial for every baby. You may ask me how it actually, this is a biological plausibility. A lot of epigenetic mechanisms with the monocytes are there. In fact, BCG starts working, the NSC effect starts occurring within 72 hours by emergency granulopoiesis. So BCG Danish and OPV given within 48 hours of birth reduce neonatal mortality in very ill newborns weighing less than 2 kg with the number needed to treat being 21. Thank you.
Thank you, Dr. Aditya. That was a very simple intervention with a great impact. I would request the judges and the audience. Wow. Yeah, the nice presentation, but how do you explain the strain between fraction and damage?
Yeah, as I said earlier, the blow one trial, which was done in the same setting, the same 3 NICUs.
So what is the reason? What is the difference in the strain?
The strains are containing the BCG, live BCG vaccine. However, they have been maintaining these 4 different labs. One is Russia, one is Tokyo, one is Bulgarian, other is Danish. Of all the trials which have been done, Danish is more potent. Whereas, in fact, we used the Russian strain in the blow-on trial. We never had scars with the babies. The scar is like a surrogate marker for the immunity produced. So that happens more with the Danish strain.
You should stop using any other strain other than Danish for
exactly. So that's the national policy. Slowly, this RCT has changed the practice. It has changed the practice not only in our NICU, but the other NICUs are following in the country.
Yeah, it's a very good paper, well written, well methodology. Two clarification. One is we look at the tough part of it, sample size calculation. You kept it very stringent condition, 95% power, and it's a 0.0, unusually 0.01 level. But when it came to analysis, you diluted that. What is the reason for that? Because at 5% level, you analyze everything, and you move to survival analysis, where the other place, sample size calculation, is a comparison of proportion you use. Any specific reason for that?
Sir, the statistics is very elaborate. From what I understood, because the mortality rates keep changing between NICUs, so that way the randomization will continue. So that was the reason for keeping the mortality rate as 510, and based on which we kept on randomized.
Another point is the number with the Q3. It's probably you have to check it. It's a published paper. But in 21, you got it as, and lower limit is 10, confidence level, but upper limit is 200 something.
Yes.
And you have a large sample size and it's a large event rate.
Yes.
The number of events is, so I don't know. I'm really sort of wondering if it can be like that.
Yes.
Or any calculation. This thing.
Possible.
That's all.
So the number needed rate is the inverse of absolute risk reduction.
Yeah, but that's
So-
why the exponential inverse you take, that is because the right side is going to more than 200. Usually we expect for a small sample size or a small number of events.
Sure, so we'll reach it.
Yeah, few questions. Okay. I think this work is very good. Can you put that table where you have put that primary outcome? Yeah, this is the question, expansion of what just now was mentioned. The primary outcome, the first row, the result ratio is 0.69 to 0.98. So almost reaching 1, is it not?
Yes, sir.
So 0.98 rounding off comes to 1. 1 means no effect, no? Is it not?
I agree, sir. In fact, the results of this study have also been used with the meta-analysis of the earlier conducted universal studies. There also it is quite significant.
No, what I mean is that the wide variation in the confidence interval, and that's because it's not told the event rate of 510. It is a bit of a issue I was just speaking. Then in the fourth row, I didn't understand what does it mean that control censored when ECG OPV given less than 28 days? Because here the confidence interval is slightly with 0.93 little away from 1. That's why you got a p-value of 0.06.
So we stopped observing them after 28 days, but the event of death could have occurred subsequently. That's why the right censoring was done.
Okay, I'm still not clear, but it's okay. The other thing is you mentioned 2 times about stratified deep pool. So all patients were not in deep pool.
So there are 3 NACUs, sir. NACU of JIPMER, NACU of IOG, NACU of ICH. 3 large NACUs. That's why we are able to reach the
1, 2, 3.
Yes.
So that all the NACUs were equally presented on both sides. That's what it is.
Yes.
Okay, okay, thank you.
Thank you. We'll have to move on in the interest of time. So the next presentation is from Dr. Dinesh Kumar. He's talking about comprehensive observation of the morphology and the neurovascular pattern of the triangular fibrocartilage complex of the wrist joint.
Good evening, everyone. Good evening. So, considering the length of the session and considering the time point, and also the topic is little bit lighter compared to the topics which have been discussed. So, first I want to introduce the topic in a way that if we ask the student, let us take a first year MBBS student, what all the structures constitute the wrist joint? We expect them to answer us like this structure also will be included in the wrist joint along with the radius and ulna. But unfortunately, most of the students won't be able to recollect the name of triangular fibrocartilage complex. So this study is about observing the morphology and neurovascular pattern of the triangular fibrocartilage complex of the wrist joint. This is one of the underemphasized and understudied area related to the entire cadaveric anatomy and also the surgical anatomy of the ligaments and joints of the body. So with this introduction, we will be going on to where will be the exact location of this triangular fibrocartilage complex. Triangular fibrocartilage complex is a meniscoid-like structure. It is basically a fibrocartilage, but it is not only a fibrocartilage. It is a complex which has a fibrocartilage in the center and which is surrounded by 7 different architectural ligaments which are present around it. All the ligaments and the disc along with the meniscus homologue and also the sheath of a tendon, the extensor carpi ulnaris tendon, put together constitute a complex entity, and that complex entity is called as triangular fibrocartilage complex. Over the years, this area has been a not so well studied region because they didn't observe much of clinical significance or outcomes related to this area. But over time, the orthopedicians and also those who are involved in the sports injury related rehabilitation, they found out that there are two types of injuries which are happening related to the triangular fibrocartilage complex. One, acute traumatic based injuries, and second one is chronic degenerative injuries. So the acute traumatic injuries, mostly because of the undertreatment of this structure, it will progress to chronic degenerative conditions, and because of which majority of the patients who are having pathology related to the triangular fibrocartilage complex, they will present with perennial chronic wrist pain in the medial side of the wrist joint and medial side of the upper limb. So this particular complex or this particular like ligamentous complex will act like a load stabilizer, and it also acts as an important factor which transmits the weight on either side of the wrist joint. So we can see over here we have an area which is being dissected out, and after dissecting out we are finding a complex set of ligaments which are present around it, like ulnocapitate ligament, ulnotricutal ligament, meniscus femoral, and this subsheath and tendon of extensor carpi ulnaris also, and all these put together constitute the triangular fibrocartilage complex. Considering the underemphasis of this particular topic and also of the potential clinical utility of the topic in with respect to arthroscopic wrist surgeries, we plan to observe the morphology, neurovascular pattern, and also the relations of this particular triangular fibrocartilage complex. So, in short, this is a schematic representation of the area which is showing the articular disc or fibrocartilage with a set of 7 ligaments around it. And here we can observe a tendon, that is extensor carpi ulnaris tendon, the sheath of which also constitutes to this triangular fibrocartilage complex. And this entire area is going to be the area of our study, the area of interest of the present study. Over here, we can see that there is a branch also which is coming, that is the dorsal branch of anterior interosseous artery, and from here also the posterior branches are coming, which form the vascularity of a region. So, we want to further study the overall morphology, gross anatomical dimensions, neurovascular pattern, neuro separately, vascular separately, and also the relations of this particular triangular fibrocartilage complex. This is the plain objective of the study, and this is the process of dissecting out of triangular fibrocartilage complex. It is a bit difficult to dissect area because of the relatively narrower disposition, and also presence of like too much structures will be convoluting this particular area. But this is how the dissection has been done, and the area which has been marked with the star, this is the triangular fibrocartilage complex, and this is how the measurements are being taken in situ before the particular cartilage along with the ligaments are removed. So here, this is how the triangular fibrocartilage complex has been removed and the measurements has been taken, and this is the overall dissection part which is after the dorsal capsulotomy. And this is the process by which from the ulna, the xyloid process of the ulna, the TFCC has been dissected. So the samples were collected from 40 formalin embalmed cadavers. It is a convenience-based sampling. So all the dissected limbs which were available in our dissection hall, and also the cadavers which we were used for dissection, we tried to dissect out and remove this triangular fibrocartilage complex with the articular disc and the ligaments together. And the sample were placed in 10% neutral buffer formalin for fixation. This neutral buffer formalin is a routine conventional protocol which is followed for all surgical anatomy related procedures. After that, we have done a study in two parts. The present publication we have published only related to the neurovascular pattern. In another publication, we have published related to the morphology, relations, and other aspects of the morphology using special stain. But here we have done only two special stain. One is aramine chloride, which is a special stain used for visualizing the nerve fibers distribution pattern in the triangular fibrocartilage complex, and the immunohistochemistry staining for observing the vascular pattern of the triangular fibrocartilage complex. The results, basic descriptive statistical analysis has been done. And for visualizing the luminal area of the blood vessels, we used image J analysis for distribution pattern and also for the luminal area of blood vessels. This is from another paper where we did the publishing of the normal HND appearance of the triangular fibrocartilage complex. We can see the proximal end of the articular disc, and this is the epiligament which is having the vessels. As we all could be seeing, a routine HND stain won't give much detail about the neurovascular structure or the composition of the collagen and elastic fibers. So for observing the composition of the collagen and elastic fiber, we use another special stain, that is VVG, Verhoeven Van Giesen staining, which gives a comparative distribution pattern of the collagen and elastic fibers in the TFCC and also the other ligaments that are around it. And this is the aramine chloride staining, where we can see the distribution pattern of the nerve fiber. The nerve fiber tend to take a unique black color in the aramine chloride pomegranate silver staining, and whereby we can count the number of nerve fiber using image J, and we can document it over a period, over all the structures whichever we want to study. And here we have done the IHC of blood vessels. Here the nucleus is stained using TAPI. The endothelium is observed using VE cadherin primary antibody, and the tagged secondary antibody with C5 is being used. And after that, using the microscopy, the luminal area of blood vessels we can measure, and the distribution pattern also can be analyzed. So this is the composite numericals which have been published in our paper, but I want to focus for the want of time only on the two different aspects which gave a significant result in this. We can see over here that the articular disc, there is a distribution pattern in the difference between the proximal and distal part of the articular disc, and related to this dorsal radio-ulnar ligament, there is a significant distribution pattern. Apart from this, we can't observe any difference between the right and left side, and apart from that, the other areas and other ligaments also were more or less having a similar pattern of distribution. So to summarize, the articular disc has the least number of nerve fiber, but the periphery of the complex, which consisted of the different ligaments, other ligament, whichever has been discussed, showed higher nerve density comparatively. The vascular pattern was observed in various components, especially we can find out that the periphery of the articular disc has more vessels, and that is has a more propensity for healing after the injury, and it has to be used cautiously during surgery when compared to the central part of the disc. And higher vascularity and dense nerve fibers were observed in the proximal portion of the disc. So how this study can be used surgically? First, for surgical repairs. Peripheral repairs are highly viable due to the robust vascular networks. Central tears require debridement. Selective denervation can be done if we know the neurovascular pattern to relieve the patients of the perennial chronic rest pain, and the portal placement can be efficaciously done for arthroscopic wrist surgeries in such condition if we know the relationship of the other structures in and around the artery. So these are our references, and this is the publication which has been done in Archives of Bone and Joint Surgery. So thank you.
Thank you, Dr. Dinesh, for a wonderful presentation. One or two questions I have.
Yes, sir.
One is that you compared left and right.
Yes, sir.
Okay, and most of the values it's not significant.
Yes, sir.
Did you expect any difference there?
No, sir. As a part of a study, we did the comparison between left and right. But during the initial part of the protocol also, we didn't expect that much variations will happen between left and right, sir.
No, but are there any studies where there is a difference? Like why you have compared all your tables are practically comparison of left and right?
Left and right, and also between the different part of the ligaments which we have studied also. Basically, we want like proximal and distal only. But as a part of completion of the study, we did.
In the aids, why did you mention those aids? Any particular reason?
Which one, sir?
The aids, if you look there.
Yes, sir.
Okay, you have mentioned particularly the staining by these particular methods.
Yes, sir.
What is the rationale?
So because the stain, the aramine chloride, purposefully we have done for observing the nerve fibers, and the immunohistochemistry is for vessels. So for observing the neurovascular pattern, we have used these two differential staining patterns.
So the last question is, you already told the clinical implications.
Yes, sir.
So what you have found out, is it not documented earlier, like you said?
Yes, sir.
For the surgeons?
Yes, sir. So very less study. Actually, only one study is being done, like in abroad, related to the triangular fibrocartilage complex, and there also the observation of the blood vessels has been done. So our study, we have done the observation of the blood vessels.
What I meant from the academic textbooks.
No, sir. They just mentioned that the triangular fibrocartilage complex and these are the ligaments which constitute it. That much information is only available in the textbooks as of.
Thank you.
Oh, there are no other questions. Thank you, Dr. Dinesh.
Thank you, sir.
We'll move on to the next presentation by Dr. Ram Kumar on melatonin on sleep in Parkinson's disease, a randomized double-blind placebo controlled trial.
Good evening, everyone. Today I will be presenting my the published paper, Melatonin on Sleep in Parkinson's Disease, which has been published in the Sleep Medicine Journal. So actually, Parkinson's is the second most common neurodegenerative disease after Alzheimer's disease. And sleep problems are quite common. Up to 84% of the patients can be affected by sleep problems. And melatonin is a drug which is a neurohormone and has got a chronobiotic action. It means that it can enter in the circadian rhythm and play a role in the sleep-wake cycle and can promote the sleep promoting action. So what are my primary outcomes? My primary outcomes is the difference in the sleep quality, which is being judged by the Pittsburgh Sleep Quality Index, and the daytime somnolence is being assessed by the Epworth Sleepiness Scale. And we find out the difference between the melatonin and placebo in PD patients. And the secondary outcomes include varied parameters. We use the objective parameters because the primary parameters were basically the questionnaires. So for the secondary parameters, we use the objective parameters like PSG parameters like sleep. PSG means polysomnography, like sleep latency, REM sleep latency, and total sleep time, and varied others. Then others include PDQ-39, Parkinson's Disease Quality Life Index. Then non-motor symptoms scale, and UPDRS-3, which will look into the motor aspects of the Parkinson's disease. So the methodology is it is a randomized double-blind placebo-controlled study, and patients included our patients attend the neurology OPD, and after going through the ethics committee and after registering CTRI, we proceeded the study. So we included patients age greater than or equal to 30 years, and the patients met the criteria of the UK Brain Bank criteria, and for the inclusion criteria, basically use the patients who had sleep problems as shown by the PSQA index. This Pittsburgh Sleep Quality Index, it should be greater than 5. Greater than 5 is the cutoff. And exclusion criteria includes REM sleep behavioral disorders and atypical and drug-induced PDs. Then other conditions like schizophrenia, then varied disorders like bipolar disorder, then epilepsy, which will have a say on the sleep problem. So we excluded those things to prevent the bias. And then I also excluded patients who are currently using melatonin or amlodipine or similar others. And we also excluded patients who use beta blockers, which are brain permeable. Then steroids and antipsychotics also been excluded. And based upon our recommendation of the ethics committee, we excluded patients with severe insomnia, with insomnia severity index greater than or equal to 22. So methodology, we did the block randomization and it's of varying size, and the study allocation was done by the SNOS method, and the block size was not disclosed to us. So this is the overall mode of study. First, after we are getting the screening and demographic contents, we did the baseline sleep scores and polysomnography. The drug was given. In interim, we just analyzed, we made a telephone call regarding the adherence to drugs and toxicity. Then in the end, we once again did the PSG and then the sleep scores, and we saw about the toxicity also. So statistical analysis, the sample size of 82 was calculated based upon the 80% power. And it is based upon the previous study where there was a group difference of 3.82 and standard deviation of 0.62 and primary endpoint ESS as seen from the previous study. Actually, we calculated for both the primary outcomes, ESS and PSQI, but ESS had a higher sample size, so we used it for our study. And we made the analysis using the SPSS version 19. These are the results. So 107 patients were screened and 21 are excluded. After randomization, 43 into the placebo group and 43 into the melatonin group. And after last follow-up and non-compliance, the final analyzed were 35 in the melatonin group and 38 in the placebo group. So baseline characteristics with regard to everything was fairly equal. There was no major significant variations. And this is our main study results. As seen, the primary objectives are PSQA and Epworth Sleepiness Scale, and both came under statistically significant. The PSQA, that mean difference was 1.87, and the ESS was 1.25. Other secondary parameters like sleep latency, total sleep time, which is a PSG parameter, and NMSS, which is a scale based upon the non-motor symptoms, and PDQ-39, the life quality index in Parkinson's disease, everything came to be statistically significant. So this is a box plot comparing the PSQA ESS scores before and after the treatment in melatonin and placebo groups. As you can see, there is a difference in both, but the difference between the melatonin and placebo was statistically significant, and it was and adverse effects were also comparable, except drowsiness, others were comparable. So discussion, so melatonin significantly improved the primary outcome, that is the Pittsburgh Sleep Quality Index, the mean difference of 1.87, and it also improved the daytime sleepiness index of Epworth Sleepiness Scale, with the mean difference of 1.2 compared to placebo. And I like to say one thing, actually, the person cannot live or cannot make sense of the world if it doesn't have food or sleep. So sleep is so important, but when I reviewed in the literature, what I found is very appalling. Like literally there is no proper evidence. As you can see, even melatonin, there is only insufficient evidence and is possibly useful. There are no RCTs, only one RCT was done, and also a very small RCT with 18 patients. And literally most of them are open trial, and then other drugs also like rotigotine and then esopoclone, they are also only possibly useful evidence of that. No proper evidence. So this made me stimulate and do the study, and that's the reason for doing the study. So after the study, I have studied a significant step towards the evidence which is needed, which was felt in the Movement Disorder Society review update on the non-motor symptoms of PD. So conclusion, we found it is safe and effective except some drowsiness. The drug was very much tolerable and also got a statistically significant outcomes in our study. So, but one thing I want to say that even though it is statistically significant, it didn't actually achieve the minimal clinically significant difference. You see, PSQI, we had 1.87 as the outcome, that's difference. But if you see PSQI, the minimal clinical difference is 4. But we didn't achieve that, so mentioned in our shortcomings. And another thing is that what we wanted to do is in India, our patient profile is entirely different. As you can see, our patients are young, have short disease duration, and high use of anticholinergic drugs. And they have only modest equivalent levodopa dosage. But abroad, everything is the opposite. They are older and they also have a higher intake of levodopa and they don't have that much serotonin. So our study, this melatonin in our population, it's somewhat okay, but whether it will be useful in the other populations, it is doubtful. And the strength I would say on the study is that it is the first major RCT, no other RCTs has been done, and it's on an important topic. And we are, and ours reasonably less attrition rate, and the adverse effects also very less. Limitation may be a single center study, and as you can see, the patient profile is somewhat different from the Western population, so generalizability is less. So maybe multicentric studies can be done, and
Thank you, Dr. Ramkumar. What the deductions and others for questions?
Yeah, thank you, Dr. Ramkumar, the good work. Can you just put the table there, what you put the results in? Yeah, this one. Actually, you not put the numbers on the top. I was trying to search in the paper. You're supposed to put what number is.
Melatonin is 35 and placebo is 38.
No, but in the paper, only the number is there. Okay, you put it up.
Comes out diagram.
I didn't find in the paper. Okay, now can you put that thing back? Now, because I want to know whether this is ITT analysis or
this is protocol analysis. That's also
so when you see the attrition rate, you said it is less, but I thought it is more. You put that consorting. It's about 20%. You see then, see how many patients are, see the left side block, 8 people are not there out of 43. 35, 45 minus 35 is fairly, it's around 20%. So it's slightly higher patient rate. Now, I want to ask you these scales what you have used. Okay, the particular parameters to evaluate the outcome. Are they very objective or subjective?
Sir, actually, they are approved by the Movement Disorder Society, International Movement.
My question is, are they very objective or subjective?
Yeah, it is basically subjective, sir. But in sleep, the subjective component is more important than objective because those thing parameters don't match correctly. The subjective quality improvement in the patient's life, sleep is a very subjective one.
That's why you have that.
Yes, sir.
Okay, because I did not find maybe I missed it, but how did you do the double blinding? Because I was trying to see the methodology, I could not find any 2 lines or 3 lines. Exactly how you have done the double blinding?
Both the drugs were similar, sir, with similar strips, and it was not like we couldn't, we cannot make out like placebo or that. We did with the clinical pharmacology department.
Okay, that's all from me. Thank you. Yes, one small question. Sorry. It's a good paper, even though it's right. At the initial stage, you got the 3.8 or more of the score difference of the clinically involved. And finally, you got only 1.8. Isn't it? Even though it was.
That is for ESS, sir. Like for PHK, it was different. Actually, we used both.
I'm coming to my question. You said 1.8, so it gave the statistical significance. And you finally, I was waiting for that. You made a comment that that's a limitation of the study. Is it a limitation or a conclusion is different? You wanted to tell conclusion, yes,
no, sir, because
this intervention is not effective.
Actually, this intervention was statistically significant, but clinically, what is the PSQ index that is the thing, sir? It is like 4 must be the reduction to the patient to appreciate it in real life. But it got only 1.8, so they might not, they might not perceive so much. So, but anyway, it is a thing in the right direction. So that's the reason for we want to do a multicentric study, maybe because melatonin. The reason is that other drugs practically cannot use in Parkinson's disease, like around those class of drugs on benzodiazepines. Those you cannot use prolongedly. Melatonin is a neurohormone, which is a physiological hormone. It's generally secreted by the.
Whatever it is, but that is not a limitation. That's the point I'm driving. It's not a limitation of the drug. That is all right. Everything is all right. But
real world,
not giving what you expected.
Real world.
One question, Dr. Ramkumar, about the increasing the dose of melatonin.
No, we use the dose which is like dose which has been used in few studies, and 3 milligram is the middle ground, and some studies have used 2 milligram prolonged release, but 3 milligram is the middle ground dose, which is fairly standard dose of the drugs.
Okay, thank you, Dr.
Thank you.
The next presenter is Dr. Jawaharlal. Telemedicine for persons with epilepsy and mixed methods.
FPA for additional very good afternoon. I will take the floor. No more RCT. We are going to talk about the mixed method study. So thank you for the opportunity for allowing me to present the study on telemedicine for persons with epilepsy in India. This was to go on to the problem statement. Epilepsy is a fairly common chronic neurological disorder affecting anywhere between 1 to 2 per thousand population. And the treatment gap for epilepsy is very large, estimated to be between 50 and 90% in India. So telemedicine, with its ability to cut costs, reduce travel time, travel costs, improving the accessibility to quality care, is probably a bridge to help reduce this treatment gap. So we were thinking of all of these, and then the pandemic struck. All the traditional pathways by which we could offer care to these persons was lost, and telemedicine was adopted very widely, including in JIPMER, to provide continued care for these kind of patients. So we decided to exploit this natural experiment, and we wanted to look at what is the frequency, how much of telemedicine use among our persons with epilepsy, and to explore the determinants, satisfactions, facilitators, and barriers to telemedicine use from both persons with epilepsy, that is the PWE, and provider perspectives. So this is our study design. Ours is an explanatory sequential mixed method study with a larger quantitative component. For the quantitative component, we surveyed 770 persons with epilepsy. This was numbers were estimated to get an odds ratio, to estimate an odds ratio. Our previous studies showed that women were more likely to use telemedicine as compared to men. And so we used an odds ratio. In that study, we got an odds ratio of around 1.5. To estimate the similar odds ratio of gender differences, we estimated around 770 participants, persons with epilepsy will need to be surveyed. So how did we get these persons with epilepsy? We utilized the fact that we are a highly EMR dependent department. So all our patients who had between 2018 and 2020 who had at least 2 visits to our OPD department for the sake of epilepsy, we extracted their data by developing an algorithm. The link below or the reference below is a paper that we published regarding the accuracy of our algorithm, as well as the patterns that we noted using a time series analysis. So we identified these participants and we sequentially included them in our study with replacement in case they were not available or they were not willing to participate. For care providers, we use global sampling. Actually, we sent out requests to all the sister departments, neurology, neurosurgery, pediatrics, medicine, and psychiatry, who were all, we thought we would be involved in care of patients with epilepsy. We got about 49 responses from them. From among these people, we then purposively sampled. So this is the first level of integration that we did. We identified users and non-users of telemedicine as well as providers and non-providers of telemedicine. And then we conducted the qualitative part of our analysis. For the qualitative analysis, we conducted 5 FGDs. 3 included 6 participants each of telemedicine users. 1 included 6 participants of non-users. 1 focus group discussion, which included only healthcare providers. In addition, we conducted 11 interviews, and all this was done to data saturation. So what did we find? We found that out of 770 persons with epilepsy whom we surveyed, 386 had used telemedicine during the COVID pandemic. That is between the years of 2020 and 2022, when we were not offering any OPD services other than teleconsultations. On multivariate regression analysis, we found higher education, greater distance from the site, use of internet, self-ownership of mobile, lower income. They were all positive predictors of telemedicine use. Age and gender, contrary to what we were expecting, did not account for telemedicine use. Despite all that, this model only accounted for 14% of the variability in the telemedicine use. So we used standardized scores, which we had validated and previously used in our own settings for satisfaction. So on the right is the persons with epilepsy, and this is based on telemedicine satisfaction questionnaire. And the higher the scores, the better the satisfaction. As you can see, the problems were basically almost all of them required help to use telemedicine. And as far as physicians were concerned, this is the inverse. So lower scores are better scores. This is again a U optimum score. Again for telemedicine, it's again validated score. It was provided in English, whereas the TSQ was provided in the local language. And here again, the biggest problem for them was they were not satisfied with the quality of care that they were delivering using telemedicine. So what did we find as outcomes? Well, this is not really a very robust outcome because we were only looking at self-reported seizures of fewer than 1 per year. And this was significantly less among those who use telemedicine. But there are many drawbacks, like in the sense that we found that these were patients who are more often on monotherapy and things like that. So there's little to, it shows that there's probably some benefit, but we do not know what is the modicum of benefit. So the second level of integration was to combine these quantitative and qualitative findings. We used the joint display analysis. For the sake of time, I'm not presenting my joint display analysis, but essentially 5 themes came up. And these are our 5 themes. The first is the appropriate patient selection. So it is not only patient selection, but appropriate physician selection. It was noted by that about 1/3 of our participants, 1/3 of our providers did not provide telemedicine. And the reasons they said was that they did not have adequate training but opportunity. So that brings us to the second problem, where lack of awareness, and most of our patients did not seek telemedicine because they were not aware that such a facility was available. Communication gaps, again, these are both ways. Patients, what we found very context specific to India was that providers had a problem with language. So in a place like JIPMER, where our residents are from all over the place, our faculty are also from all over the place, this is, I think, a very unique problem and has not been discussed in telemedicine literature previously. As far as technology is concerned, there were problems. Almost all of the participants needed help to use the telemedicine interface. But this telemedicine interface that we provided in JIPMER was built in-house, and it is a proprietary thing. So now with eSanjeevani, maybe the platforms will be different, and maybe the ease of operation and the workflows will be different. So maybe the reach and the utility will also be different. As far as medications are concerned, we found that all our persons with epilepsy are very, very concerned about anti-epileptic medications, whereas the physicians were more concerned about communication gaps. They were worried that they were not getting across appropriately. They were worried about lack of alternative sources of non-verbal sources of communication, papers, old records, and things like that. So in a sense, the sense and limitation of our study is that our study had the largest number of persons with epilepsy, and we did use both users as well as non-users. We used a comprehensive methodology with both quant and qualitative components. However, because this was conducted immediate post-COVID, so there is a possibility of recall bias. And of course, because it is a mixed method study, there is contextual data in it. So in a conclusion, telemedicine reaches over half low-income epilepsy population in a public system, even when we did not provide much time for adjustment to the telemedicine. Digital literacy is emerging as a structural determinant of health. Adequate planning, especially with respect to training our providers for telemedicine and using appropriate technology is necessary to reduce inequities. That's it from me. Thank you. I would like to thank ICMR. This was funded by ICMR, my team, participants in the study, Dr. Mr. Anudeep, who helped us develop the algorithm. And
thank you, my resident also.
Yes, ma'am.
Anyway, nice presentation. I just wanted to know, was it a video call or it was just a audio call with patients?
What we were providing is predominantly audio calls. Most of this data was with respect to audio calls, although we were offering video calls. But the number of people who utilized the video calls was only about 30 in the entire 7
They may not have smartphones. And secondly, did you directly contact only the patients or even the attendants for this?
No, only patients gave answer.
Okay.
So we excluded participants who were not able to provide data.
Good study, Rajeshwari. Only one question I have is that you did it some time back, as you said, this study. Based on the experience of this study, if you have to do another new study, how the methodology will change?
Are you asking me how I would like to change the implementation of telemedicine, sir? Or how?
No. If you want to do, ask him to do another study on similar lines, based on the experience of this study, how will you change the methodology so that you can improve upon the study?
Okay. So what I would like to improve on this study, so that to make it more better. So what I would like to...
I'm saying this is not good.
I understand. Yes. So what I would like to do is basically the telemedicine satisfaction questionnaire that we use had certain wordings that were very wrong. Like the question was, I do not require help. So it was very difficult to understand. So these were all things that we did not pick up in the beginning, in the pilot, in this thing. But as we are utilizing it, we understood. So a more homegrown, more contextual telemedicine satisfaction questionnaire is what I would have liked to use. Second is, we cannot recreate the COVID pandemic. So I do not know how we will be able to institute this kind of telemedicine where we have no other choice and then follow up these patients. But given the possibility that I'm able to prospectively look at outcomes, I would like to look at hardcore outcomes. Means I would like to see what is the adherence rate of these participants. Did they benefit from the anti-seizure medications? Did they get seizure freedom from these anti-seizure medications? And there may be some other quality of life and other such indicators would also be something.
Can you overcome, you said that language problem was there, because we might not know the language. You said people come from different strata, different areas.
Providers had a problem, sir, yes.
So how will you overcome that with the present technology?
With the present technology, you could of course use AI, but then having an AI translator at every this thing and rechecking that may be difficult. But for most small interactions, because all of them identified at first encounters are not good encounters, it is only follow-up encounters. So maybe we could utilize AI to as an intermediary to provide information.
Just small, it's some part of the, it's a good consideration as well as a good paper, the complex control. But you said the sampling you have done with the replacement. What is that?
So what we did is we used our electronic health records, sir. So from 2016 onwards, we are tracking our patients on EMR only. All our OPD records are on EMR. So what we did is we developed an algorithm to identify our persons with epilepsy who were already in the database, who had at least 2 visits to our OPD. So they had a commitment to taking continued care in JIPMER department for epilepsy. So this had to be between 2018 and 2020. So these participants, we had a line list. And then we went down the line list to identify with replacement. If they were not available, if they were not traceable, or if they were not interested, then we went down to the list.
Okay, but actually, ideally, that is not with the replacement. If the replacement means the same subject, it's again put back and again take a random sample. Okay, that is okay. That is what. And second is, people thinking, I'm just asking, why you went for a modeling? Because it is basically you look at associates, isn't it? Then you try to put a model and then you have to tell at the end, sorry, my model is not good, answer is 40%. You could have avoided that.
So we just did univariate analysis and a lot of factors because numbers were 770. So a lot of them were triggered positive. So we wanted to see whether there is anything that retains its flavor. So that's why we did modeling.
Yeah, but you don't have to tell model.
Understood.
Thank you, Dr. Rajeshwari. On the presentation, we move on to the next presentation by Dr. Arpita on real-time detection of pre-malignant cervical lesion using AI model in multispectral imaging system.
So the paper is real-time detection of pre-malignant cervical lesions using artificial intelligence model for multispectral imaging system. Yes. The paper is published in European Journal of Obstetrics and Gynecology. It's a collaborative work with Engineering Institute, that is IIIT and JIPMER. Coming to the problem statement, we know that the global burden of cervical cancer is approximately 3 lakh women die of cervical cancer annually, making early accurate detection very much necessary. The challenge of early accurate detection is the high cost of cytology and HPV screening, lack of trained personnel, and via and standard colposcopy being highly subjective. So the key of the hour is cost effectiveness, point of care, AI-based screening, so that inter-clinician variability and the burden on the clinician comes down. So our objective was to eliminate this subjectivity by integrating the real-time artificial intelligence model into our system. So this multispectral imaging system, which we have named as Gynosite, is a project where we are trying to develop the probe. And we wanted to integrate this artificial intelligence as a byproduct along with the other features in the probe. So this is how the probe looks, and it shines 5 different lights, and it has an AI real-time based detection. So it's a study was conducted between February 2024 and December 2024. The data was collected as a convenient sampling. All females who underwent screening and was found positive were recruited, and they underwent colposcopy with normal colposcope, which we had, that is Lesigan, and the images were acquired and normal saline, 3% acetic acid and lugolcidine, which is a standard protocol. So we used around 600 data set, and we used 80% of them for training and 20% for testing. So this was a demography of the patient profile, and the data sets that were acquired, those images which were very clear and had no blood stains, when the cervix was clearly seen, only those images were acquired. Hence, there is discrepancy in the number of saline, acetic acid, or lugolcidine. And these data sets were augmented with a normal augmentation protocol. It might be like this thing turning, zooming, or cutting the images. So the flow of procedure was, we recruited the patient after the consent, and we proceeded with the colposcopy. The images were acquired, and image annotation was done. This was done by the clinician. The atypical blood vessels were marked, acetic acid areas were marked, and iodine negative areas were marked. Following annotation of the images, the data set were underwent preparation. And this was used for the training and testing of the model. And the two models that we used were YOLO V8 model and efficient net model. The performance matrix of these models, these are the engineering matrix, that is MAP 50, which is nothing but, you cannot say that if a area is detected as positive, or whichever area is detected, it cannot be said as true positive and true negative. It has to be matched with the clinician's area. So the matrix that we use is MAP 50 for that. So the precision is nothing but true positive predictive value. Recall is nothing but sensitivity. F1 score is a score which matches both precision and recall. It takes into account both the sensitivity and positive predictive value. Following which, we went in for the deployment. So we deployed in two phases. So the trained algorithm was deployed with the static images, and the trained algorithm was also deployed for the real-time images. So when we deployed to the static images using GUI, we were able to find out that the algorithm is detecting areas of lesion with a bounded area. This is how it looks. These are the images that are fed, and it detects the lesions. So this was compared with the clinician's marked lesions, which is usually recorded in the colposcopic register. The next step was real-time detection, that is deployment into our Pro. And here, whenever the camera is on and there is a capture of the frame, you need not press any image capture. Whenever you switch on the camera, it is capturing the image. Each frame is taken as one image, and it is processed. And if at all it detects any lesion, it is marked. If at all it has no lesion, it remains as a plain image. So this is how a real-time detection of iodine negative area happens. If you see in the start of this image, even the speculum is being marked as a positive area, and even the vulva, which was slightly white in color, was also marked as positive area. So what we did was next is segmented. We segmented the cervix and said the algorithm say, this is my area of interest, don't see anything else. Even if the speculum is there, don't mark it as astovite area. So when we proceeded with the segmentation of cervix and we proceeded with marking of the lesions, it was much more precise in terms of the acetic acid lesions being marked. So a nice geographical area of astovite areas and iodine negative areas were marked in real time. Coming to the results, the metrics, both in terms of engineering metrics and clinical metrics, was published. The F1 score was around 90% and MAP 50 was around 91, which has a good, which is relatively good. Clinical accuracy in terms of detection of lugolcidine was around 86%. Acetic acid, after we segmented the cervix, it improved from 57% to 85%. Coming to the validation, it is only the internal validation. The clinician's impression was taken into account. Of course, both the AI interpretation and clinician's impressions were compared with the standard, that is gold standard, that is the final biopsy. It was compared and acknowledged. So if we see the latest literature, most of the models which are there, which are lately published, use only white light. whereas we use multispectral images, so the data accuracy and the data representation is much higher. So we have seen that the accuracy being relatively better compared to the models which are there. Also, the models which are available, the AI architecture which has been in the literature, only use the static images, whereas our model is made only not only for the static but also for the real time. So that is the advantage that we have. Coming to the clinical implications, one is the state. Our main objective was to implement that into our probe, which relatively we are able to do now. And another translational success was use of this GUI. We can translate into low resource setting environments where if an image has been captured in the community setup, and if the person there in the community system is not able to understand which is the Astro-White area or Lugol-Sardin area, they can upload the image into the app and save. And it is not internet dependent. The limitation was it can overdiagnose the inflammatory lesions. Of course, the smaller sample size. And future scope is doing multi-institutional trials will do an external validation and improve the specificity of the lesion. I acknowledge NRF who have funded us in the Postgraduate.
Good one. My doubt is why did you take patients at 22 years of age? So we don't really screen any patient before 25. Is it on speculum you found something?
Actually, from 21 onwards.
Yeah, but the recommendation still is 25. 21, especially in our country.
Yes, ma'am. Yes, ma'am. But since the marriage age here is not ideally beyond 20.
Yeah,
so we see patients who are.
So that is one thing. And did you do speculum for all these before you did this? You started the study or directly did you put the scope?
We did the speculum.
Speculum. And another thing, what I wanted to know is you have kept the images. These are not the pre-fed images or
no, this is totally from JIPMER.
So how did you validate it? I mean, these are the images, and this is abnormal, this is normal. Or did you try to feed it in the one?
It was individually done by me, so that is the validation. That is the drawback also. Only one person or internal validation is done. It has to be externally validated. And one more validation was those areas which were biopsied were compared to the gold standard, that is biopsy.
Yeah, but not everything would have been biopsied. It's a big limitation.
Finding diagnostic accuracy, we are not able to biopsy because of the ethical issues, you cannot biopsy normal area.
Good work. This is the gold standard actually. That was my question, but then you showed the slide. So it was histopathology. Yes, what you said. Okay. You did not do any comparison with the existing methods that you utilized for this diagnosis. Conventional methods.
For the diagnosis.
For this comparative methods. And this is the new method, is it not? AI system what you're using for diagnosis.
You meant the algorithm?
No, whatever you're using it routinely without before this. Any comparison with that?
Routinely, what we use is visual inspection.
Glucoside, acetic acid, whatever you're using. So any comparison was done with the conventional method or?
Conventional method of doing colposcopy is using acetic acid and glucoside. Okay. The problem statement which I started was inter-observer variability in interpretation of colposcopic images. So which I say is pale white. Somebody will say it as dense white. So especially when the postgraduates are allowed to do the colposcopy, there will be unnecessary biopsies, which would be like a transient whiteness. They will pick as a dense white and biopsy. So in order to reduce that inter-observer variability, we added this component of real-time detection where an AI will assist to say, okay, this is the level of aceto whiteness.
But ultimately it is dependent on what you feed. So that becomes a limitation to the farm.
Yes, and the more rigorous you do, the better it is.
Okay.
Studying the use of multiple frequencies of to expect differential reflection behavior or we assume that the human tissue might reflect back certain frequencies going down from now. This is question number one.
So multispectral imaging is the main purpose of the group. Multispectral imaging rationale is the oxygen levels, the oxygen saturation levels are different in the dysplastic epithelium and a normal epithelium. So using multispectral imaging, we will be able to find out various ratios, green versus white, white versus green, green, yellow, green, red. These ratios of wavelengths images are used and we are able to map the oxygen saturation level. These mapped oxygen saturation level will actually tell you which is dysplastic epithelium without even using acetic acid and glucose. So the basic purpose is a label-free detection of dysplasia.
Second question, for this modern theory, in our internal computers, how we have exported somewhere, so how was the data previously handled?
The data was handled within the JIPMER. The staff who was hired was trained from the external expert, that is from the academy. It was handled within the
Thank you. The next presentation is by Dr. Kalerisi about the universal screening of newborns from JIPMER.
How does it know? Good evening, esteemed faculty members. I'll be presenting my paper on universal hearing screening of newborns from a tertiary care hospital in South India, a prospective analytical study. Hearing is fundamental to Hearing is fundamental to a child's development. Globally, 32 million children they present with debilitating hearing loss. This constitutes to about 5% of world population. In India, the impact is profound. 5 per 1 lakh population have congenital sensorineural hearing loss. And this adds to 18,000 new cases of congenital hearing loss every year. An early intervention by newborn hearing screening and rehabilitation can reduce this impact by 60%. There are two types of screening system, that is high-risk hearing screening and universal hearing screening. But high-risk hearing screening can catch us only 50% of congenital hearing loss newborns, whereas universal hearing screening ensures 100% coverage. The objectives of my study were to estimate the prevalence of hearing loss in neonates in tertiary healthcare center in South India using universal hearing screen program and to study the relationship between hearing status in newborn with various risk factors like maternal ototoxic drug intake, maternal torch infection, low birth weight, low APGAR score with hearing loss. A prospective analytical study was conducted over 2 years duration in the Department of ENT JIPMER. All newborns delivered in JIPMER or referred from outside for screening were included in the study. The sample size calculated was 3,679. Consecutive sampling technique was used. We followed two-tier screening protocol in which all newborns born in JIPMER were screened initially with transient evoked otoacoustic emission within 24 to 48 hours of birth. At the time of screening, a detailed history regarding presence of any risk factor for hearing loss, present or not, were also taken. The result of the test could be either pass or refer. Newborns who were referred underwent repeat transient evoked otoacoustic emission test at 6 weeks when they come for their vaccination after ear examination. Newborns who were referred, they underwent the gold standard confirmatory test, that is brainstem evoked response audiometry. So out of 3,679 screened newborns, we found that 1,253 newborns did not pass the first screening and they were referred for second TEOAE, in which 1,174 newborn infants underwent the test and 161 infants did not pass the test, and they were referred for the gold standard test, that's the BERA, and in that we found that 11 infants had congenital sensorineural hearing loss. So the prevalence of congenital sensorineural hearing loss in our study was 0.29%, and 95% confidence interval is ranging from 0.2 to 0.6%. On studying the presence of risk factors for hearing loss, we found that 37.2%, that is 1,370 newborns, they had risk factors for hearing loss. On studying the risk factors, we found that the most common risk factor was low Apgar score, which was seen in 897 newborns, followed by low birth weight, seen in 715 newborns. On studying the association between the risk factor and the congenital hearing loss, we found that there are 5 major risk factors. They are maternal torch infection, craniofacial anomalies, low birth weight, low Apgar score, and prolonged mechanical ventilatory support. On further studying this major risk factors with the hearing loss, after adjusting for the confounding factors, we found that the presence of maternal torch infection increases the risk, like 43 times higher risk of having congenital sensorineural hearing loss, and the presence of craniofacial anomaly has 53 times higher risk of having hearing loss, and the presence of prolonged mechanical ventilatory support has 114 times higher risk of having hearing loss. And coming to the discussion, the prevalence of hearing loss in our study was 0.29%, whereas in a reference study it is 0.6%. It's attributed to the difference in the sample size, and in the reference study they included only the high-risk newborns. And family history of hearing loss was insignificant in our study, whereas significant in other studies. It's because in our study only 18 newborns had family history of hearing loss, and this is a small number, and this in turn reinforces that universal hearing screening should be followed. And low Apgar score is significant in our study, also significant in other studies. Hyperbilirubinemia is insignificant in our study, whereas in other study it is significant. It's because of the difference in the sample size and the specific bilirubin threshold cutoff used for the high-risk infants. Low birth weight is significant in our study and also in the literature. It's attributed to the physiological immaturity of the auditory system. Craniofacial anomalies, maternal torch infection, and prolonged ventilatory support were significant risk factor in our study, also seen in the literature. In summary, the prevalence of congenital sensorineural hearing loss in our hospital is 0.29%, and always two-tier screening system is practical and robust, and neonates who fail in this referred for the confirmatory test. And major risk factors identified in our study were maternal torch infection, craniofacial abnormalities, prolonged mechanical ventilatory support are linked to the hearing impairment. And assumed risk factor screening is not universal, and always universal newborn screening must be mandatory even in the developing country. Thank you.
Thank you. My doubt is, you said maternal torch infections. Why did you, first of all, why were these mothers screened for torch, or did you screen after they had this hearing loss?
Ma'am, whether we took history of antenatal period, any fever with rash. So we, in the history wise only we took, ma'am.
No, but that doesn't mean it is torch infection. History with fever could be anything. So torch, unless because we just don't screen mothers for torch. They are very insignificant for me. So labeling torch as the reason for the toughness may not be correct unless you prove.
Okay.
See, one question I want to ask you, you only projected that in your family. It is not informative, is it not? Why you have not added anything to a part of the, you're going to find or something like that? If you look at the title, universal screening of newborns from special hospitals of India, it doesn't mean anything.
It's a hearing. We submitted in the otorhinolaryngology journal, so we assumed it's for a third person. That time only I realized it. So
I was wondering that something should be there.
Yes, sir.
So it's a very open title, and it can mean anything. You look at prospective analytical study. Now, Dr. Nair is here. I'm not very sure whether this is a typical prospective study, because it has already happened now. So
it should be cross-sectional reference, but it's a case control study because what you have done the analysis univariate and logistic multivariate analysis. It is already an event which happened. You compare between groups which do not have the problem and have the problem. If then you not accepted, it get published. You don't have to worry about that. But you can remember.
So we submitted it as cross-sectional. Then they suggested to modify it as prospective analytical study. So we have to change it.
So that's why you did it.
Yes, sir. Because in our protocol it is written as cross-section.
Cross-section. But it's not typically
Cross-sectional analytical.
But you've got two parts.
Yes, sir.
The prevalence, if you only take, then it is cross-section. But you have done most of the analysis for identifying the risk factor. That's the more important part of the study.
Secondary actually.
Just to find out what is the prevalence is not that important. More important is what are the factors that can lead to that, so that we can prevent that. Yes. Actually, well, enrollment is prospective, but otherwise the design is it's a cross-section, isn't it? Prospectively, you enroll the participants, but the design is the cross-sectional one. Okay. Now, we have two questions. One is the first part is prevalent.
Yes.
And in that sample size,
calculated for yes, sir.
Definitely, they must have commented about that because it's a very, very low prevalence.
Yes, sir.
So you use absolute precision or relative?
Absolute precision.
Oh, that's a problem. Because when it is a point something is the prevalent, so that if you use absolute precision, it will give you a lot of damage. The point one day. And second is prospective analysis. Do you think this study is very...
Sir, the confidence interval is wide.
No, the reason is very clear. You have only 11 cases.
Yes, sir.
Isn't it? You have more than 3,000, the other side, only 11 cases. After that, won't only go to that. If you look at it, you got it, respect you are talking. Everything based on number one or
yes, sir.
That I can call it as by chance it happened to be that. Probably respecting what we do, these are the type of situation where low prevalence is better to go for a case. That is a give a respect. Thank you.
Thank you.
Thank you, Dr. Kalayanthi. Just one question. Whether you looked at the drugs which were used like aminoglycosides and all, as well as factor?
Maternal IV injection of drugs we have taken, but none of them for aminoglycosides, vancomycin, these drugs we asked, ma'am. And we also try to look at the chart in the when the babies were bought for the screening, but none of them really had this maternal ototoxic drug intake.
Thank you. Thank you for the presentation. We'll move on to the last presentation by Dr. Divyajyoti Sahu on factors affecting volume and quality of umbilical cord length.
So here can see I can go. Perfect. It is working here. Yes. Good evening, all. So cord blood. So a lot of us are fascinated by the term umbilical cord blood. It has a lot of potential. Like it has a pool of stem cells. It has a pool of like future promise for the regenerative medicine for neurological conditions or like treating leukemia and lymphoma by transplant. So it has a lot of hope. So, but it is still a biological waste for years. It is considered as potential source of various diseases, resource. However, it is a still biological waste, and more than maybe 99.9% are being wasted every day. These umbilical cord blood are used for transplant and transfusion across the globe. A deciding factor is, in most of the cases, is the quantity. So if you see West versus East, whatever studies has been done, so quantity is very less in Indian studies, whatever has come. Along with that, collection method, many other factors may affect the volume of the cord blood. With that background, the literature search is very scant from India and across the Asias. So we went ahead to see what are the various factors which affect the cord blood volume and the quality. So this was a prospective observational study conducted in the Department of Transfusion Medicine with collaboration with OG department. The study period was September 2022 to June 2024. During the study period, healthy antenatal female who were going to be delivered were included. The ethical clearance was obtained from the institutional ethical committee. Sample size, the method used was sample size for estimating a single mean with absolute precision of 1 and 5% level of significance with the expected variation of cord blood volume around 40 ml. The estimated sample size was calculated with the help of Department of Statistics was found to be 65. All healthy women who came to be for delivery in JIPMER were included. However, we excluded all high-risk pregnant mothers having genital infections, genital diseases, anemia, prematurity, PROM, known genetic disorder, gestational diabetes, pregnancy-induced eclampsia. All these cases were excluded. Coming to the study procedure, the full-term delivery were only included. Consent was obtained from pregnant mother before the delivery. After the delivery of healthy baby, the cord was clamped, cut and digested. So we had two choices to go for in utero or ex utero. In both cases, like for example, in utero, the cord blood was collected before the delivery of the placenta. However, in ex utero, we took out the placenta. Further, after that only it was cleaned and further whatever possible blood was collected from it. So these are the figures. First one is the placenta, second one is ex utero, third one is in utero. So volume of the cord blood was the first criteria with how much we are collecting. So cord blood was collected till the blood flowed freely to the cord through a single peak. The volume of the cord blood was estimated by using the blood weighing device. Second, we are observing whether there is any clots. So it was done by visual checks, and further we went through the whole unit through a BT set to see whether any clots are there or not. So these are the figures which shows presence of clot here, and it was run through a BT set to see whether there is a free flow or whether this arrow shows the clot. Here also there is some clots in some cases. We have analyzed everything. So statistical analysis was done. First we saw whether there is normal distribution or not. The nominal and ordinal variables were and continuous data were observed as per the requirement, and everything was done under SPSS 26. Coming to the result, this is the demographic distribution. So mother age-wise, most of the age was from 20 to 30 years, while weight, most of them were more than 60 kg. Parity we saw. Baby weight following the delivery we saw, and also method of collection we observed in all cases. So first we saw the association between the presence of clot and mode of collection. So presence of clot and mode of collection, whether it is in utero, ex utero, and we saw ex utero is like in utero was far better than the ex utero mode of collection. Next was the association between the volume and the mode of collection, because when the volume increases, then the dose of the stem cells is expected to be more there. So it was observed that in utero, the volume is far better than ex utero method. Third thing, we saw the association of baby's birth weight with umbilical cord volume. So Pearson's correlation reveals a strong positive correlation. As the weight of the baby increases, the chances of collecting more and more umbilical cord blood volume was more. Further, we saw the association between the volume of the cord blood collected and the age of the mother. And the chi-square test reveals there is no significant association between volume and age group of the mother. Comparing the association between cord blood collected and the mother's weight. So here also chi-square test we put, and p-value shows 0.1812 indicates there is no association between volume of the umbilical cord blood and mother's weight. So next was the difference between umbilical cord blood with the gender. The analysis of the analysis showed us there is difference between male and female gender. Association between the volume of the cord blood and the parity of the mother, and the association shows with the increase in parity, the chances of volume collection is more. So coming to the discussion, the collected cord blood in the present study was around 70 ml. So this is almost same with the reported from the other places outside India. However, Bhattacharya et al. And Eliezer et al. They found the much less volume cord blood from India. So what may be the reason? Maybe we trained the person who was collecting the blood for 1 month before the study started, and she could find out the particular reasons why, what are the possibility of collection of less cord blood. So our volume was far better than other studies. The choice of ex utero and in utero also impacts the umbilical cord blood volume. In concordance with lot of studies, they have shown that ex utero they collect less in comparison to in utero. So a randomized control trial which recommended ex utero method to be inferior than in utero. So plenty of studies are there. So our study also demonstrated that in utero collection associated with fewer clots. 2 or more pricks if you go for, then chances of clots will increase. Also, there was a time delay between delivery of the placenta and phlebotomy that also reduces the total volume collection. So strength of the study, this one single person was doing the all collections, and he or she was trained before the starting of the study. However, the limitation says like RBC storage, RBC ATP, and reduced glutathione, all those things we could not include it in this present study. So to conclude, our study has shown that in utero collection has better volume and fewer clots than ex utero method. The parity of the mother, weight of the newborn, and the mode of collection have positive association with the volume. However, age, weight of the mother, and gender of the newborn and the time of clamping had no association with the volume. These are my references. I am thankful to JIPMER for this intramural funding and entire transfusion medicine department and OG department for their help. This was published in Asia and Journal of Transfusion Sciences. Thank you.
Yes, thank you. I have 2 questions. One thing is we always do a delayed corporate clamping. So that itself you would have lost so much of corporate.
Yes, ma'am.
And second, and we don't really do corporate clamping once the placenta is delivered. So that would have made a lot of difference.
Yes, madam. That all those cases we had less collection.
And
yeah, extension of this question, we don't see so many confounding factors, no? When you compare between the 2 groups. So how do you take care of those?
Sir, we want more volume. So this study has shown that ex in utero to be preferred. So once it is delayed, the time delayed, the quantity that we are going to receive or collect is less. So our study shows that we should go for in utero collection.
Thank you.
any other questions? Like no other questions. Yeah, thank you, Dr. Divya. I thank all the judges for their time and effort. Thank you all the participants also who are present here for such a long time. Thank you all. Thank you.
Thank you.
And really thanks to all the audience for in a long way, but still having the ability to thanks a lot to everybody. And volunteers, they have done a wonderful job. Our students from college are contributed the research as well as the volunteers. Thanks. Thank you very much, sir.
That's been a final note as we have come to the end of this long day. Heartfelt gratitude to all the presenters, moderators, the judges, and each and everyone for this intellectual exchange today and yesterday. Having the starters being served yesterday and today, we will have a great feast tomorrow, the 11th Research Day at the APP Abdul Kalam Auditorium, starting from 9 a.m. sharp tomorrow. So the Research Day audition will be presented by Dr. Alok Srivastava sir, and the keynote address by Chief Guest Dr. N.K. Arora sir. Followed by that, the announcement of the results of all the presentations of yesterday and today, and the award, the serious award will be presented, including the Faculty Research Award. So more exciting things are waiting to happen tomorrow. Stay tuned and we'll see you all tomorrow at 9 a.m. at 8:00. Thank you.